করতে পারলি না শেষ।
So, Dr. Lipika Adhikari, you are requested to start your speech.
Shall I start?
Yes, sir.
Good afternoon, respected. Hello.
Please go ahead, madam.
Yes,
Okay.
Please go ahead.
Good afternoon, respected chairperson and dear colleagues. At the outset, I must thank the organizing committee for inviting me as a speaker on the very important topic, that is treating high blood pressure in elderly. How is it different from young? Now, what do we mean by age? Is it a chronological age or it is a biological age? Look at these beautiful ladies of age 70 to 75 years and so robust and lively, whereas this gentleman of 65 years, very fragile and dependent. So over the course of 20th century, life expectancy increased around 10 years, and 75-year-old of today is 65-year-old in 1950s. ESC/ACH guideline defines old as more than 65 years and very old more than 80 years. ACC/AHA also same opinion, old is more than 65 years. So what happens in the elderly? The arterial wall stiffens and the reflected pulse wave reaches the aorta in systole, thereby amplifying the systolic pressure, widening the pulse pressure. Augmented aortic central pressure accelerates the development of ventricular hypertrophy, increases myocardial oxygen demand, accelerates the endothelial dysfunction and atherosclerosis. Rapid diastolic runoff compromises coronary perfusion and thereby predisposing subendothelial ischemia. So with aging, systolic blood pressure goes on rising and the diastolic blood pressure declines after 55 years. So there is a wide pulse pressure with increased augmentation index. So Sphygmocor is a commercial device available that uses brachial artery generalized transfer function, convert the radial waveforms measured by the applanation tonometry to a derived central aortic blood pressure waveform. Pulse tonometry provides two principal measures of aortic stiffness, that is the pulse wave velocity and the augmentation index. So what should we prefer? Manual blood pressure checkup, ambulatory BP monitoring, or it is an automated office blood pressure measurement? 2013 ESH and ESC guideline and the 2016 Canadian and Australian hypertension guideline place a far greater emphasis than US guideline do on home and ambulatory BP monitoring for clinical decision making. Based on the registry data from 11 countries, ambulatory and home BP monitoring should be routine in hypertensive elderly individuals. White coat hypertension and masked hypertension are so common in elderly patients, and the conventional office BP reading alone will promote either over treatment or under treatment of hypertension in 3 out of 4 patients. This is a beautiful picture from the Braunwald textbook. 24-hour ambulatory BP recording in a frail 70-year-old woman referred for evaluation of labile hypertension and dizziness. Red arrows shows repeated episodes of postprandial hypotension and 1 episode of orthostatic hypotension when patient walked to the bathroom 90 minutes after going to sleep. White coat reaction also seen when the patient comes to clinic. So superiority of ambulatory measurement as a measure of cardiovascular risk is also defined, that is 9 times hypertension shows 5-year risk of cardiovascular death more than that of the office BP measurement. So what is the definition of hypertension? It is almost unanimous. Conventional office BP more than 140/90. Unattended office automated BP measurement, it is 135/85. Ambulatory BP monitoring daytime, it is more than 135/85. Nighttime more than 120/70, and 124 or 48 hours average more than 130/80. Now, regarding the blood pressure threshold and goals of therapy, we are really perplexed by the multiple guidelines. So no one people are like, everyone has his own likes and dislikes. One man's meat may be the another man's poison. In GNC 7 and 8 guideline, they shows that whenever the age is more than 60 years, BP goal is less than 150/90, and age less than 60 years, BP goal is less than 140/90, irrespective of the atherosclerotic cardiovascular disease risk factors. But SPRINT trial subsequently shows that whenever there is an intensive treatment of hypertension to achieve a goal of 120 millimeter of mercury, it is cardiovascular death is less as compared to standard treatment. SPS-3 study also shows that ischemic stroke is less whenever there is a lower target group. So in comparison to JNC 8 stages, 2017 ACC-AHA guideline redefined pre-hypertension group into elevated and stage 1 hypertension. Elevated means systolic blood pressure 121 to 129 and diastolic blood pressure less than 80. So what to do with these patients? These patients, elevated blood pressure patients, requires non-pharmacological therapy. And for stage 1 hypertension, atherosclerotic cardiovascular disease 10-year risk has to be calculated, and when it is less than 10, non-pharmacological therapy has to be started. But when it is more than 10, start pharmacological therapy along with non-pharmacological therapy and reassess the patients at 1 month. Stage 2 hypertension, straight away go for non-pharmacological along with pharmacotherapy and reassess again at 1 month. So in treatment of hypertension in elderly, we have to have special attention to the elderly problems like dementia, depression, delirium, frequent falls, pressure ulcers, inappropriate prescribing of medicines, incontinence, iatrogenic problems, sleep disorders, osteoporosis, sensory alterations including hearing and visual impairment, immobility, and gait disturbances. Also, the elderly patients have more target organ damages and cerebrovascular disease, dementia, coronary artery disease, LVH, atrial fibrillation, aortic and peripheral vascular disease, chronic kidney disease, ophthalmological disorders, diabetes, etc. And also MAST hypertension as well as white coat hypertension are more in elderly patients. So MAST hypertension definitely associated with high CV risk, so they has to be treated with pharmacotherapy. Whereas white coat hypertension have global 10-year CV risk less than 7.5%. So here non-pharmacological therapy has to be started, but pharmacological therapy is deferred. What is pseudohypertension? Patients of elderly patients have sclerotic and calcified arteries. So when it has to be suspected, the persistent blood pressure elevation, no end organ damage, and symptoms of overtreatment. These patients may require appropriate measurement on blood pressure. Now, who are the patients high risk? For high risk patients, intensify the drug therapy if the average awake blood pressure is more than 130/80 and sleeping BP more than 115/65. And sprint inclusion criteria shows who are high risk patients having coronary artery disease, myocardial infarction, angina, low GFR, 10-year CV risk more than 10%, age more than 75, African ancestry, LVH, patient having LVH, diabetes, prior stroke, or prior heart failure admissions. Who are the difficult group of patients in the elderly group? Patients who require more than 4 drugs for treatment, during treatment having recurrent falls, diastolic blood pressure going down to below 65 years when targeting the systolic blood pressure. So answer here is we have to be satisfied with higher levels of BP control. And if you see the J curve, diastolic and systolic J curve, diastolic J curve is steeper than the systolic J curve. So whenever we are targeting systolic blood pressure, diastolic blood pressure go down, and that may precipitate acute kidney injury and even some patients having angina. So modified goal will be intensive therapy in robust patients aged 75 years or older. Start with low dose medication, intensify the regimen slowly, more frequent follow-up of office BP to avoid causing orthostatic hypotension, symptomatic post-exercise hypotension, acute kidney injury, and worsening of angina. So modified goal is for frail elderly patients, relax the goal of therapy, and that the standing systolic BP 135 millimeter of mercury or greater without orthostatic symptoms. Ambulatory monitoring is extremely helpful if available. Home BP of 150, sitting home BP of 155 millimeter of mercury may be an appropriate treatment for frail old patient with marked orthostatic and postprandial hypotension. Home seated BP of 130 millimeter of mercury may be okay for vigorously healthy 85-year-old women. Symptomatic orthostatic hypotension must be avoided, particularly when treating elderly patients with long-standing diabetes and developed autonomic neuropathy. What will be the antihypertensive of choice? Initial medication should be low-dose combination therapy, both for synergistic efficacy as well as minimize the dose-dependent side effects. In HIVET trial, perindopril indapamide used. In SPRINT, amlodipine azilsartan CTD used. But in JNC, they go for the high-grade dose of thiazides, but is shorter half-life, increases fluctuation of blood pressure, and high dose can result in hyponatremia, hypokalemia, hyperuricemia, and hyperglycemia. The evidence clearly support the use of long-acting indapamide and CTD over short-acting hydrochlorothiazide. For patients with hypertension, not controlled with amlodipine, telmisartan, irbesartan may be added along with indapamide. Vasodilating beta blockers like carvedilol and nebivolol may be the first-line therapy in hypertension with coronary artery disease and heart failure. So, real problem in elderly patients is postprandial and orthostatic hypotension. It really a challenging problem. It is really challenging. Useful strategies include frequent, small, low carbohydrate meals, caffeine with meals, liberalize the salt intake. If these non-drug related strategies prove insufficient, fludrocortisone can be added, but often causes worsening of the supine hypertension, which can be managed by elevation of the head end of the bed with 6-inch block with a head up tilt 30 degree, and low dose short-acting ARBs of losartan or losartan 25 or 50 milligram at bedtime. The evidence of insufficient evidence is insufficient regarding the recommendation of midodrine, the alpha-adrenergic agonist for orthostatic hypotension, whereas recent evidence indicates that abdominal compression garments and droxidopa are the most effective and safest approach to manage severe orthostatic hypotension. So what will be the take home? Look for biological age, patient's frailty. To start with, ambulatory BP monitoring is essential. Intensive therapy is better, but go slow. Specific attention for geriatric syndromes and side effects of the treatment. Do not rush for target. Treat to reduce the morbidity and mortality. Thank you, sir, for your patient hearing.
Thank you, Dr. Lipika Adhikari, for your excellent speech. Any question related to it will be dealt at the end of this session. Now I will request our senior Professor Ashok Kaur, Dr. Ashok Kaur, to conduct the rest of the session. Sir, Dr. Ashok Kaur. Sir, you have to unmute.
Dr. Ashok sir has sent a request to unmute. Yeah.
Yes, yes.
Please go ahead. Yeah.
Now, can you hear me?
Yes, sir.
Can you hear me? Okay.
Yes, sir.
Okay, okay.
Yes, sir. Please go ahead.
Now, our next speaker is Dr. Sumanto Chatterjee, and he's going to speak on coronary artery disease, diabetes mellitus, and management of hypertension. So, patients who are having hypertension with coronary artery disease and type 2 diabetes mellitus, and how you are going to manage effectively. Dr. Sumanto Chatterjee, please. Dr. Sumanto Chatterjee?
Yeah. Hello. Good morning, everybody. I am Dr. Sumanto Chatterjee. Today's topic, my topic is managing hypertension in coronary artery disease and in diabetes mellitus patient. Respected chairpersons and dear colleagues, you can see my presentations?
Yeah.
Go ahead.
Yeah, okay. So hypertension is a major contributor to cardiovascular mortality and morbidity worldwide and across India. Around 13% of the total of all annual deaths worldwide is due to hypertension, and its prevalence is around 30%. So it's a huge global disease. If we consider diabetes mellitus and hypertension, it's a deadly duo. Hypertension is twice common in patients of diabetes than patients without diabetes. Type 2 diabetes mellitus is 2.5 times more common in hypertensives, and this deadly duo can lead to heart failure, stroke, CKD, and coronary artery disease. Here we can see CV mortality rises exponentially in diabetic patients whenever his or her blood pressure is, from 120 to 200 escalates. And these putative mechanisms like atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling on top of obesity, dyslipidemia, insulin resistance, and genetic predispositions in this diabetes and hypertension can lead to macrovascular and microvascular disease, and the spiral cascades of cascade continues to impact your vascular system. So there are some special characteristics in hypertensive patients in diabetes mellitus. What are those? Number one is salt sensitivity of the hypertension and volume expansion or volume modification. ISH, non-dipping, microalbuminuria and macroalbuminuria, orthostatic hypertension and hypotension. These are the special characteristics we have to deal with whenever we are taking care of hypertension patients in diabetes mellitus. So we all know for the last couple of years, there confusion going on regarding the target and the treatment onset of and the ranges of hypertension. SSC, ESC, and ISH all differ in this regard. But we are today we are towards this 2018 ESC guidelines. So they are clearly saying that if the patient is suffering from hypertension and diabetes mellitus, you can start your treatment whenever anybody crosses 140/90. Target is 130 or lower if tolerated, but not below 120. This is the SBP. If the patient's age is 18 to 65, if age is 65 to 80, then target less than 140 to 130 if tolerated. Above 80, 140. Below just 140 if tolerated. Diastolic treatment in all the age group is below 80 but not below 70. This scheme holds true in CAD patients also. CAD suffering from hypertension, then also start your treatment in 140/90. Target is 130 or lower if tolerated. Diastolic range is also below 80 but not below 70. ESC guideline is saying that SBP less than 130 may be considered in patients particularly at high risk of cerebrovascular events, stroke. Regarding treatment and evaluation, lifestyle changes, that is weight loss, physical activity, alcohol restriction, smoking cessation, sodium restriction, increased consumption of fruits, vegetables, low-fat dairy products, these are highly recommended in patients with diabetes mellitus and pre-diabetes mellitus with hypertension. That is class 1 level A. RAS blockade, ACE inhibitors, and ARB are recommended in treatment of hypertension in patients with diabetes mellitus, particularly in presence of proteinuria or albuminuria, microalbuminuria, and target organ damage, namely LVH. In patients who are suffering from impaired fasting or IGT, RAS blockade should be preferred to a beta blocker or diuretic to reduce the risk of new onset diabetes mellitus. This is a class 2A indication. And of course, in diabetes mellitus patients, we should select our antihypertensive regime, anti-diabetic medicine regime, so that it is having a safe CV safety profile and it reduces its blood pressure. So SGLT2 inhibitors and GLP-1 analogs, these are the two molecules, pharmacological drugs where SBP, DBP, and mean blood pressure, whatever a minor amount may be, but it reduces SBP, DBP, and mean blood pressure. So we should seriously consider these SGLT2 inhibitors and GLP-1 analogs among the anti-diabetic basket in hypertensive diabetes patients. Home blood pressure self-monitoring should be considered and encouraged in patients with diabetes mellitus on antihypertensive treatment to check that their BP is appropriately controlled. It is class 2A. And 24 hours ABPM should also consider to have the compliance check. So it is a summary of various targets given by different societies for management of hypertension in diabetes. That is NICE, CHAP, WHO, IDF, JSH. These are all saying that target should be 130/80. IGH, ESC guidelines, ADA, JNC, ASH, SSCHA, they are all around. They differ, maybe 130, 140, 90, and 80, this kind of thing. And we see here this SPRINT trial probably after JNC 8 probably changed the guidelines. So this is a, ADA schematic diagram. How can we treat? It's one logical explanation. If the initial blood pressure is above 160, start with 2 agents. Otherwise, you can start with 1 agent along with your lifestyle management. If there is albuminuria, definitely you start with ACE inhibitors or ARB. Otherwise, you can start with ACE inhibitor, ARB, or CCB or diuretic from your basket. And in every level, you consider to check adverse effects. If any, then you can switch your basket from ACE, ARB, CCB, and diuretics. We know these things. To summarize, diabetes and hypertension, this is a deadly duo, but it is a treatable. Definitely, patient awareness generation or awareness promotion is utmost important. Addressing both the thing is very much important to promote vascular health by reducing microvascular complication and spiraling cascade. So now coming to hypertension and ischemic heart disease. So we know whatever ASCVD score you are calculating, definitely there is systolic blood pressure, diastolic blood pressure, and what on what treatment you are on. So it is a very important in CAT patients. So this is the CV mortality risk doubles with each 20 millimeter SBP increment. We can see from 115 to 175, there is a huge chunk of increment in CV mortality. So we have to be very much cautious in treating these cases. 10 millimeter reduction in systolic blood pressure reduces risk of major cardiovascular disease event by 20%, coronary heart disease by 17%, stroke by 27%, heart failure by 28%, and all-cause mortality by 13%. It's a huge data. So we can save millions of patients if we correctly choose our regime and goal in CAD plus and hypertension patients. So this is a mechanism of hypertension and ischemic heart disease interaction between the genetic, demographic, and environmental factors, physical forces and hemodynamic factors, endothelial dysfunction, calcium, oxidative stress, metabolic factors are there, which are incriminated to have this, initiate the spiraling cascade of microvascular disease and ultimately leading to ischemic heart disease. 2019 ESC guidelines is saying that it is recommended that office blood pressure is controlled to target values systolic blood pressure 120, 130 in general and 130, 140 in older patients aged more than 65. In hypertensive patients with a recent MI, beta blocker or RAS inhibitors are recommended. In patients with symptomatic angina, beta blocker and CCBs are recommended. You should not combine AC inhibitors and ARB. It's from on target. So this is a scheme. It's by ESC 2018 guidelines that you can start with one pill dual combination, that is ACE or ARB plus beta blocker or CCB, or CCB plus diuretic or beta blocker plus diuretic. This is the initial scheme of treatment. Consider monotherapy in low risk grade 1 hypertension or very frail patients or in more than 80 years. Next step 2 is a triple combination, and step 3 is it is a resistant hypertension. You can add spironolactone or other diuretic, alpha blocker and beta blocker. This is a schematic diagram where we can use this one pill strategy or two pill strategy to have your hypertension checked in coronary artery disease. So BP goal, do not go by these numbers because it is lifted from 2015 ACC/AHA, but it is saying that a lower target, a more stricter blood pressure control may be appropriate in some individuals with CAD, previous MI, stroke, TIA, or CAD risk equivalence, that is carotid artery disease, PAD, peripheral artery disease, abdominal aortic aneurysms. It is class 2B. This is for this I have highlighted this slide. CAD plus hypertension means 3 segments. Number 1, CAD, chronic stable angina, CCS plus hypertension, ACS, recent ACS plus hypertension, and heart failure, ischemic heart failure and hypertension. These are the 3 things we have to look for. So in CCS, chronic stable angina plus hypertension, definitely we should choose one antihypertensive agent which is having also anti-ischemic therapy, anti-ischemic potential, that is beta blocker and non-DHP calcium channel blocker. You can use it. After that, if it is not controlled your beta blocker or non-DHP calcium channel blocker, you can add ACC inhibitors and ARBs, specifically if the patient is suffering from diabetes mellitus, heart failure, LV dysfunction, CKD, albuminuria, LVH, this kind of thing, and definitely then diuretic if the patient is suffering from LV dysfunction and all those things. If the patient is having recent AMI plus ACS plus hypertension, then definitely AC inhibitor, ARB and beta blocker, this comes in forefront. In acute AMI, we know that if the patient is having high blood pressure, and patient is having ongoing chest pain, then there is a role for beta blocker. Short-acting beta-1 selective beta blocker without any intrinsic sympathomimetic activity. These are the things. Esmolol, bisoprolol, or metoprolol we can use, even IV also we can use. Within 24 hours, if the patient is not suffering from inferior MI or shock or something like that, SA inhibitors and beta blocker, usually we introduce maybe beta blocker first and then SA inhibitors within 24 hours or 48 hours. In discharge, we should include SA inhibitors, beta blockers in ACS patients suffering from hypertension. In heart failure ischemic origin, definitely we know that ARNI, SA inhibitor, ARB, beta blocker, specifically metoprolol, bisoprolol, or carvedilol, and MRA. These three things are having utmost importance because it is having survival benefit. ARNI is also, Vimata is also having antihypertensive property. We know it, and studies are coming up. So definitely, in any heart failure patient who is suffering from hypertension, definitely the ARNI, SA inhibitor, ARB, and then beta blocker. These three beta blockers should be our choice. So to summarize, hypertension in diabetes and ischemic heart disease is very much common, dangerous, but it is treatable. Patients with hypertension and diabetes are at increased risk of cardiovascular disease, ischemic heart disease. Risk assessment should be performed, whatever scoring system you are using. Patient awareness development is utmost important. BP goal is usually around 130/80, whatever guideline you are following. Lifestyle modification should be advocated at the first place, the first visit, for better control of blood pressure and other risk amendment. Early initiation of pharmacological therapy should be considered for better management, risk reduction, and slowing down the progression of the disease. Thank you.
Thank you, Sumanto.
Thank you.
I think the question and answer session will be at the end of this symposium.
Okay,
So our next speaker, yes, I will request Dr. Sukumar Ghosh to call the next speaker and introduce next speaker.
I'm audible?
Yes.
Am I audible? Okay.
Yes.
So thank you, Professor Kaur, to give me the scope to talk. And now the next speaker, without wasting a time, I call on the next speaker, Dr. Arindam Pandey. He will be talking on the hypertension patient with CKD and stroke patients. So Dr. Pandey is here.
Yes, sir. Am I audible?
Yes, you are
You
audible.
can start the process and you stick to the time actually.
I'll try my best, sir. Thank you very much for giving me the opportunity to deliver my talk in this wonderful gathering. So my talk is management of hypertension in stroke and chronic kidney disease. So I am given 12 minutes time, so I'll try to divide it into 6 minutes each. So as we all know, hypertension and chronic kidney disease, actually both can be responsible for one of them. So either long-term hypertension can lead to chronic kidney disease. Again, it is very common co-presentation to have hypertension in along with chronic kidney disease. So diabetes, hypertension, most common cause of CKD, and evidence suggests that progression of kidney failure can be delayed or prevented by proper control of this risk factor. But unfortunately, CKD often is overlooked. Many a time in our OPD, we do not give importance to a creatinine of 1.4, 1.5. Whether if we properly calculate the eGFR, many a time they will be categorized as stage 2, stage 3 CKD. So that is very important. It is not often picked up early. So factors which are actually contributing to hypertension in patients of CKD are actually there. It can be a sympathetic activation, so direct vasoconstriction or stimulation of renin release, imbalance between prostaglandin and kinin, so that also lead to vasoconstriction. There is some endothelin mediated mechanism, so direct vasoconstriction, renal injury, and many a time there is reduced nitric oxide production, which can give rise to loss of vasodilating property of the vasculature. So there is often increase in the salt retention, volume expansion, RAS activation, aldosterone sympathetic activity, and many things which are actually exacerbated in CKD patients. At the same time, some of the things actually can go down. So nitric oxide is one of them, kinin, and prostaglandin. So all these things actually, they give a complex pathophysiology to produce hypertension in CKD. So at one end, there is endothelial dysfunction, inflammation, oxidative stress, where, homeostasis of RAS and sympathetic activity many a time is lost, and there is accelerated atherosclerosis, which is many a time a common presentation in CKD patients. So the stiffness of the arterial wall also is high. And last but not the least, many a time the hypertension can be drug induced. So many of the CKD patients, they can undergo renal transplantation, and many of the immunosuppression, they are very much known to cause hypertension. So all these things we need to keep in mind whenever we are treating CKD patients. So this is a very simplified approach how we should manage hypertension in CKD. Basically, this is the approach provided by the Nephrological Society of India. So as per their advice, as per this flowchart, so 18 to 80 years, anybody who is suffering from CKD, if the blood pressure is not controlled, so goal target BP as a whole, they have mentioned it should be less than 130/80. So if it is not met, then we should start with ACE inhibitor, ARB, or calcium channel blocker. We need to monitor EGFR and potassium very closely, because if it goes up or EGFR comes down, then we many a time need to stop ACE inhibitor or ARB. And at the same time, there is also importance of lifestyle modification. And if the blood pressure is comes to target, then it's fine. If it doesn't come, then we need to reinforce the medication and lifestyle adherence. Adherence is very, very important. Many of the CKD patients, they are on multiple medication. So many a time they forget to take the antihypertensive. So it is very important to assure the adherence. And if the blood pressure is not controlled, we might need to consider adding another, called calcium channel blocker, diuretic, and beta blocker in some of the patients. So if with this strategy, the blood pressure is not controlled, as per the Nephrological Society of India, they are supposed to, the GPs and all physicians, they are supposed to refer the patient to the nephrologist. This is a very simplified and easily followed approach as per the Nephrological Society of India. Now, if we look at the major antihypertensive drug classes and their mechanism, which can be utilized in CKD patient, one end, there is centrally acting alpha agonist, which actually works in the central nervous system to stimulate alpha-2 receptor in brainstem. There is beta-adrenergic blocker. We all know it blocks the beta-2 receptor, and so cardiac contractility as well as heart rate is comes down. And most important class of medication, they actually works on the vasculature. So be it ACE inhibitor, ARB, and dihydropyridine calcium channel blocker, or a direct vasodilator, say for example hydralazine or minoxidil, they works directly on the vasculature. And their last class of the medicine is the diuretic. So there is thiazide diuretic, loop diuretic, as well as mineralocorticoid receptor. I'm not going to detail. So important adverse effect is become very important, because many of the adverse effect of the drug classes, they are not seen normally, but if there is concomitant CKD, it becomes more relevant. So ACE inhibitor, ARB, hyperkalemia becomes extremely relevant. So dihydropyridine calcium channel blocker, the peripheral edema can be more common in CKD patient. Similarly, thiazide diuretic or any other loop diuretic, the dyselectrolytemia can be aggravated in presence of CKD. Same thing is true about mineralocorticoid receptor antagonist and all other direct vasodilator and centrally acting. They can cause fatigue, bradycardia, especially if they are concomitantly being used with beta blockers. So we need to keep them on mind, the side effects. So as per the current, this is very easy to follow one of the protocol. As per this, they have divided the CKD patient. Someone is muting me. So as per them, either the CKD patient can be on hemodialysis or may not be on hemodialysis. So similarly, the choice of antihypertensive medication should also vary. So on patients who are not on dialysis, first line is definitely ACE inhibitor and ARB. So many a time we are afraid to give ACE inhibitor ARB in CKD patient, but we must not forget these are the agent which actually can retard the progression of CKD. It can improve the proteinuria. So first agent which should be considered in patients who are not on CK, not on dialysis, is actually ACE inhibitor or an ARB. Second agent is definitely a calcium channel blocker or diuretic. Third agent definitely will be diuretic and or the calcium channel blocker, which has not been used as a second agent. And fourth class has to be mineralocorticoid receptor antagonist. Now, we must understand this approach should differ if the patient is already on hemodialysis, because diuretics, they probably do not have any role as antihypertensive medication in patients who are on dialysis. So we cannot use diuretic, we cannot use mineralocorticoid receptor antagonist. So first line becomes beta blocker, second line is calcium channel inhibitor, third agent is actually ACE inhibitor or ARB. But we must be very, very careful about the monitoring of the potassium. And fourth agent is actually a direct vasodilator agent. So that is how the approach goes on. Now, types of kidney disease and BP goal. What should be the ideal BP goal? Most of the cases, whether it is proteinuric, diabetic, non-diabetic, kidney transplant, most of the cases the goal blood pressure as per the different guideline and recommendation body has to be systolic less than equal to 130 and diastolic less than equal to 80. Only exception is the elderly people with CKD. Here the systolic blood pressure goal is less than equal to 140 and diastolic less than equal to 90. So hypertension in chronic kidney disease, I have already mentioned this slide, so I'm not going to. So there is also equal importance of lifestyle measures such as weight reduction. Salt is very, very important. Exercise at least 30 minutes a day, 5 days a week. Alcohol moderation, smoking cessation, those are also equally important. And this is a last ESC guideline regarding the pharmacological treatment of hypertension and CKD. As per this, initially ACE inhibitor or ARB has to be given plus minus a calcium channel blocker, which is a one pill approach. Second step is to add a diuretic. Third step, if the patient is at resistant hypertension, we can think of spironolactone. So this is similar to the thing which I already shown. But yes, if the patient is on hemodialysis, we probably cannot give diuretic and mineralocorticoid receptor antagonist. So this was the first part of my presentation. Coming to the second part of my presentation, management of hypertension in stroke, which is also extremely important. Stroke, as we all know, most common cause of stroke is hypertension. It is very, very unlikely to get a stroke without hypertension. If we get that, we must evaluate the patient properly. There might be some rarer causes as well. So stroke is the second most common cause of mortality worldwide and third most common cause of disability. All of us know that. Hypertension is the most prevalent risk factor for stroke. It is the leading modifiable risk factor as well, and appropriate control of blood pressure is required to ensure good outcome in patients with stroke to prevent recurrence of the stroke as well. So this is one flowchart which says that stroke mortality rate in each decade of age versus usual blood pressure at the start of the year. So if we see, if the starting blood pressure is higher, the mortality and morbidity associated both systolic as well as diastolic blood pressure is also higher. So mechanism by which hypertension induces stroke, there are some postulation. There can be oxidative stress, there can be inflammation, there can be baroreflex dysfunction. All of them can lead to cerebrovascular morphological alteration as well as functional alteration, which leads to stroke. And this is true for both hemorrhagic as well as ischemic stroke. So blood pressure in acute stroke is extremely important. Many times there is controversy regarding this, how we should manage, what should be the ideal target. Now cerebral autoregulation, which closely controls the cerebral blood flow across a wide variety of systemic blood pressure, is altered in acute stroke setting. So generally, despite there being a number of large clinical trials and systemic review, there is no clear guide for BP following acute ischemic stroke, and guideline in this regard also varies. Different guideline gives different suggestion. There is evidence that BP should be lowered rapidly in patients with ischemic intracranial hemorrhage, but what should be the ideal approach in ischemic stroke, that is not actually clear. And there had been multiple trials which addressed this issue. Progress trial, one of the trials, showed that treatment to lower blood pressure in people to have had a stroke or TIA reduces the risk of further recurrence. And there has been trials with ACE inhibitor in HOPE study, Perindopil with Progress study, PROFESS study, utilized telmisartan. There has been ASCOT BPLA, which compared amlodipine with atenolol, which found amlodipine probably is a better molecule in stroke prevention. So if we consider and want to have a simplified approach, how blood pressure level in patients with stroke suggested by different guidelines, this is easier to follow flow chart. Here, as per this suggestion, primary prophylaxis, if we want to do a primary prophylaxis, patients with hypertension should be treated with antihypertensive drug to target blood pressure less than 140/90. There is no confusion regarding that. Now, in acute hemorrhagic stroke, in patients with a systolic blood pressure of 150 to 220, without contraindication to acute blood pressure treatment, acute lowering of blood pressure, systolic to less than 140 is actually safe. And in patients presenting with systolic blood pressure more than 220, it may be reasonable to consider aggressive reduction of blood pressure with continuous IV infusion and frequent blood pressure monitoring. Now, this is a simple approach, but if it is acute ischemic stroke, then it is not that easy. So if the acute ischemic patients with elevated blood pressure, now who are eligible for treatment with IV altiplate should have their blood pressure carefully lowered to a systolic blood pressure less than 185 and diastolic less than 110 before IV fibrinolytic therapy is initiated. That is extremely important. Otherwise, there will be chances of hemorrhagic transformation. In patients not treated with IV fibrinolytic therapy, for whom intra-arterial therapy is planned, it is reasonable to maintain the blood pressure less than 185 and 110 before the procedure. Now, if those things are not there, no intra-arterial procedure, no plan for thrombolysis, it is actually not clear whether I will take 1 minute. 1 minute more. Yeah. Okay. Yeah. So secondary prophylaxis. Now, secondary prophylaxis, TIA, we can reduce this blood pressure immediately. Now, long term, after around 7 to 10 days after the ischemic stroke, actually we should stick to the target of 140/80. So these are the things I have already gone through. NICE guideline is fine. So lifestyle. So I think I have covered most of the things. So we must understand. Age is very important determinant of the pathophysiology of the blood pressure. So less than 55, actually, it is a high renin blood pressure, and more than 55, it is salt sensitive, low renin blood pressure. So more than 55 age, we should try to use more diuretics and calcium channel blockers, and less than 55, we should try to use ACE inhibitor and ARB more. So that is a simple take home. With that, I'd like to finish. Thank you very much.
Thank you, Dr. Pandey. I think that our question session will be after finishing all the speakers' speech. So I request my co-chairperson, Dr. Sharma. Is he there? Hello, Dr. Ranjan Sharma. Dr. Sharma is present or not? May I request you to call the next speaker?
If he is not there, Professor Ghosh, you can call Dr. Avik Karab.
Professor Ghosh or moderators are also there, senior moderators.
Okay, which we can request the moderator, which
Sir, Dr. Sharma not available, sir. Not
Dr. Manoranjan Mandal, Dr. Debashish Ghosh.
Dr. Debashish Ghosh, are you there? As a moderator?
Dr. Manoranjan Mandal.
Dr. Mandal is present. Okay, I request Dr. Manoranjan Mandal.
Dr. Avik.
Yes, I am here, Dr. Manoranjan Mandal. May I request Dr. Avik Karab to deliver his talk, Management of Hypertension in High-Risk Patient with Managing Difficult to Control Hypertension. Dr. Karab, please deliver your talk without delay. Dr. Karab, are you here? I am seeing you have shared the screen. Your slides are visible, but you are not audible.
এটা ঠিক আছে, ওই যে তো রঞ্জন শর্মা আসেনি, দেবাশিস ঘোষ বললো আমি জয়েন করছি।
So let him start. Let Dr.
Dr. Karo, please start. Your audio, you have
It's not audible. You are not audible.
No, Avik is not audible.
হ্যাঁ এমনি ঠিক আছে, ওই যে আবার শোনা যাচ্ছে না।
Yeah, kindly change your headset.
Hello.
Dr. Avik, are you able to hear us? If you're able to hear us, put a thumbs up. You're able to hear us.
No, he is not able to hear.
He has an internet problem. His videos are also jerking.
So, can we go on to the next speaker and he will join after him?
Yes,
Okay,
yes,
okay.
yes. You can go ahead.
So, is Bishwarup Sarkar ready?
No, Vishwajit Mojumdar.
No, Bishwajit Mojumdar, he can't come. On his behalf, Dr. Bishwarup Sarkar will talk.
Okay.
Bishwarup Sarkar has joined.
Hypertension trials.
Yeah, he joined,
hypertension
sir.
trials.
Biswarup Sarkar joined, sir. Biswarup Sarkar
Let Bishwarup Sarkar start the talk, and by that time, Obi Karo get ready.
Hello. Hello. Hello.
We can hear you, Ashok sir. Dr. Ashok sir, we can hear you. Yeah.
Yes.
Yeah, please unmute Biswarup sir. Please kindly unmute yourself. I have sent a request also. Biswarup Sarkar sir, we can see you. We can see your PPT also. Kindly unmute.
Biswarup Sarkar is not audible.
Kindly
Because he's
unmute.
muted. Sir, kindly unmute yourself.
I have sent a request. Kindly accept the pop-up.
Dr. Sarkar, kindly unmute yourself.
Guide him, I don't know, probably.
Call him.
Not audible.
Sir, in bottom of your screen, bottom left side, you can see mic option.
You follow the screen in bottom and unmute yourself.
Yes, please go ahead.
Am I audible now?
Yeah,
Yes,
you are
ma'am.
audible.
Should I start?
Yes. Go ahead.
Good afternoon, everybody. Today we'll discuss some of the important terms in hypertension. And it is well established that hypertension is a major public health concern nowadays. And burden of hypertension is enormous, and it is expected to reach 1.6 billion by 2025. And expenditure associated with treatment of hypertension is also enormous. It is very surprising that only 50 years ago, hypertension was considered essential malady and not amenable to treatment. In late 50, there is introduction of thiazide diuretics, which paved the way for successful treatment of hypertension, and also some trials like VA Cooperative 1 and Cooperative 2 trials also conducted during 1964 and 1970. And these two trials first showed the beneficial effect of reduction of diastolic hypertension in terms of reduction in cardiovascular mortality and morbidity. And you all know that US President Franklin Roosevelt has a high blood pressure, and he died due to hemorrhagic hypertensive stroke. And at that time, hypertension was considered as a benign condition. So his death brought the potential of hypertension as a deadly malady into the limelight. After that, several landmark trials has been conducted, and now we have reached this stage. We have several guidelines and goal for hypertension treatment is all settled. Several combination of drugs, which drugs should be treated as a first line, all has been settled. And in different conditions like diabetes, CKD, and cardiovascular disease, which drugs should be used. And in different conditions like isolated systolic hypertension and resistant hypertension, what should be done is all well settled. Now, with this background, we discuss different important trials. And this is another important MRFI trial published in 1982 and included 12,666 population, and they are randomized to either intervention or control group. In intervention include dietary counseling, smoking counseling, and treatment of hypertension and lipid lowering. After duration of 7 years of follow-up, mortality in both of these groups is almost similar and total mortality is almost similar. Failure of this study is attributed due to hypocalcemia due to thyroid diuretics. This is systolic hypertension in elderly program. This is one of the important trial published in 1991, and before this era, isolated systolic hypertension was considered as a benign condition, and this is the first randomized trial so benefits of treating isolated systolic hypertension. Double-blind placebo-controlled trial included 4,700 population. They are either randomized to chlorthalidone with step-up of atenolol or reserpine or placebo. And after follow-up of 4.5 years, it has been concluded that in the incidence of MI, stroke, cardiovascular death, and death from other cause were reduced significantly in the treatment term. And this is trial with diet like DAS diet, though originated in 1990, published in 1997 in NEJM with low sodium, that it showed this dietary pattern can reduce systolic and diastolic blood pressure around 5 millimeter of mercury and 2 to 3 millimeter of mercury respectively. This is ASK trial, one of the important trial in Afro-American African population. It included around 1,000 people, 1,000 population, and they are randomized to either beta blocker, angiotensin converting enzyme, and calcium channel blocker to demonstrate the target BP and also prevent the progression of renal failure. After 5 years of the follow-up, it has been shown that angiotensin converting enzyme was more effective in slowing the decline of glomerular filtration rate, and it is significantly more effective than calcium channel blocker and also beta blocker. This is one of the landmark trial, ALHEART trial. This is the largest antihypertensive trial. It is double-blind randomized control trial. It included 42,000 population. They have been divided into 4 groups to receive either chlorthalidone or amlodipine or lisinopril or doxazosin respectively. Primary outcome was fetal cardiovascular death or non-fetal MI, and secondary outcome of composite of all-cause mortality, stroke, CSD, combined CV disease. And it has been concluded at the end that incidence of primary outcome was identical in chlorthalidone, amlodipine, and lisinopril group. Although secondary outcome was less common, particularly in chlorthalidone group. After this trial, this thiazide diuretic has been considered as a first-line therapy, particularly in JNC 8 guideline. This is Anglo-Canadian cardiac outcome trial. This is one of the important trial with BP blood pressure lowering arm, published in 2005, included 19,000 population. They are randomized to either amlodipine or angiotensin converting enzyme or versus atenolol thiazide combination. At the end of the trial, it has showed that the amlodipine angiotensin converting enzyme combination was superior to this beta blocker and thiazide combination in terms of cardiovascular outcome trial. This is high-weight trial. This is one of the hypertension in very elderly trial. This is the first trial showed beneficial effect of treating hypertension, particularly very elderly population, more than 80 years of age. They are either randomized to indamamide plus perindopril combination versus placebo. Study was stopped prematurely after a mean follow-up of 1.8 years due to positive result, and it has showed that trial was stopped early due to 21% reduction in all-cause mortality and 34% reduction in cardiovascular event, particularly in the treatment arm group. This is accomplished trial. This is another landmark trial published in 2008. It is double-blind randomized control trials. It included around 11,000 population. It compared the efficacy of amlodipine and angiotensin converting enzyme combination versus diuretic and angiotensin converting enzyme. After follow-up of 2.5 years, it showed that combination of amlodipine and angiotensin converting enzyme was superior to the combination of diuretic and angiotensin converting enzyme in terms of primary and secondary outcome. This is ACCORD trial. This included diabetic population, and they has been randomized to either intensive therapy where BP target is below 120 versus standard therapy where BP target is below 140. And after a follow-up of 4.7 years, primary outcome was similar in both of the groups. So it was concluded that compared to usual blood pressure control, intensive BP control in diabetic did not translate into significant outcome benefit. This is pre-dimet trial. This is particularly effect of Mediterranean diet on cardiovascular disease, and 3 arms are there: Mediterranean diet with olive oil, Mediterranean diet with nuts, and in the control groups there is low-fat diet. After a follow-up of 5 years, there is 30% reduction of heart disease and 52% reduction of development of diabetes. Reduction of heart disease is closely associated with the reduction of blood pressure as seen in the meta-analysis. This is on-target trial. This is the first trial that showed telmisartan is as effective as ramipril at reducing cardiovascular risk in patients with vascular heart disease and with better tolerability. Combination therapy does not reduce primary outcome compared to ramipril alone. Now come to the most important trial in our era. This is the SPRINT trial, systolic hypertension intervention trial. This was published in 2015. It is randomized control trial. It included 9,361 non-diabetic patients with high cardiovascular risk without prior stroke. They are randomized to either intensive blood pressure control group where BP goal is less than 120 and standard blood pressure control group where BP systolic blood pressure goal is less than 140. After 3.26 years of follow-up, primary outcome and was assessed. It is composite of MI, acute coronary syndrome, stroke, heart failure, or death from cardiovascular event. And it shows the significant benefit, particularly in terms of outcome. There was 25% reduction in cardiovascular event and 27% reduction in all-cause mortality in the intensive BP control group. There are certain criticism of the SPRINT trial. So diabetic patient are not included in this trial. Major proportion of overall cardiovascular benefit was due to reduced development of heart failure, and investigator was not totally blinded to the procedure. So there is increased use of diuretic, particularly in intensive treatment groups. So there is in heart failure. This cannot be applied to younger hypertensive with low risks. Apart from heart failure benefit, risk of MI or stroke is not reduced. BP measurement was different and by oscillometric method, and presence or absence of staph was not mandatory. There was increased incidence of serious effect in the intensive group. This ACCORD 2010, SPRINT 2015, and SPRINT in elderly age group in 2016, all these 3 trials compare the intensive BP lowering therapy versus standard BP lowering therapy. ACCORD failed to show any significant benefit, but SPRINT and SPRINT in elderly age group show significant benefit in the treatment arm, particularly in intensive group therapy. These are the trial with device and intervention. This is Simplicity Hypertension 1 and Simplicity Hypertension 2 trial. This shows that catheter-based renervation therapy is beneficial in hypertension reduction. And there is also another trial, Simplicity Hypertension 3 trial. This is the largest and first study to include SAM trial, but it failed to show any beneficial effect of renal denervation therapy in comparison to SAM control. This was Spiral Hypertension Op-Med trial published in 2020. It showed that catheter-based renal denervation therapy was beneficial in reduction of hypertension in comparison to SAM therapy in absence of antihypertensive medication. Radiance Hypertensive Solo trial also showed similar effect. Rio's pivotal trial that showed the beneficial effect of baroreceptor stimulation in terms of blood pressure control, but this trial failed to meet safety concern in this trial. So the trial, JNC8 was based on this important trial like ALHAT trial, ASK trial, and DAS trial. And 2008 TSC guideline was based on SPRINT, HOPE3, HIVET, On Target, ACCORD, ADVANCE, PATH, ASCOT, and PATH2 and ACCOMPLISH. Special mentioning of PATH2 trial, it is particularly in resistant hypertension when spironolactone was added beside other standard treatment, and it shows significant beneficial effect. So there are some other upcoming trials, that Spiral Hypertension, ONMED trial, ROX control trial, Fineron new MRA trial, and Daglutril other trial, and also vaccination. So in near future, this trial also modified our current guidelines. For the timing, we have to wait for this. Thank you.
Thanks to all the speakers. I think all the speakers has done a nice job. Can you hear me? Hello?
Yes.
Can you hear me? Hello?
Sir, can Ovik Karo connect once? Can we try with him once more?
Yes, yes.
Ashok sir,
he has been left out.
If he cannot connect, then we'll go to the discussion part.
So he's there? Dr. Ovik Karo is here?
Dr. Ovik.
Ovik?
he is there, sir, but his internet connection is very poor.
Okay. So I think...
So we can start the discussion.
I think we can start the discussion. Yes. In the meantime, if he comes, allow him to speak. Okay? Okay. Achha. Okay. Now, let us start with the first speaker, Dr. Professor Lipika Adhikari. Now, she has spoke about the role of management of hypertension in elderly people. Now, in elderly people, the problem is that particularly she has emphasized the SPRINT trial, because the SPRINT trial, you know that it involves mainly the patients, elderly patients with systolic hypertension. On a diastolic comment on diastolic blood pressure was not rather commented in the SPRINT trial. Now, the situation is that in elderly people above the age of 60. Yes, Lipika, can you hear me? Lipika?
Okay,
Hello? Lipika, can you hear me?
I can hear you, sir.
Okay. Now, elderly patients above the age of 60, and it is very difficult to control the systolic blood pressure.
Right.
So keeping the diastolic blood pressure 70 or above, or 65 or above, because you cannot bring down the diastolic blood pressure to 70, below 70 or below 65, otherwise it will reduce the coronary perfusion. And it is very difficult. Simultaneously, at the SPRINT trial, they have said that you have to bring down the systolic blood pressure if it is 130 or 120, prognosis is much better. So how we are going to, this contradictory situation, how we are going to justify, or how we are going to come to a term regarding the management of hypertension in elderly people, keeping in view the systolic blood pressure to be controlled below 160, diastolic blood pressure has to be kept about 70.
The dictum is, whenever we are considering the systolic blood pressure in the elderly patients, we have to respect also the diastolic blood pressure. But if I, like SPRINT trial, if I try to go up to 120 or below 120, then obviously the diastolic blood pressure also will go down, and that can precipitate acute kidney injury as well as the precipitate angina. So the thing is, in that case, in this case, whenever we are treating systolic blood pressure and the diastolic blood pressure simultaneously goes down, we have to have a target a bit higher. So that we have to respect the diastolic blood pressure also simultaneously. So we have to have a target a bit higher, up to that may be 130 or 140 like that, but we have to respect the diastolic blood pressure simultaneously.
Now next, Dr. Sumanto Chatterjee. He has talked on hypertension, coronary artery disease, and type 2 diabetes management. And these are the three things which are combined together in most of the time in our practice: hypertension, coronary artery disease, and diabetes mellitus. Now, according to after this DAPA heart failure trial, we are very much convinced that SGLT2 inhibitors should be used in patients who are having reduced, HFrEF patients with diabetes and hypertension or coronary artery, whatever it may be. But in patients who are having hypertension and diabetes mellitus and preserved ejection fraction, what will be your recommendations on using SGLT2 inhibitors? Sumanto, heart failure with preserved ejection fraction, hypertension, type 2 diabetes mellitus. Role of SGLT2 inhibitors. Yes. Hello. Hello. Hello.
Yes, sir. Yes, sir. We can hear you, sir. We can hear you.
So where is Sumanto? Sumanto is the...
No, sir. Sumanto not there, sir. Sumanto not.
Sumanto is not there. Okay. Okay. Then okay. I think then we will go to the next speaker, Dr. Arindam Pandey. He has talked on CKD, stroke, and hypertension. And in all these situations, it is better to control the blood pressure to 130/80 or even below that. I agree with his concluding remarks regarding the management of hypertension in this sort of situation. Now, then Vishwarup Sarkar, he has...
Sir, just a minute. Sir, excuse me.
Yes.
I had one comment to Dr. Arindam Pandey.
Yes, yes.
Regarding hypertension and stroke.
Yes.
In presence of a significant carotid artery stenosis, whether it is desirable to lower the blood pressure to the standard level?
130/80 or below.
Below.
If we are talking about acute stroke, so basically carotid artery stenosis, it will give rise to ischemic stroke. I'm thinking that it is not a hemorrhagic stroke. So in ischemic stroke, our guideline is very simple. If we are planning to do thrombolysis, fibrinolysis, then we need to reduce the blood pressure acutely. Or if we are planning to do some intra-arterial procedure, then also we need to reduce the blood pressure very acutely. Now, the carotid artery stenosis, if we are planning to, if it is very, very critical, and if we are planning to do some intervention on the carotid artery stenosis in presence of acute stroke, in those situations, we need to reduce the blood pressure very acutely. Otherwise, it may not be possible. In all other situations, there is no definitive trial which has given us the result which suggests that reducing blood pressure in ischemic stroke acutely, it helps. I am excluding the trials which has dealt with transient ischemic attack, because transient ischemic attack, we can reduce the blood pressure acutely, but in all other cases of ischemic stroke, where no such procedures or thrombolysis is planned, we are not supposed to reduce the blood pressure acutely. In fact, after some duration, we need to reduce the blood pressure.
No, the question was that specific problem that is in presence of significant carotid artery stenosis, where blood pressure below 115/75 may be deleterious and it may precipitate further ischemic stroke. Yes, I want a comment from you.
Yes, sir. Because I already told, if we are not planning not only carotid stenosis, in all other situations, we are not supposed to reduce the blood pressure. And I think you are talking about long-term chronic management. Long-term. This is one exception. Yes. If we are talking about long-term management, we have seen in most of the situation, it is always better to reduce the blood pressure less than 140 systolic and less than 90 diastolic. But probably this is one situation, because if we reduce the blood pressure further to very, very low level, then there might be hampered cerebral perfusion in presence of carotid stenosis. So this is one particular situation. Probably we should be little relaxed, even in chronic management.
Yes. So another question to you. We all recommend SC inhibitor and ARB in presence of CKD.
Yes.
But it is a double-edged sword.
Technical support ke phone করেছিস?
What is your recommendation regarding the
ওইখানেই তো দেখাচ্ছে ওই তো ইয়েতেই তো
we should not use or we should use?
Sir,
actually it is guided by the EGFR.
Yes, sir.
There is no specific guideline to which we will use it. Not use it.
Yes,
but overall we are recommended that in CKD you use SC and ARB.
Yes, sir.
But at one stage it will be a deleterious.
Yes, sir. So
which is that stage?
Yes, sir. I would like to divide the CKD patient into patients who are on dialysis and who are not on dialysis. So patients who are not on dialysis, ACE inhibitor and ARB is actually a first line therapy. Now, if someone who is on dialysis, ACE inhibitor ARB actually comes after beta blocker and calcium channel blocker. They are actually supposed to be given as a third line agent. Now, it is very, very important to understand, it is, as you mentioned, it is a dual-edged sword because it can sometimes give rise to very, very high level of hyperkalemia, which can be deleterious, or it can increase the creatinine to some extent, which actually can precipitate acute kidney injury. So it is very important initial part when we are prescribing this initial part, we should monitor potassium probably within 42 hours. If it is not possible, at least 72 hours. Then after 7 days. Now, if the patient tolerates, then we can actually be little relaxed. We can increase the frequency of monitoring of potassium and creatinine. Now, if there is 25% increase in the creatinine at any point of the time, we should straight away stop ACE inhibitor and ARB. At any level of hyperkalemia, we should stop ACE inhibitor and ARB.
Thank you.
Thanks. Harinam. Avik Karak is here. Avik Karak has joined.
Dr. Sumanta has joined.
Acha, Sumanta has joined. Acha, Sumanto, I had a question to you regarding management of hypertension, diabetes, and coronary artery disease. Now, you talked about just a role of SGLT2 inhibitors in the management of hypertension and diabetes mellitus. Now, what will be your opinion regarding hypertension, type 2 diabetes mellitus with heart failure, preserved ejection fraction, not reduced ejection fraction? Reduced ejection fraction, we know that consensus treatment for SGLT2 inhibitor is there. But what about the HEP, hypertension and type 2 diabetes mellitus? Role of SGLT2. Sumanto.
Dr. Sumanta has joined, but he is not responding.
Oh, he's not responding. Okay.
Dr. Sumanta is there in the group. He is there in the group.
No, Dr. Sumanta, you need to unmute yourself. Please unmute yourself, Dr. Sumanta.
I have sent a request to Dr. Sumanta.
Sir, basically, HEPF has not that much strong recommendation. Not any single molecule also doesn't succeed to get that much strong recommendation in HEPF. ARNI, SC inhibitor, ARB, aldactone, everything has been tried, but having not that much successful outcome. But definitely we can try ARNI and MRA and beta blocker in HEPF also, and we should look for the cause of HEPF. If it is due to atrial fibrillation, if it is due to diabetes, or if it is due to hypertension, then we should manage that thing specifically, particularly. But not any single agent has, that much strongly approved for HEPF till now, sir. We have to look forward for any strong study backup to come.
Okay. There is no data now.
Yes, sir. Not that much strong data now.
Thanks, yes. Thanks, Sumanto. Thanks.
Thank you, sir. Thank you, sir.
Okay. Now I have got one last question to Dr. Biswarup Sarkar. Biswarup is here? Biswarup?
Yes, sir.
Yes, you are here. Achha, you talked about the different trials starting from the very beginning from 1970 until 2020. The last trial you talked about the SPRINT trial and the ACCOMPLISH trial. Now, in the ACCOMPLISH trial, you have mentioned about the role of calcium channel blockers, ACE inhibitors. Now, that trial showed what you mentioned, that calcium channel blockers and ACE inhibitors combination is a quite effective or better in patients who are having systolic LV dysfunction. Is it true? How can it be? Because we know that calcium channel blockers either has got a neutral effect or deleterious effect in patients who are having systolic heart failure. Hello. Can you hear me?
Hello.
Hello. I think.
Yes, sir. Yes, sir. We can hear you, sir.
Hello.
So yes, Biswarup.
Last part I cannot get you, sir.
Now, what I am saying is combination of. I am repeating.
Yeah.
According to your accomplished style, combination of calcium channel blockers and AC inhibitors.
Yes.
In patients who are having hypertension with systolic LV dysfunction, they are a good choice.
Good choice.
But how can it be? Because we know that calcium channel blockers, either they are having neutral effect or deleterious effect in patients who are having systolic heart failure. So why not AC inhibitors and diuretics is a better choice than AC inhibitors or CCB?
Oh, it is a better choice, but in this trial it has been shown that the
how can it be? How you are going to reconcile the fact? What is your opinion about this statement that CCB plus AC inhibitors is a better choice in patients who are having hypertension, LV systolic dysfunction?
So this is basically contradictory, though. But the combination it's so.
The combination is very good. I agree that if the patient is not having LV systolic dysfunction, if it is a normal ejection fraction, it is a very good combination.
Very good combination.
As the investigators, Ashok,
yes.
As the investigators, why they did it?
So
you can't answer that.
Soumitra, you can answer.
No.
You can comment.
I can comment that when we are talking about calcium channel blockers, perhaps we are talking about the DHP type. We are not talking about diltiazem and verapam.
It is amlodipine.
The amlodipine is, as you said, is neutral. It's not deleterious.
Neutral
and as long as as long as pressure is nicely controlled, the afterload is controlled. So maybe it helps indirectly. I mean, it is not a comparison of ACE inhibitor diuretic versus ACE inhibitor amlodipine. So they are definitely ACE inhibitor diuretic would score higher in a heart failure situation. There is no doubt about it, Ashok. May I ask one question to Biswarup, Dr. Sarkar?
Yeah.
In ESC guideline, ACE inhibitor is RAS blockade is mandatory.
Yes.
In ACC guideline, RAS blockade is one of the first 3-line drugs.
Yes.
So why this difference? They have got the same data, same trial results with them, both the ACC people and ESC people. Is it because, I have got a theory, I have no confirmation about it, that as America has got a lot of Afro-Caribbean population who are low renin hypertension, where RAS blockade does not work so much. And they work with amlodipine and diuretic. That's why in a large population of America, RAS blockade cannot be the best choice. So instead of blindly following these guidelines, should we need to know what is the status of hypertension in Indians? Are we high renin hypertension or are we low renin hypertension? Is there any data?
Not data, but our studies or our science goes with the Afro-Caribbean, genetics. Afro-Caribbean genetics, so we'll be low renin hypertension.
Do you think so? But we are metabolic syndrome, and metabolic syndrome is usually associated with high renin state. Is there any study anywhere?
No.
Is there any study anywhere? Minalda, do you have any access to any study? What is the renin status of Indian hypertensives?
We have few studies regarding the plasma renin activity. And in the younger group of patients, there was a rise in the plasma renin activity amongst Indian patients also. But so far, your concern is concerned whether we should try more with the calcium channel blockers versus the AC inhibitor ARB group. That's not confirmed or not substantiated. But having said this, myself, yourself, and so many other people have been part of some consensus statement where we found that ARBs or for that matter AC, they fairly do good to our
very well. Yeah. So I suspect the majority of our hypertensives are on the high renin side, majority. But there is no proof. It will be a nice study if somebody does it somewhere. That's my suggestion.
But age should be important. After 55 years or something. Yeah, but after 55 years or something, it becomes low-renin sort of hypertension. So age should also be taken care of.
Okay. If I think I'll request my co-chairperson, Professor Sukumar Ghosh, to wind up the session.
It's very nice session. It's a very nice session. All presented, all the speakers have done justified to the speech, and every good discussions. And I'm happy with this program, Dr. Shah. Okay, if anybody has anything to say, or other co-chairperson, they can talk. Thank you. If anybody likes to say, other co-chairperson, they can make any comment. Otherwise, we can close this session.
Okay, thank you, everybody. So we are moving on to our next topic, that is heart failure. Hello.
Jayant, you are audible. You are audible.
Okay.
Just carry on.
Okay. So our chairpersons are Dr. Amol Kumar Khan, Dr. Pradyut Kumar Jha, Dr. Kajal Ganguly, Dr. Sunil Baron Rai, and Dr. Debobroto Roy. And our moderators are Dr. Supratik Kundu, Dr. Manoj Bhanja Chaudhary, Dr. Bapadutta Kumar, and Dr. Soumitra Rai. So let us start the session.
So speaker, so it's your person.
Dr. Khan, as a senior chairperson, would you please start the session? Dr. Khan, as a senior chairperson, would you please start the session?
জয়ন্ত
আমার কোনো এইটাই সেশন আমার কিছু রোল শোনার জন্য
বল
Jayant, may I request you to join as the chairperson and request the...
Hello.
Right, Dr. Khan is there. Dr. Khan, can you...
Am I audible?
Yeah, you are audible now.
Your voice is breaking.
Debobroto, am I audible?
Yeah, you are audible. You are audible.
So
Then we are going to start a very important session on heart failure. I think all the chairpersons are there.
Yeah.
That is Dr. Sunil Baron Roy and Professor Kajal Ganguly.
And Dr. T.K. Jha and myself. We are there. And I request
and
the
is there.
Yeah, and all the chairpersons to unmute themselves. Kindly unmute.
Should we start the session right now?
Yeah. Yeah.
Then as you know, that Jayanto has already told that we have 4 important speakers who will speak on different facets of managing heart failure.
Jayanto, mute karo tomar.
I think there are 5 speakers. There are 5 subjects.
There are 4 speakers. As per the notice, Oyon Kaur, Bhuvan Majhi, Pradeep Saha, and Subra Banerjee.
And Dilip Kumar, there is another page. Please turn over.
It has not been mentioned over here. It's all right, no problem. And everybody will get 12 minutes of time.
Yes.
And our first speaker is the youngest speaker, Oyon. Oyon will talk on heart failure, guideline directed management therapy. And that is the basic of managing heart failure. And I think Oyon will cover up this subject very good. And moderator is there, Supratik Kundu, Manoj Bhanja Chaudhary, Bapadutta Kumar, and yourself, Soumitra is there. I am seeing only Soumitra's face.
So I'm here, sir.
So Oyon, let's start. Oyon, are you ready for starting?
Oyon আছো? Oyon, তুমি আছো? Otherwise, if you are not ready, we can go to the second speaker and till Ayan becomes ready.
Dr. Ayan Kar has not yet joined. Please go to the next speaker.
Yeah, Bhuvan is ready.
Yeah.
Bhuvan is ready.
Yes, I am ready.
Bhuvan, please start.
Okay, then
Please
Bhuvan
start.
start.
Bhuvan.
Yeah.
I think you are going to discuss about FF.
Yes, yes.
That is preserved ejection fraction, most difficult part of the managing heart failure patients.
Yes, sir.
Okay, go on, start your deliberations.
So, sir, my topic is management of heart failure with preserved ejection fraction. We all know the definition of heart failure. The definition of heart failure and classification of heart failure by European Society of Cardiology has been into HFrEF. Heart failure with
Hello? Dr. Ayan Kar is not answering my call.
So the signs and symptoms of heart failure has to be there, along with if the left ventricular ejection fraction is more than equal to 50%, then it is known as HFpEF. And along with that, there may be elevated levels of natriuretic peptides, and at least one additional criterion like relevant structural heart disease, either left ventricular hypertrophy or LA enlargement, or the parameters of diastolic dysfunction may be there. It is not moving. Next slide.
Kindly click on your slide and move, sir.
Yes. So the scheme for diagnosis of heart failure with preserved ejection fraction has signs and symptoms of heart failure has to be there. Left ventricular ejection fraction should be more than equal to 50% without LV dilatation, and different parameters of LV diastolic dysfunction along with the elevation of cardiac biomarkers may or may not be there. So what are the pathophysiological contributors of heart failure with preserved ejection fraction? There are multitude of factors like longitudinal systolic dysfunction, chronotropic incompetency, autonomic dysfunction, endothelial dysfunction, pulmonary hypertension and RV failure, abnormal VA coupling, skeletal muscle abnormalities, inflammation, arterial stiffness, and other extracardiac causes of volume overload, and diastolic dysfunction obviously. So the presentation of HFpEF are three types. So the factors that are responsible: environmental and diet, along with comorbidities and genetic susceptibility, lead to a vulnerable heart in a vulnerable patient that leads to heart failure with preserved ejection fraction. So it starts initially from exercise-induced increased LA pressure, followed by volume overload, and ultimately up to pulmonary hypertension leading to RV failure. Now come to the management. So the earliest studies we know is PEF-CHF study. It was done in 53 European centers with a mean follow-up of 26.2 months. The patients with more than 40% ejection fractions were taken. About 152 patients were enrolled. So ultimate results were seen that at 1 year, it reduced composite outcome of death and heart failure related hospitalization. But when they were followed up to 3 years, it was not significant. In the IPRESERVE trial, irbesartan was studied in 4,128 patients with more than 45% ejection fraction. In this trial, the rate of hospitalization was also same. So there was no difference between irbesartan and placebo as compared to in the primary outcome as well as secondary outcome events. In the CHAMP PRESERVE trial, candesartan was studied in patients with more than 40% LVEF. Around 3,000 patients were studied and followed up for a median period of 37.7 months. In candesartan, we could see that the adjusted hazard ratio was 0.86 with a p-value of 0.051 in terms of heart failure hospitalization. In no other primary or secondary outcomes, it was significant. So it was not significant in any other primary or secondary outcome events. The absolute risk reduction was in hospitalization for heart failure, it was around 2.37%. And the composite of cardiovascular death and hospital admission, it was around 2.26%. VALID trial showed the role of supporting antihypertensive treatment. It showed the lowering blood pressure, improved diastolic function, irrespective of the type of antihypertensive agent used. Now, optimized heart failure registry, it was about beta blockers. In systolic heart failure, where the curve diverges, in diastolic heart failure, there is no significant role of beta blocker in terms of any of the outcomes. Senior trials was about nebivolol, around 2,100 patients were studied. And we can see that none of the diastolic parameters were significantly improved with the use of nebivolol. Now, LDO CHF trial, here the aldosterone and antagonist spironolactone was used, and echo evidence of diastolic dysfunction was there. It was seen that E by E prime, medial E by E prime value was reduced at 6 months and 1 year with spironolactone. However, peak VO2 was not significantly improved. In the TOPCAT trial, again spironolactone was used in patients with left ventricular ejection fraction more than 45%. And here the only outcome that was significant was the hospitalization for heart failure. The hospitalization for heart failure was significantly improved with spironolactone compared to the placebo. Now, RAM-PAP was in this trial, eplerenone was studied, exercise capacity was improved, markers of collagen turnover also decreased, and diastolic function was improved. However, in the DIG-PFA trial, digoxin didn't show any benefit, as well as sildenafil in the RELAX trial didn't show any benefit. Now come to the neprilysin inhibition, the Paramount trial. In this trial, the sacubitril valsartan was tried against valsartan alone. However, the primary objective was anti-proBNP reduction rather than any outcome events. And the secondary objective was echocardiographic measures of diastolic function, left atrial size, left ventricular size and function, etc. It was shown that anti-proBNP was reduced with LCZ 696 compared to valsartan. And also the left atrial volume and left atrial width was improved. However, the diastolic parameters like E by E prime value and lateral E prime was not improved. So the in management of diastolic hypertension, the role of ivabradine, it was seen that compared to placebo, ivabradine significantly worsened the changes in peak VO2 in the diastolic heart failure cohort and significantly reduced submaximal exercise capacity, as determined the oxygen uptake efficiency slope. So the large trials in heart failure with preserved ejection fraction like type reserve, PEP-CHF, CHAMP reserve, SINEAS and DIG, it didn't show any benefit. Now, other trials also, when you see that basically the primary outcome was it was not significant. Some of the trials like Champion trials reduced heart failure hospitalization. Some improved the anti-proBNP level. Some improved the pulmonary hemodynamics like that of sildenafil. However, most of the other trials like nebivolol, carvedilol, eplerenone, and sildenafil, these trials are negative or at best neutral. Now, what are the non-pharmacological interventions? Lifestyle modifications are recommended to reduce the risk of all forms of cardiovascular disease. Measures include weight loss, smoking cessation, dietary changes, and exercise. Identification and treatment of comorbid conditions such as high blood pressure, diabetes, and hypercholesterolemia are important in reducing the risk of subsequent heart failure. So, for systolic heart failure, there are lots of therapies from NOIH1, NOIH2 through NOIH4 like ACE inhibitor, angiotensin receptor blockers, beta blocker, MR antagonist, digitalis, and diuretics. And for diastolic heart failure, all are question marks. Probably some role of diuretics is there. So what is the therapeutic approach to diastolic heart failure? First, we have to treat the volume overload with diuretics and mineralocorticoid receptor antagonists. However, we have to avoid what diuresis? About diet, it should be low salt and heart-healthy diet. Hypertension should be treated aggressively with diuretics, ACE inhibition, angiotensin receptor blockers, and hydrolyzine isosorbide dinitrate. Exercise training, aerobic capacity, and more than 30-minute exercise, at least for 3 days per week. Heart rate control with beta-blocking agent, diltiazem and verapamil, and sometimes with ivabradine if heart rate is not controlled below 70. Additional treatment to consider statins and sildenafil in case of pulmonary hypertension, and weight loss treatment if BMI more than 30. So matchmaking for optimizing heart failure, in the most left-hand side, we have to reduce the heart rate with ivabradine. We have to reduce left atrial pressure with intra-atrial shunt device, exercise training, inorganic nitrates. When there is volume overload, aldosterone blocker, neprilysin inhibitors, and at the extreme end, when there is pulmonary hypertension from PDE5 inhibitor to SGC stimulator and hemodynamic sensors, etc. So now with heart failure and preserved ejection fraction, the management has shifted to sensors, seizures, gaspers, slitters, cutters, and drillers. These are entering into the management of heart failure with preserved ejection fraction. CardioMEMS heart failure system is a system for pulmonary pressure monitoring in heart failure patients and has been approved by FDA. It is placed in the right pulmonary artery which monitors the pulmonary artery pressure. Now the interarterial shunt device for heart failure with preserved ejection fraction, there is creation of left to right shunt which decrease the LA pressure at rest as well as exercise, and that decreases the symptoms of heart failure with preserved ejection fraction. These are known as atrial flow regulators and other devices. The transcatheter implantation are carried out to create a small permanent interarterial shunt with QP by QS ratio of 1.2 to 1.3. So the reduced LFP heart failure trial is going on with these devices. This is to evaluate the safety and performance of the interarterial septal defect system in the treatment of heart failure patient with elevated left atrial pressure despite appropriate medical treatment. And we all know that pericardium accounts for 40% of the left ventricular end-diastolic pressure. And in cases of heart failure with preserved ejection fraction, the curves pressure-volume relationship has been shifted to the left. And so we have to reduce the left ventricular end-diastolic pressure. And there are pericardiectomy devices which increases diastolic compliance, increases cardiac output, and decreases the morbidity. However, decreases the morbidity. However, there are morbidity with surgery also. Methods are 3 novel devices like pericardial seizures, Gaspers and Slitters. There are percutaneous epicardial access devices which are deployed over the wire. These are the pericardial Slitters. So ultimately, we have to come to the recommendation for treatment of heart failure with preserved ejection fraction. This is quite old. No new guidelines has come out. It is about of 2013. So systolic and diastolic blood pressure should be controlled according to published clinical practice guidelines. Diuretics should be used for relief of symptoms due to volume overload. Coronary revascularization for patients with coronary artery disease in whom angina or demonstrable myocardial ischemia is present despite guideline-directed medical therapy. Management of atrial fibrillation according to published clinical practice guidelines for heart failure with preserved ejection fraction to improve symptomatic heart failure, class 2A recommendation, and use of beta-blocking agents, ACE inhibitor, and ARBs for hypertension in heart failure with preserved ejection fraction. It also is a class 2A recommendation. ARBs might be considered to decrease hospitalization for heart failure with preserved ejection fraction as a class 2B indication, and nutritional supplementation is not recommended. There is no benefit. So the take-home message is non-cardiovascular causes like COPD, CKD, diabetes mellitus must be identified early and aggressively treated. Patients with obesity, hypertension, and atrial fibrillation require weight reduction and exercise programs to aggressively control BP and heart rate. Volume overload should be treated with diuretics. Pharmacological therapy trials with beta blocker, calcium channel blocker, ACE inhibitors, ARBs, and nitrates have in general been neutral in decreasing patient mortality. Medical treatment based on pulmonary artery pressure monitoring with a permanently implanted right pulmonary artery microsensor significantly reduces hospitalizations in treatment of heart failure. A clinical trial is currently examining the effects on patients' mortality from heart failure. If significant coronary artery disease is present and contributes to heart failure, the patient with HFpEF should be evaluated for coronary revascularization. So thank you for patient hearing.
Thank you, Bhuvan. Excellent lecture. Excellent lecture. So, shall we take up the questions at the last, Jayanto? Jayanto?
Debabrata, I think the standard procedure here in these sessions are that questions will be at the end. Otherwise, it's difficult to manage time.
So I request Dr. Ayankar to start his deliberation. So Ayankar, please.
Thank you, sir. I'm really sorry for the delay. I don't have permissions to share my screen. Can you please?
Permission given, sir. Please go ahead. Please go ahead.
You are the co-host now. Please share your screen.
Right, sir. Thank you. Okay. So I've been given a little difficult topic. It's rather than difficult, it's a very broad topic and covers many ages. And as Dr. Bhuvan Vaje has already said, the host of options for treatment in heart failure with reduced ejection fraction is definitely much more than compared to preserved ejection fraction. So we'll come to the problem at hand. Reason why we talk so much about heart failure is because it is one of the largest global health problems that we are currently facing, especially with aging populations and with the fact that we no more have infectious diseases to deal with so much. Significant associated morbidity cost the world close to $100 billion in the year 2012. Although we do not have reliable estimates from India, but roughly you could peg the prevalence of heart failure at 1.3 to 4.6 million. So which actually in a large hospital-based practice or a university hospital-based practice would be accounting for 30 to 50% of your hospital admissions in cardiology department alone. So if you look at the inter-CHF study, that is something that we need to understand out here, that amongst almost all of these regions which either are developing or developed in many ways, the largest contributor to mortality is actually cardiac death. And that is something that we really need to worry about, whereas China has brought this down to 7% thanks to their excellent healthcare services. So the data that we have from our setup, and that is mostly from the Trivandrum Heart Failure Registry, the important thing to note is that despite this being a benchmark of healthcare in India, even at 3 years, 44.8 patients had died, which tells you that with the benchmarks of healthcare and with guidelines, standard of care given to most patients, we still have a very high 3-year all-cause mortality. And that basically tells you that there is a lot of scope for improvement in all places as far as therapy is concerned. So let's look at the natural history of heart failure. A natural history of heart failure, as you can see, is something that follows this line on top. It is a quality of life. As you can see, there is waxing and waning. And finally, once it comes to the end stage, that is where patients either have arrhythmic deaths or pump failure, and they basically have very little chances of any form of therapy, and mostly are managed by palliative therapies at this point of time, or they go into what is known as the advanced heart failure care therapy, that is either a mechanical circulatory support or a cardiac transplant. And so as you can see on the lower scale, you see that this is the intensity of care. So the worse the patient becomes, the intensity of care, it also has to increase, and along with that is the cost also increases. So this is something that we need to understand. So we need to understand that all our patients need to be brought into this first part of the scale and ensure that they do not progress so rapidly back into this part. So what are our available treatment modalities? So we understand that most of the patients who visit to us either as OPD or in the hospital are either in stage C or in stage D. And with various therapies, we are either able to downgrade them down these steps into stage B, or they worsen further and become stage D and become eligible for what is known as advanced heart failure therapy. That includes ventricular assist devices, transplantations, hospice care, palliative care, etc. So I would, rather than going through a lot of guidelines, I would rather give you what are the practical derivatives of available guidelines, and I will heavily borrow for the European Society of Cardiology guidelines for heart failure. So firstly, it is for the diagnosis of heart failure. We need to keep it very simple and go back to our basics, ensure that we have detailed clinical histories, onset, progressions, know what precipitates, look out for cardiotoxic drugs, look out for radiation, look out for tachycardiomyopathies, some things which are easily missed. In fact, some of them are actually treatable. So you have curable causes of heart failure also, especially let's say hypocalcemic heart failures, etc. Nextly, we should also look at clinical examination, something that is very simply done. It is not as difficult as cardiac auscultation, but we call it the clinical examination for congestion. And that involves jugular venous distension, edema, basal rails, S3 gallops. You can do the cold peripheries, broad apical impulse. These are all basic, simple clinical features which can be done on a very simple cursory examination of the patient. And of course, the 12-lead ECG. And then, of course, we should familiarize ourselves with the 3 basic modes of heart failure, or rather, they are classified into 3 major parts to ensure the therapies are marginally different as far as we are concerned, of which the heart failure with mid-range ejection fraction, that is one between 40 to 49%, is something which still has a lot of research going and probably will gradually develop its set of therapies in the long run. So how do you generally work up? So once you've done the basics and you know that greater than 1 features of heart failure is present in any of the 3, you go for your NT-proBNPs, which is a very specific marker, except for those patients who have CKD. And then, of course, confirm your diagnosis with an echocardiography and start the patient on guideline-directed medical therapy. It is extremely unlikely that if any of these 3 are not congruent with your diagnosis of heart failure, that the patient is having heart failure. except for chronic kidney disease patients, where it is sometimes very difficult to differentiate between volume overload as well as cardiac heart failure. Then, of course, we come to the fancy gadgets of today's time. So we've for some time started to say that the stethoscope is gradually going to become something that is going to be for the prehistoric age. So now we look at ultrasound B lines, we look at A lines, effusions, we look at IVCs, and of course we spoke about the CardioMEMS device. But remember, even in a busy OPD practice, this is all resource intensive and it is not easily available. And even if it were to be available, it is something that is generally more time consuming and it can never really replace the physical examination. So what happens is that, so is the physical exam an anachronism in heart failure? So let me show you on the sidelines of the Paradigm HF trial, Crawford MH has actually come up with this clinical examination parameters, which he looked at the Paradigm patients, and they looked at 4 major clinical signs of congestion, and that was jugular venous distension. They looked at Rales, they looked at an S3 gallop, they looked at edema. And after multivariate adjustments, they were able to show that if either 1, 2, 3, or 4 of them were present, the hazard ratios prospectively and almost exponentially increase for the primary endpoints of the Paradigm HF trial, and that was CV death and hospitalizations for heart failure. So the authors concluded that in HF patients with reduced EF, a physical examination for congestion is an independent predictor of outcome, even when you adjust it for symptoms and BNP levels. So therefore, we cannot forego our simple physical examination when it comes to treating patients with heart failure with reduced ejection fraction. So what are the drugs available to us? We have our ACE, ARBs, and of course, the new kid on the block is ARNI, but it is no more very new because it's been here for almost a decade now. We have the beta blockers, the MRAs, now we have ivabradine, diuretics, and of course, those patients who do not tolerate ACE, ARB, or ARNIs, they go in for isosulfide dinitrate and hydralazine. Apart from that, we have a small segment which also responds to digoxin, especially those patients with heart failure with reduced ejection fraction and atrial fibrillation. And then, of course, the new block is the kid on the block is the SGLT2I inhibitors. And of course, we have vericiguat, which has been recently unveiled in this year's May 2020. So let us look at some simple recommendations as far as OP treatment for heart failure. We understand the treatment of hypertension, which basically is equivalent to afterload to the heart, is something that is importantly dealt with on an aggressive footing for all patients with heart failure. Apart from that, all those patients who have a background of ischemic cardiomyopathies need to be on statin. Last and third and fourth most, we have to give these patients ACE inhibitor, and it is recommended. It is a class 1A recommendation. Apart from that, we also give these patients beta blockers, which has a level of evidence which is class B. And then if you look at the 4 pillars of heart failure with reduced ejection fraction treatment, we have the ARBs, the ACE inhibitors, the beta blockers, and the MRAs. And of course, I think this will be talked about subsequently. And this is one of the molecules which has been a game changer as far as heart failure is concerned. And as you can see, no other molecule actually can boast of so many zeros before the 2 as far as the p-value is concerned, with a significant number needed to treat of 21 only, and a risk reduction which is 20% over and above that of angiotensin receptor blockers and ACE inhibitors. That is something that we've really not seen in a long time. Of course, this is one of the older studies. This is a beta blocker studies, especially with one of the beta blockers that we are most convincingly used in HFrEF patients, that is carvedilol. And here too, you can see this is a 35% risk reduction over standard of care. Another molecule that is important to use in heart failure is ivabradine. Remember, this is given in patients where you want to avoid the negative inotropy and the hypotensive effects of beta blockers. And as you can see here also, its effects, that is the 18% reduction in composite endpoints of CV death and hospital admission for worsening heart failure, was purely driven by hospitalizations for heart failure, because that is something that is where ivabradine really has been helpful. Next, we come to one of the newer molecules, and that is dapagliflozin, and that has recently been evaluated in a trial, huge multicentric trial known as the DAPA-HF trial. And as you would see that here also, your composite endpoints of CV death, heart failure hospitalization, and urgent heart failure visit was significantly reduced with almost a 26% reduction out here, and with good confidence intervals with a number needed to treat of 21%. So definitely, but what is interesting to note is that what this primary endpoint is basically powered by the worsening heart failure event out here. And as you can see, that is something that has been something talked about. But of course, the benefit as far as cardiovascular death is concerned is a little modest, with a confidence interval which is reaching unity out here. Benefit seen is what is important also to note is that this benefit was seen irrespective of diabetes status. So it is no more a diabetic molecule. I think it is something that is gradually going to become the new metabolic molecule as far as heart failure is concerned. So if you look at the recent positive trials in HFrEF and what DAPA-HF actually shows you, that it is almost on par with the other molecules that we've evaluated of late as far as HFrEF is concerned, and definitely is going to become a major molecule as far as heart failure is concerned in the long run. So hence, from 4 pillars, we now have the 5th pillar of modern cardiology interventions as far as pharmacological interventions in heart failure is concerned, and that is dapagliflozin. On the sidelines, we would also want to talk about the soluble guanylyl cyclase inhibitor, that is vericiguat, and that is in patients with heart failure with reduced ejection fraction, and this was published in May 14. Here also you can see that the primary outcome again was CV death and hospitalizations for heart failure, and that has actually reduced significantly. But again, the benefit as of now stands to be modest, and we are still skeptical about this molecule, and gradually we need to have more data on this molecule. Then comes, of course, the device-based therapies. I'll keep it short out here, and we understand that those patients between NYHA class 2 to 4 who has an EF of less than 35 despite 3 months of guideline-directed medical therapy, or has symptomatic heart failure, or is an outside hospital cardiac arrest survivor, these patients should get an ICD, especially the ischemic subsets. And of course, for the patients who are CRT, they need to have basically an LBBB morphology with a QRS which is more than 130 milliseconds to ensure that they are generally responders. But even despite that, we have a non-responder rate of 30%. So what do you do for those patients who are ineligible for CRT therapy? And that is where this paper comes in. So this paper was published by the European Heart Rhythm Association, and this is new devices in heart failure, and we'll be talking about the cardiac contractility modulation system. And this is something that basically delivers impulses in the absolute refractory period and changes the calcium handling inside the heart. And as you can see that there are 2 large-scale studies which have shown that, if not anything else, it has actually improved exercise tolerance in the form of 6-minute walk test, NYHA class, as well as the Minnesota Living with Heart Failure score. On the same sidelines, I think it is important to or interesting to discuss the fact that the ARNI also happens to act like the poor man's ICD. So sub-analysis of the paradigm trial, it shows that ARNI actually reduced mortality for sudden cardiac death and pump failure by almost 20% in both arms, but notably had no effect on the incident atrial fibrillation arm. So then comes that even despite that, when you still have patients who are still very symptomatic and need advanced therapies, and that is where we talk about advanced heart failure therapies, and that would include a left ventricular assist device or a cardiac transplant. And to put it in very short, this is a head-to-head comparison between the 2 groups. What is interesting to note is, as far as we are concerned with the current data, cardiac transplant is still the gold standard as far as advanced heart failure therapy is concerned. Although LVAD with the momentum trials as well as the HeartMate 3, it is getting better survival at 5 years. And I guess as the stroke rates come down, it is also going to be a very viable therapy. What is interesting?
Ayan?
Yes, sir.
Ayan, you are crossing the time.
Just 2 slides more. Just 2 slides, I'm done.
Yeah.
So numbers, and what is interesting to note is that here we have most of our transplants in India, they happen basically down south, and that is inclusive of 95%. And it's something that we need to improve upon. We need to increase donor awareness and donor so that people donate more organs in our parts of the country. And of course, the end all of this take home is that doctors who deal with heart failure need excellent training, extensive experience, and superb judgment. But what is important to know that despite having a lot of guidelines, you should not necessarily follow guidelines slavishly. Sometimes you have to ensure that you have to think out of the box to do the best for your patients. Thank you so much.
Thank you, Ayan.
Thank you, sir.
Excellent lecture. Maybe there are 1 or 2 points that we'll take up during the discussion.
Sure,
Thank
sir.
you very much.
Thank you, sir.
Soumitra, can you invite the next speaker, please?
Sure. Just let me see the program quickly. Dr. Pradeep Shah. So the next subject is present status of RNA. Now we have generalized talk on HEF-REF and HEP-PEF. Now we'll go into individual molecule and individual procedure. The first molecule, of course, comes to mind is RNA. And we have got no other than Dr. Pradeep Shah to talk on RNA for next 12 minutes, though it's now 5-6 years old. Now, what is the expanding horizon of RNA in management of HEP-REF? Dr. Shah, please. Dr. Shah, please unmute yourself.
Dr. Shah, please unmute yourself. There is, on the bottom of your screen, there is a microphone icon. Kindly click that to unmute yourself. We have also sent you a message.
The slides are well visible, but we need to listen to you also.
Pradeep? No, sir. Slide shared by backend, sir.
Oh, so, oh. So is he connected? Dr. Shah is connected?
Yeah, connected, sir. Connected.
Dr. Pradeep is connected. Due to internet issues, we are sharing the slides. We will request Dr. Pradeep to start talking.
Dr. Shah, you please start your presentation. Can you see your slides?
I think he cannot hear us.
He cannot hear us.
No, he can see. Morning also is the same issue from morning.
That is a problem.
So let him try some
it's a
later
technical
on.
problem now.
Can he ask Dr. Shubha Banerjee to join us?
Yeah, I've already joined. So you must let me share my screen then.
Yeah, that's better. Go ahead.
Okay.
Oh, will you talk something new compared to yesterday or the same slides?
No, in a different bottle, of course. But please, the host have to allow me to share.
Allowed, sir. Please go ahead.
Okay.
I have given access already.
Great. Okay. Yeah, just have to make sure it's not yesterday's slides. Okay. Yeah, great. So, I'll just go to this view slide show view. Yeah, is it visible?
Yes, sir, visible, sir. Please go ahead.
Okay, thank you. So I'm going to talk today on the role of SGLT2 inhibitors on beyond blood sugar control. So we have data from multiple cardiovascular outcome trials which show that SGLT2 inhibitors have multiple cardiorenal benefits apart from reducing blood sugar. And among these benefits, the one most consistently shown in all the trials with all the SGLT2 inhibitors that have been tried is prevention of heart failure hospitalization. So, such that 2019 AAC guidelines have recommended the use of SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, and recently orforglipron in patients with diabetes and at increased risk of cardiovascular events or established cardiovascular events to reduce the risk of heart failure hospitalization. Now, the SGLT2 inhibitors have been shown now to prevent the development of heart failure in patients with type 2 diabetes. So the two other important questions now are that can they be used to treat patients with established heart failure? And secondly, can they be used to treat patients, even those without diabetes, to treat heart failure? Now, DAPA heart failure is the first study which looked into this, and it enrolled more than 4,700 patients across 20 countries and included patients who had ejection fraction 40% or less, class 2 to 4 NYHA, and had elevated NT-proBNP, and these patients were put either on placebo or on dapagliflozin 10 milligram once a day. Baseline characteristics showed that most of the patients were in NYHA class 2, and mean ejection fraction was about 31. EGFR was reduced. The mean EGFR was 66, and about 42% had prior diabetes. And they were on optimal medical therapy, as well as they were also on device therapy. And the primary outcome, which was a composite of worsening heart failure or cardiovascular death, and worsening heart failure was defined as hospitalization for heart failure or an urgent visit resulting in intravenous therapy for heart failure. Now, the primary composite outcome was significantly lowered with dapagliflozin compared to placebo, and this was similar in patients with and without diabetes. And similarly, the individual components of the primary outcome, that's the cardiovascular death and worsening heart failure, were also significantly reduced with dapagliflozin, irrespective of whether they were diabetics or non-diabetics. And among the secondary outcomes, cardiovascular death or heart failure hospitalization, total hospitalization, cardiovascular death, and all-cause death were again significantly reduced with dapagliflozin compared to placebo. And as you have seen, there was no significant difference between diabetics and non-diabetics. Even if you look at the quality of life indices, and the one that was measured was Kansas City Cardiomyopathy Questionnaire score, and it showed that the improvement were more pronounced with dapagliflozin compared to placebo, and again similar irrespective of whether they had diabetes or not. And the same went true for worsening of renal function. That it was seen that dapagliflozin slowed down worsening of renal function compared to placebo, and again it didn't matter whether they were diabetics or non-diabetics. And the primary endpoint favored dapagliflozin in all the pre-specified subgroups. I mean, it depends on age, but it doesn't matter whether it's age, LVF, or whatever. And even if you look at the background heart failure therapy, you would see that dapagliflozin was better than placebo, irrespective of the background therapy. And interestingly, that also includes ARNI, the one which has been shown really to benefit patients with heart failure with reduced ejection fraction. So this benefit of dapagliflozin was seen over and above in those patients who had ARNI, and over and above ARNI, we had the benefit. And also patients who are on CRT, they also responded to dapagliflozin. And the safety and all the adverse effects which we are commonly associated with dapagliflozin, like volume depletion, renal adverse effects, fracture, amputation, hypoglycemia, diabetic ketoacidosis, none was more common with dapagliflozin compared to placebo, at least significantly not common. Now, coming to the other trial, which has been recently published, that is the Emperor Reduce trial, where empagliflozin 10 milligram was compared to placebo. And here, similar criteria was chosen as DAPA heart failure, only that the level of NT-proBNP that was necessary to enlose this patient depended to some extent on the level of the ejection fraction and also whether atrial fibrillation was present or not. And the other difference was here the cutoff EGFR was taken as less than 20, whereas in DAPA heart failure, the cutoff EGFR was less than 30. The endpoints, the primary endpoint was composite of cardiovascular death or heart failure hospitalization. Secondary endpoint, there were two secondary endpoints. The first was total hospitalization, and the second was slope of decline in GFR over time. And the baseline characteristics, well, it also had a high proportion of class 2, NYHA class 2 patients, and the ejection fraction, about more than 70% patients had ejection fraction less than 30. This way, the Emperor Reduce trial was enriched for patients with more severe LV dysfunction. In other words, they are more sicker patients. And here about 50% were diabetics, and EGFR, mean EGFR similar to DAPA heart failure study. The primary endpoint was significantly reduced with empagliflozin, about 25% relative risk reduction. And this was irrespective of the subgroup that was analyzed. And the other secondary endpoints, that is the first secondary endpoint, which was the total hospitalization for heart failure, that was also significantly reduced. And the same goes true for the second secondary endpoint, which was the change in eGFR from baseline. Now, there were certain exploratory endpoints, and that was one. It showed that the benefit of reduction of the primary outcome was mainly because of reduction of heart failure hospitalization, and the composite renal endpoint was also reduced significantly with empagliflozin compared to placebo. And also the quality of life index was better on dapagliflozin, and the total emergency department and urgent care visits for heart failure requiring IV therapy was also significantly reduced with empagliflozin compared to placebo. And although hypertension was numerically more with empagliflozin compared to placebo, symptomatic hypertension was not significantly different. Similarly, genital infection was more with empagliflozin numerically, but complicated genital tract infection was not much different. Now, there are certain differences between the two trials, but there is a meta-analysis which has been recently published in Lancet, which shows that the effect of the empagliflozin and dapagliflozin on hospitalization for heart failure were consistent in the two independent trials, and suggest that these agents also improve renal outcomes and reduced all-cause and cardiovascular death in patients with heart failure with reduced ejection fraction. In other words, possibly there is no significant difference between the results of the two trials. They show the same thing. Now, how does SGLT2 inhibitors work in heart failure with the reduced ejection fraction? The exact cause is not established, and therefore there are a lot of speculations. We still don't know which one or more are correct. There could be metabolic effects like natriuresis, uricosuriia, increased ketogenesis, a rise in hematocrit, and such others which may be responsible for the benefit seen. There could be hemodynamic effects, for example, plasma and interstitial volume, fluid volume reduction, which would reduce in a preload and afterload. There is also inhibition of sodium hydrogen exchanger activity, which would reduce the intracellular calcium overload. Metabolic shift in the myocardial cells has also long been thought to be a cause, where it's been seen like SGLT2 inhibitors increase glucose oxidation and lower free fatty acid oxidation, which helps in increased cardiac ATP production. And inhibiting and also the other possibility would be that, there's another sort of postulation is what happens is SGLT2 inhibitors actually induce nutrient deprivation signals, such as sertolin-1. And sertolin-1, what it does, it inhibits the activation of pro-inflammatory pathways, and therefore they reduce cellular stress and promote autophagy. And besides others like cardiac antifibrotic effects, improve balance in adipokine secretions, endothelial functional benefits are all been postulated. So SGLT2 inhibitors, now dapagliflozin and empagliflozin, are currently superior to placebo in improving heart failure outcomes among patients with symptomatic stable heart failure with reduced ejection fraction already on GDMT, irrespective of diabetes status. Benefit is primarily driven by a reduction in heart failure hospitalizations. There was also a benefit in renal outcomes, and there is now compelling evidence that some of the SGLT2 inhibitors may be added to currently recommended treatments for patients with heart failure with reduced ejection fraction with or without diabetes. So, so far now, for treatment of heart failure with reduced ejection fraction, we have 4 drugs in 3 pills. But with the advent of SGLT2 inhibitors, possibly we should be having 5 drugs in 4 pills. Now, ESC 2016 guideline says that in patients with symptomatic heart failure with reduced ejection fraction, we should start with ACE and beta blocker, and if the patient is symptomatic, add MRA, and if still symptomatic, switch them to ARNI, consider ivabradine, think about CRT, and so on. So what should be the position of the new agent, as the SGLT2 inhibitors, in the hierarchy? Should it be above ARNI, lower ARNI at the same time? Or should we at all be following a hierarchical approach? Whether this conventional therapy, where we start with ACE inhibitors or ARBs with beta blockers and then gradually add in each of the therapy? Is it the right approach? Or we should go for a more comprehensive therapy where we add in all the drugs that as and when necessary, because all they act in different all they have different mechanisms of action and they act in different ways. They go through different pathways. And it has been seen that with comprehensive therapy compared to conventional, and depending upon the age of the patient, you can gain 2.7 to 8.3 additional years, which are free from cardiovascular death or hospital admission for heart failure. And also about 1.4 to 6.3 of additional years of survival. So the heart failure guidelines are awaited. Till then, I think we have the DCGI approval for using one of the agents, and we can start using them to help our patients. Thank you.
Thank you, Subhroda. Excellent lecture. And we might take up a few questions in the discussion session. May I request my co-chair, Dr. P.K. Jha, to introduce the next speaker? Dr. P.K. Jha, can you please unmute yourself? Dr. Jha? Okay. Dr. Amol Khan, can you please introduce the next speaker?
Doctor, sir, I have sent you a request to unmute. Kindly unmute.
Holda, please unmute yourself.
Dr. Saha is on line. Pradeep Saha.
Which line? Main line, cord line?
Main line.
For Dr. Pradeep also I have sent a request. Yeah, he's
Dr.
unmuted.
Pradeep is there.
Can you hear us, Dr. Pradeep?
Hello.
Saha?
Hello.
Yeah.
Can you all hear me?
Yeah, I can hear.
Then Pradeep should continue.
Yeah, then I will keep the camera off, and I will only speak because I think some internet connectivity is there.
Okay.
So we can.
Whether you are in a position to talk or not.
You can keep the camera off.
Then Debabrata, we should continue discussion.
Is it okay?
No, there is Dr. Dilip Kumar to speak, I think.
And I would also like to, my topic is present status of ARNI. Can you please change the next slide? Yeah, ARNI has been explored in the following domains: the heart failure with heart failure with preserved ejection fraction, advanced heart failure requiring.
You are not audible.
LVAD or cardiac transplant. ARNI has been explored in CRT non-responders.
You are not audible.
Please continue with the previous slide, please. ARNI has been explored in CRT non-responders. ARNI has also a reduction of cardiac biomarkers. So trial, which is the landmark trial, because also caused the therapy treatment of NYHA report and class 4 was representing 11% of the population recruitment, but later it was reduced to 35%. The 9 GFR greater than 30 and potassium less than per liter. And 8 for 42 patients were enrolled and randomized to 2 groups at 696 NMG twice daily. Please, next slide, please. Next slide, please.
Dr. Khan, his internet is not working.
His internet is intermittently working. I think he's talking from cath lab.
So this is not a fair judgment.
No.
Oh, sir, he's actually sick.
Without wasting time, should we go to Dilip?
We should call Dr. Dilip Kumar.
Yes, I think we should switch over to Dr. Dilip Kumar.
Good afternoon, sir.
Dilip, you are online?
Yes, sir, I am there online.
Something very interesting. It's just not the role of CRT in HFrEF, but what about the non-responders with CRT? That's one step ahead. Really interesting, very interesting. It's not the role of CRT, non-responders to CRT. Okay.
So,
please go ahead.
Yeah, Mr. So, thank you so much for giving me a topic which is very close to my heart. That is approach to CRT non-responders. So when we implant a CRT, some of the patients that respond well, they are super responders. Some of the patients are, responders. Some of the patients are non-progressives, but quite a few are non-responders. And when we, the non-responder rate depends on the variables which we take into account in labeling these patients non-responders. If we take softer outcomes like clinical, well-being, how he feels, or a 6-minute walk test, this non-responder rate is around 25 to 30%. But when we take into account, hard outcome measures like increase in ejection fraction, reduction in LV and systolic volume, the non-responder rate is something like 35 to 40%. And this slide is, known and seen by all of us many times. These are the reasons of, non-responders, suboptimal response of CRT. It includes inadequate programming, inadequate, suboptimal LV lead position, besides, secondary factors like anemia, hypertension, and other guideline-mediated therapy which was missed. So when we want to prevent non-responders, we have to plan it right from pre-implant phase. And like in pre-implant phase, we have to choose the right patients. And while implanting a CRT, we have to look for a right vein, and we have to look for parameters which will guide us to a better response rate like QLV and RV to LV separation. And we also have to choose the right lead, multi-point pacing if needed. And post-implant, we have to treat these patients as per the guidelines. We have to offer them all the benefits of the recent molecules like ARNI, SGLT2 inhibitors. And at the same time, we have to treat arrhythmias very aggressively because they increase the non-responder rate. Like if the patient is having atrial fibrillation, PVCs, they need to be treated. And we all are aware that wider the QRSs and the left bundle branch block pattern, females, non-ischemic cardiomyopathy, these are the best responders by a CRT. But as we go towards ischemic cardiomyopathy and the QRS becomes something like 120, 130 milliseconds, the responder rate becomes doubtful. And one more way of identifying that which patient is going to be not responding well is the scar quantification by MRI. So if we get an MRI done and if we see that the scar is less than 15% burden, then we are quite assured that this patient is probably going to respond well. And this is the odds ratio of the parameters which we discussed a little while back, like QRS, LBBB, female sex, how they tell us that these patients are going to respond well. Coming to implantation, we have to choose the right vein, and this has to be posterior and lateral. And we have to avoid going more apical because a more basal and mid basal gives the best result. And the QLV which we measure, operator has to give due diligence, and he has to see how technician is measuring QLV because they can do some errors, and it has to be a QRS lead to the surface ECG, the onset of the Q, and the dominant RRS, the peak. So if the QLV is more than 90 milliseconds, then we are quite assured that this patient should respond well. At the same time, RV and LV EGM separation. The wider the separation, the better the patient's response would be. And this has to be seen by operator himself, and we should not rely on technicians. And if we have an idea about scars, like if we have done NICO, we know which area is scarred, MRI, myocardial perfusion imaging, or while implanting, we can, make out whether, we are dealing with scar area or not. Like if we're getting high threshold, if we're getting low amplitude fragmented electrograms, if we are getting long stem to onset of QRS interval, then these are, parameters which guide us that we are into scar area and we should avoid placing LV lead there. And once we have implanted the, device, we have to treat the patient according to the guideline therapy. And all these patients have to be given SGLT2 inhibitors, ARNIs, and as we discussed, if these patients have a PVC burden of around 5 to 6% even, and the patient is not responding and ejection fraction is not going up, we can consider ablating these PVCs, even 5 to 7% burden in these patients. And we can go for 3D mapping and ablation of PVCs. When it comes to optimization of the CRT, like the AV and VV delay, the gold standard is the echocardiogram the method, because if the PR interval AV delay is longer, there will be a diastolic mitral regurgitation. And if the AV delay is shorter, there will be AV will be truncated and cut off. So we don't want these two. So AV intervals should be long enough to give a proper AV and short enough to avoid a diastolic mitral regurgitation. And there are many ways, like echocardiographic ways, like patient can have echocardiographic methods like iterative methods and other methods, and we can do AV optimization. Similarly, echo-based VV optimization can be done by aortic valve VTI. And this is a old, practice we have been doing for so long. But nowadays, device-based algorithms like QuickOpt, SmartAV, they have kind of replaced, these echocardiographic ways. But still, the patient is non-responder. We should resort to echocardiographic, optimization to see that these algorithms are working properly or not. I will, talk about 3 important algorithms which probably will make a huge difference in future. And these are Medtronic adaptive CRT. So what an adaptive CRT does is it allows the intrinsic conduction on the right bundle and the RV. And in this way, it avoids the RV pacing. And we all are aware that if we are pacing the right ventricle, we are inviting the atrial fibrillation onsets. And this adaptive CRT reduces the chances of atrial fibrillation by 46%. And this way, the responder rate becomes quite high, and 12 to 14% response rate, on addition to what we see after the normal optimization we get through LV adaptive CRTs. But there is some limitation, like when it can be, it should be working. If the patient has a heart rate of less than 100, only then it will work. And if the patient has a normal PR interval, only then this is going to work. In a longer PR interval, it again goes back to a BiV CRT, unlike the LV adaptive CRT. Next is SYNC-AV. It looks a little difficult to understand, but the basic pathophysiology and the idea behind the SYNC-AV is same. It kind of searches the AV delay and tries to increase the pacing, and it also tries to increase the synchronous way by which the LV, AV, the AV conduction can fuse. So basically, what it does is the device paces for 256 cycles and then waits for 3 beats. And it takes, an idea about what is the AV interval. And then it subtracts 50 milliseconds from that and starts spacing. But this was kind of a fixed SYNC-AV, which was a classical SYNC-AV. Now they have come up with a kind of a new SYNC-AV technology where this is not a fixed 50 millisecond. This is 20% less than the normal AV delay. So it is 20% and 50% is sense and paced AV. And that's why they try to increase and enhance the AV, the pacing. And for LV first pacing, SYNC-AV, the AVV delay is calculated by, the CRT subtract VV delay from the calculated AV delay. So this way, they enhances the fusion, and this kind of 3-way fusion from there. One is coming from the up and from LV and the RV. And this 3-way fusion, they say, and they have shown in their studies that it gives us a more narrowing of the QRS. And finally, the last algorithm which I will talk about is effective CRT. And it's indeed it's a very interesting, algorithm, and it utilizes the fundamental principle of electrophysiology, that when we are pacing from inside the heart, and we are looking from a unipolar, catheter, once we are pacing and the tissue is captured, it is going to give us a cube pattern, so negative deflection. So the first you see here, with the negative deflection, if you are getting, it means there is the myocardial capture is happening. In the second, the graph, you can appreciate that is a positive deflection we can see. So it means there is a pacing, but still the myocardial is not captured. So this way, you can appreciate here the initial 3 beats which have been paced, but the QRS, initial deflection is positive. It means there was no effective pacing of the left ventricle. And we are measuring through LV cathode to RV coil. So although the dumb chamber says that we are pacing, all this by IV pacing is 100%, but still the effective pacing, the myocardial capture, the LV capture is happening only in 50%. So the effective CRT will tell us that only 50% effective pacing is being done. And as such, normal CRTs will give us 100% by IV pacing is done. So you can make out how the patient will be behaving. They will be non-responding. And this way we can make out what are the reasons. If the patient has a PVC, the patient has a high threshold of LV lead, we can correct these parameters. Similarly, if the patient has atrial fibrillation, the effective CRT algorithm increases the paced heart rate up to 30 beats, then maintain at a higher rate at 30 beats, and then come down again for 10 beats afterwards. And they look that they take into account that the myocardium is being paced and it has to be effective CRT pacing. So these 3 and this effective CRT pacing has increased the delivery in atrial fibrillation of CRT delivery by 16%. So these all 3 new algorithms like LV adaptive pacing, SYNC-AV technology, and effective CRT, probably the responder rate which we are talking about 70-75% will probably go to 90-95%. And we have to use this technology. We have to place the lead in proper site. And summing it up, CRT optimization and avoidance of non-responders starts from pre-implantation phase, and it goes forever with patient's life, because the arrhythmia can happen, the patient can have uncontrolled hypertension, patient can have other problems which has to be seen and dealt with. Thank you so much for the patient here.
Thank you, Dilip.
Thank you, sir.
I think Pradeep will not be available online. Devabrata? Yes. Devabrata is online.
Yeah. Dr. Pradeep Shah, is he ready with his...
No, he's there, sir. He's there. But again, we need to check whether he's...
But connection is not there. No.
Sir, we have tried about 4 or 5 times to connect him. We are also trying to share his slides on our side. But unfortunately, he is unable to connect because of internet issues.
Okay. Then we should start discussion, Devabrata.
Yeah. Dilip?
Yes, sir.
Dilip, am I audible, Dilip?
Yeah, I can hear you.
Yeah.
I can hear you.
Dilip, you have described several algorithms for improving the CRT response. But yes, is there any trial establishing its effectiveness? Because as you know, the last MPP trial that was done has failed to show any real benefit. What is your take on that?
Definitely. All what we have come around.
একটু জোরে বলবি, শোনা যাচ্ছে, একটু জোরে বল ভাই।
আচ্ছা, I was telling MP the multi-point pacing. It was a kind of a intuitively very attractive concept, but it failed to deliver when it came to randomized control trials. But this LV adaptive pacing, I think it has shown in trials that it has increased the responder rate to 12% to 14%.
90%.
At the same time, the reduction in AF incidence after the RV pacing, which we do obligatory by V pacing. So RV is getting paced and chances of AF becomes higher. And they have shown that reduction of 46% of onset of AF happens with LV adaptive pacing. And SYNC-AV is a new technology. Effective CRT is also new technology. They have just launched. I think 6 months or 1 year has happened. And their initial results were quite promising. I have, implanted one or two Sync-AV devices with Sync-AV, and really the QRS snoring was excellent. But definitely we need to have more data and evidence to build on before we say that these are probably, the answers what we were looking for.
Okay. Could I ask one question to Dilip Kumar?
Yes, sir.
Yeah, it's to assess who are going to respond, which you think is more important about scar? Is it the extent of the scar or the site of the location of the scar?
In fact, both are important, and we can't say, but if the burden of scar is more than 20%, the chances are there that patient may become non-responders. If you have a scar location in posterior lateral wall, defined there and restricted there, it's a difficult problem. But still, you can go ahead with a LV. Then his bundle pacing. Other alternatives are there.
So it's always better to get an MRI scan beforehand if possible, isn't it? That would give you a lot of data.
So this is a additional way of looking at this. But I think if the patient has a kind of a wide QRS left bundle branch block and non-ischemic cardiomyopathy, then I think we can go straight away. But when we are dealing with ischemic heart disease patients, probably MRI assessment can give us more idea.
Yes.
May I ask you, if you by different methods think that there is a chance of non-response, what is your approach? Will you counsel the patient and go ahead with the procedure, or will you refrain from the procedure?
Sir, I think I have done quite a few cases, and I think if I will allowed to do screens here, I can show. I have done a lot CRT in these patients, left bundle optimized CRT, and in fact, they have responded quite well. So this is another extra advantage we are getting.
So unless you do, you do not know. Unless you do, you do not know. Just one question, as the ARNI talk is missed, it is an unfortunate thing. May I ask Dr. Bhuvan Majhi, what do you think the future of ARNI in heart failure with preserved ejection fraction, particularly after the Paragon trial? What is your take on it?
Till now, no benefit has been shown with this ARNI in heart failure with preserved ejection fraction. In the initial phase, with the Paramount trial, it was shown that it reduced the anti-proBNP level. So it will be shown because there is neprilysin inhibition, so anti-proBNP will be reduced. But whether in the heart failure with preserved ejection fraction or the LVF is already more than 50%, whether it will actually improve the outcomes is not yet established.
There is some hint that up to 57% it might improve. After that, it may not, but these are all sub-analysis. Dr. Banerjee, what do you think is the role of SGLT2 inhibitor in HFpEF? Any future?
Well, I think there may be future, but again, we also thought there would be a future for ARNI, but that's also become a little bit doubtful after the results of the Paragon. So I think we should wait for the trial data, which is expected in a couple of years' time, before we conclude. At this moment, it should not be used.
Soumitra, do you think there is some scope of precision medicine in determining the treatment algorithm for heart failure with preserved ejection fraction? Because I believe there are certain papers that has been published where the treatment has been customized according to some phenotypic subgroups.
Debabrata, you are absolutely on the right. I now tell it everywhere that it is a sort of dustbin, and really you do not know what is the material in the dustbin. There are three types of materials already there. There are three types of phenotypes. On one hand, you have got the metabolic syndrome kind of people who have got the HFpEF. On the second hand, you get the ischemic heart disease with heart attack and ischemic cardiomyopathy type of people with HFpEF. And thirdly, you get the very poor prognostic atrial fibrillation, pulmonary hypertension, lean and thin patient with HFpEF. You really cannot take them together and give one shot and expect improvement. Debabrata is absolutely right. That is the basic fault of all HFpEF trials. They did not categorize the phenotype. I am sure if you categorize the phenotype to start with, you will get immediate benefit. There are enough hints in certain sub-analysis of TopCat trial and various previous trial, including iPreserve trial, that in certain segments of patient, you get really good benefit in terms of heart failure, hospitalization, and even mortality. But unfortunately, nobody differentiating the inclusion criteria of these three types of phenotypes. So that is unfortunate.
Yeah, there may be some development in future. There is a recent paper that has been published, I think, in JACC, one of the JACCs, not the JSCC proper, that has shown there is a macrophage shift towards producing more fibroblasts. So maybe the future therapies will be directed towards that pathway, maybe.
Exactly. Also, the problem is many of these phenotypes overlap. So they are not classical that we can say this is A, this is B, and this is C. Many may be a combination of A and B. So getting a trial, that's why is also a bit difficult.
Absolutely.
Another thing, Soumitra, what I believe in this heart failure session, because we are discussing sitting in India, there are certain issues, Indian issues. And all of the registries that has been conducted so far has shown a very poor compliance with heart failure therapies. And there are so many issues, mainly the educational status, the socioeconomic issues. And World Heart Federation has brought out a program, Road to Heart Failure Treatment. So any comment on that?
Yes, Debabrata, I think it's very easy to say these are the medicines which act, and McMurray might say, I want to have all the 4 medicines on me in 6 weeks' time. But how many Indian patients can continue 4 medicines which cost around 8,000 to 10,000 rupees per month for the rest of their lives? So we have to be careful while promoting evidence-based medicine in Indian scenario. And the question comes, if there are 2 expensive medicines, say ARNI and SGLT2, which you prefer?
This is a very interesting question that we are facing very frequently.
Lots of things are there. Here my take is that,
in HEP population, they are heterogeneous population.
Yes, sir. That's what you are telling. You are now talking about HEP-REF.
And many people will go out of heart failure.
Yes, that's true.
Precipitating factors. What Subra is telling that right at the moment, we don't have any adequate evidence that which is the particular drug for HEP. We have to tackle anemia, we have to tackle heart failure, we have to tackle atrial fibrillation and other things, hypertension and obesity, I think. And
for HEP-REF, sir, I have got one logic. If the patient can afford one expensive drug, it should be SGLT2 inhibitor. Because
I agree.
ARNI has got the RAS blockade. You can have cheap RAS blockade with enalapril or ramipril. You can have something on that pathway. But the SGLT2 pathway is totally new pathway. And beta blocker is cheap anyway. So you can have 3 pathways. That is why.
Not only that, Soumitra, we have several experience of patients having drop in blood pressure and rise in creatinine after starting ARNI.
That happens,
we have experienced that.
That's important.
And here, and we have.
There are senior people like Parthoda and Anjanda and Minalda. What are your takes? If you have to choose between one, patient can afford only one in HEP-REF, SGLT2 inhibitor or ARNI. What will be your take?
Definitely ARNI.
Absolutely. I also absolutely.
But why not ramipril and SGLT2? Or enalapril and SGLT2? Incremental benefit is 13%, whereas SGLT2 give 32% new benefit, even on RAS blockade.
Soumitra, if you combine these two, there is chance of hemodynamic problem, the sudden fall in blood pressure, and patient gets unstable. So in that way, if you don't combine ARNI and Bhimada, that is SGLT2 inhibitor, so naturally chance of hemodynamic imbalance will be much less. So I think it's better not to use together when the patient cannot afford. It's better to use ACE inhibitor or ARNI along with beta blocker and MRA where it is required. I think that should be the approach.
No, he's asking a separate question that whether it's SGLT2 inhibitor or ARNI. Which one is better?
It is between the two. If you look at the renal function, it's definitely SGLT2 inhibitor.
Definitely ARNI will be better.
SGLT2 inhibitors have a favorable effect on the kidney function. There is no denying the fact.
So
Nalda, what is your take?
Yeah,
So Anjan is there.
I was trying to.
I was telling, I stated that
so many are speaking all at the time that I can't speak. Whatever it is, there are overwhelming data in favor of ARNI, not on SGLT2 inhibitor. I am very clear about that. So overwhelming data, and there is significant reduction in the not only mortality, though the one or two SGLT2 heart failure data are showing some good results. But having said that, the RAS blockade has got its own beneficial effect in terms of preventing the remodeling, which has not been proved with the SGLT2 inhibitors. Most of the functions of SGLT2 inhibitors are related to either reduction in the volume or interstitial or intravascular, and to some extent some pleiotropic action. But ARNI has got definite evidence in terms of prevention
More
of
solid evidence,
reduction of mortality, and all other aspects.
More established in the terms of mortality.
Minal, I would slightly like to differ, because the two important comorbid conditions in heart failure other than ischemic heart disease is hypertension and diabetes, and both has a long-term effect on the kidney. And we had a good number of patients developing renal failure, deterioration of renal functions, hyperkalemia in the Paradigm HF study, and these patients had to be removed from the study. Unlike SGLT2 inhibitor study, where we have seen a definite improvement of the renal functions, and kidney function plays a very important role, there is no denying the fact. When you are giving diuretics in a case of Paradigm HF trial, because you stimulate the RAS system, but when you give SGLT2 inhibitors, the RAS system is not stimulated. There is overall benefit of the kidney functions, and you cannot deny it. In EMPERA trial, there are only 13% patients, 13 to 25% patients had a concomitant ARNI. But these patients were very carefully chosen patients. All patients could not take ARNI. So I believe between the two, my personal opinion, I would feel more at home using SGLT2 inhibitors in diabetic or non-diabetic patients, particularly in terms of renal functions and its effect on the kidney.
But it's not taking the remodeling process, Dr. Datto. What I want to emphasize, because the most important part is the remodeling process. In the heart failure,
it has a tremendous remodeling patient.
No, Partho, the logic is that in the RAS side, ARNI is the best, but you have got an inferior alternative. But in the SGLT2 side, you don't have any alternative. That's a totally different path.
Soumitra,
you have anti-inflammatory, profound anti-inflammatory effect of SGLT2 inhibitors.
And they also
the scientific chair is telling that the time is
yes.
So
too many precedents, past, present, and future are waiting. Past, present, and future precedents are waiting in the ring. So I think we should leave the stage.
Yes. Thank you very much. All the speakers have done a great job. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
করেছিল না তো আর্নি তো আমার তো হেপে জিজ্ঞেস করেছিল হেপে তো না আর্নি তো আমার আর কি কোশ্চেন
So can we start our next session?
Of course.
3 minutes are still left, but I think
3 minutes still left. I see only 1 minute anyway.
Dr. Abhijit Banerjee is already there. Dr. Ashok Kumar Kaur is there. I myself and Dr. Dev. Pradipda, are you there? Dr. Dev? Then I think Dr. Abhijit Banerjee can start the proceeding.
If he has joined.
Yeah, he has joined.
Has everybody joined? Dr. Abhijit Banerjee? Dr. Ashok Kumar Kaur?
Ashokda, you unmute yourself.
Dr. Ashok, sir, join, sir.
Dr. Dev?
Yes, now can you hear me?
Yes.
Hello?
Sir. Yes, sir, we can hear you.
Hello.
Okay. Okay.
Dr. Deb?
No, sir. Dr. Deep not yet.
Is supposed to join.
Can you start the program?
Yes, can you start it now? Hello?
I think you can start it.
Okay, Dr. Abhijit Banerjee is here. Professor P.S. Banerjee is here, I think.
Yes, I am here.
Okay, fine. So we can start the program?
Then please start the session.
Okay. So, Dr. Abhijit Banerjee, do you like to speak something?
Abhijit is not online, I think.
No, he's online.
I am sorry, I am like a new, like a driver who has been given a car who cannot drive. So I'll just
fine. Thank you,
hear
thank
what
you,
you are
thank
saying.
you, Abhijit da. Thank you.
Thank you.
But you are here. We are happy with you. Okay. Now today just now we are having a very nice ritualistic session in this update session of CSI conference that is called presidential oration. And this presidential oration, our president of West Bengal branch CSI, Professor P.S. Banerjee, is going to deliver the lecture presidential oration on the topic management of heart failure in elderly people. Professor P.S. Banerjee.
Thank you, Dr. Kaur, Dr. Abhijit Banerjee, and all other senior dignitaries present in this meeting. So welcome you all to this Update Cardiology 2020 session, a virtual. So my task is to manage the heart failure in the elderly. I know there was a lot of discussion about the heart failure in the previous session, but again, because the living age is increasing, so automatically the incidence of heart failure is also increasing. And if you find the admission rate in the hospital of heart failure, majority of the patients are above the age of 60 years. And if you go further, you can find that 20% of the patients with heart failure above the age of 85 years. So that is why it is better that you should understand this problem, because in the elderly, there are many comorbid conditions and there is polypharmacy and a lot of problems with these multiple drug interaction, and you have to manage the comorbidities. So this is really a challenging situation. And moreover, because they are physically often frail and inactive, symptoms are often very minimal in the form of the exertional dyspnea. So they may be only fatigability is the primary presentation of the heart failure in this elderly. So we should be very careful for the early diagnosis of heart failure in the elderly, so that you can give an appropriate management, keeping in mind of all the existing comorbid conditions he or she is carrying on. So we will consider the incidence of heart failure in the elderly, physiological changes and mechanism of aging, the causes of heart failure, the pathophysiology of aging of heart leading to heart failure, elderly versus younger, the management proper, and pharmacological regimen consideration, and the DEFeat heart failure trial, and also the ARNI-related trial, and finally the conclusion. Next slide, please. So if you consider the incidence, heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject the blood for metabolic need of the body. Chronic heart failure is a disease with significantly higher prevalence in the elderly or patients older than 65 years old. The elderly are more susceptible to heart failure due to several morphological and physiological changes related to the aging. More than 80% of the individuals hospitalized for the heart failure are over the age of 65 years, and 24% are over the age of 85 years. Next slide. Now, what are the physiological changes and mechanism of aging? Now, if you follow this slide, you can see the percent prevalence-wise, Top on the list is the arthritis to the tune of around 45%. And next you find the heart disease is around 40%. And then comes down cancer, diabetes, COPD, asthma. So automatically heart failure is second on the list from the higher side. And that is why the diagnosis of this condition must be done very diligently and treatment should be implemented as early as possible to reduce the mortality. Next slide. Next slide, please. Causes of heart failure, if you consider, coming to the heart itself, you have several valve defects, particularly in the elderly, calcific aortic stenosis, aortic regurgitation. There may be chronic atrial fibrillation, and there may be heart muscle defect like hypertrophic cardiomyopathy, dilated cardiomyopathy, or other infiltrative muscle disorder. And there may be the most important is the coronary artery disease. And that is considered to be the one of the major cause of heart failure in the elderly patient. Coming to the lifestyle, the failure to take the preventive medicines for preventing the development of the heart failure, like in diabetes, hypertension, renal disease, etc. Diet, that is taking high salt diet and excess fluid intake and alcohol abuse, these are all important factors for the development of the heart failure. Now, high blood pressure is one of the major factors in the development of heart failure in the elderly. And so the management of hypertension is very important. Now, coming to the lung disease, it may be because of the chronic obstructive pulmonary disease. It may be due to pulmonary arterial hypertension, and it may be due to obstructive sleep apnea, and there may be a high pressure in the pulmonary artery, that is secondary or primary pulmonary hypertension. There may be other causes like anemia, kidney disease, diabetes, obesity, obstructive sleep apnea, and there will be thyroid disorder, particularly thyrotoxicosis, and side effects of medications like anti-cancer medicines, SAID, corticosteroids, etc. As regards the infection, although the rheumatic fever was a very high incidence in 4 to 5 decades back, but nowadays because of the preventive treatment, now the incidence of rheumatic heart disease has come down to a great extent, although it is often seen in the rural areas or in the urban crowded areas. So go for the next slide. Now, cardiovascular changes with the please go to the previous slide. Go to the previous slide, please. Next slide. Yes. Now, cardiac causes of heart failure, as I already told you, the majority of the patients, in the 70% of the cases, it is the atherosclerotic coronary artery disease, which is the major cause of heart failure. Hypertension is also one of the major contributing factors for the heart failure. Heart failure can also be caused by one or more of the following conditions, that is ventricular diastolic dysfunction, which is nowadays called as heart failure with preserved ejection fraction. There may be narrowing or leakage of the valve, as I already told you, in elderly patient, most likely the regurgitant aortic valve or stenotic aortic valve or MR. Now, weakening or stiffening of the heart muscle, that means the heart cannot relax properly, particularly in the setting of hypertrophic or infiltrative cardiac muscle disease. Abnormal rhythm disorders like uncontrolled or chronic atrial fibrillation, one of the important cause, but among all the causes, the majority cases are because of coronary artery disease. Next slide. Now, cardiovascular changes with the age. Now, as we grow older, the aortic compliance is reduced, arterial stiffening occurs, so automatically the afterload is increased. So there is increase in the systolic pressure, there is increase in the pulse pressure, there is good diameter, there is aortic wall thickness is also increased, the pulse velocity is increased, early reflected waves and late peak velocity are all increased. And as a result of that, the aortic impedance is also increased and the left ventricular afterload is increased. And due to that, the left ventricular wall tension is increased, which results in left ventricular hypertrophy. There is increased myocardial contraction time, and these two things results in the reduction in the left ventricular compliance. There is normalization of the left ventricular wall tension, the maintenance of the ejection time, and there is early diastolic filling rate. So all these things together ultimately results in impaired diastolic function, increase in the left atrial pressure and the size, that is improved myocardial oxygen supply and demand balance, preserve systolic function, but there is impaired diastolic function. So that is how physiological changes occurs in elderly patients with the heart failure. Next. Next, pathophysiology of the aging heart leading to the failure. The one of the important factor is the handling of the calcium, and this improper handling of the calcium results in the improper relaxation of the cardiac, and there may be localized or excess fibrosis along the different segments of the heart muscle. There is increased wall thickness, there is left ventricular hypertrophy, decreased telemeters length of the myocytes, so which results in chronic programmed death of the myocyte. And all these things together again ultimately lead to impaired relaxation and compliance failure, and finally diastolic dysfunction, and render to the poor reduced cardiac reserve, and there is finally left ventricular dilatation, and ultimately the cardiac failure starting from diastolic to systolic dysfunction. Next. Sign symptoms, you all know that the symptoms include the breathlessness and dyspnea. In the elderly particularly, dyspnea is not often seen unless they are ambulatory. If the patient is bedridden and frail patient, it is very difficult to get this symptom, but that is the most common symptom, that is dyspnea on exertion. Later on, if not treated, there will be orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigability, and ankle swelling. But one most important aspect of the clinical examination is the examination of the jugular vein to find out the elevated jugular venous pressure, because if the patient is not much symptomatic presenting with the ankle edema, clinician must look at the jugular vein to find out any increase in the jugular venous pressure, any presence of hepatojugular reflux, third heart sound, displaced apical impulse, cardiac murmur like mitral or tricuspid regurgitation. Patient may have the tiredness, shortness of breath, coughing, fluid retention, pumping action of the heart grows weaker, and there is accumulation of fluid within the pleural space, swelling of the feet, and there may be swelling of the back, and finally pulmonary edema. So the pulmonary edema is followed by pulmonary arterial hypertension, and finally the biventricular failure. Next slide. Now, what is the difference between the elderly and the younger people? In contrast to the younger patient with systolic heart failure, the elderly patient with acute decompensation of the heart failure more often present with acute pulmonary edema and hypertension, often called the flash pulmonary edema, consistent with a significant vascular contribution to the underlying pathophysiology. Conversely, the elderly outpatient may present with a gradual onset of symptoms and atypical finding, including the loss of appetite, a decrease in the body mass index, whereas traditional heart failure symptoms such as shortness of breath may be absent or difficult to interpret due to the lack of specificity. Next slide, please. Now, chronic heart failure can be classified as heart failure with reduced ejection fraction, mid-range, and preserved ejection fraction. Now, heart failure with the preserved ejection fraction, often called diastolic dysfunction, and in this patient, the ejection fraction is usually more than 50%, and left ventricular remodeling occurs in the form of concentric hypertrophy. There is normal end-diastolic volume, increased wall thickness, and the left ventricular muscle mass, and the high ratio of the mass-volume ratio. Now, there is no guideline-directed management in this scenario of the heart failure with the preserved ejection fraction. Mostly the treatment of the underlying cause and correction of the underlying factors, and to some extent you can give small doses of diuretic, you can use the ACE inhibitor, you can use beta blocker, calcium channel blocker, and even in some cases you can use a mineral receptor antagonist. Coming to the heart failure with the mid-range ejection fraction, much known about this scenario. Here the ejection fraction remains within 40 to 49%, and treatment depends upon what are the precipitating factors and what was the underlying cause, and treat accordingly. And lastly, coming to the heart failure with the low or reduced ejection fraction, where the ejection fraction is less than 40%, and there is eccentric dilatation of the cavity, increase in the end-diastolic volume, reduced in the wall thickness of the left ventricle, and low ratio of the mass volume, and the guideline-directed therapy are available in this scenario, although with a poor outcome. Even the 5-year mortality down the line was around 50%. And this kind of heart failure with reduced ejection fraction, also we do have various device therapy, and we ultimately, these patients may get benefit with cardiac transplantation. Next slide. Chronic heart failure or classification of the heart failure, you all know that based on the functional class, NOAHA, it is from class 1 to class 4. So starting from no limitation of activity to slight limitation of the activity, marked limitation of the activity, and unable to carry out any physical activity without discomfort. So these are the laid down classification is being taught from the college life. So everybody knows about that. Next slide. Now, based on the clinical progression of the disease, again, we have the ACC/AHA guideline, and this is stages A to D, and stage A meaning that there are risk factors for the heart failure, but there are no sign symptoms or there are no evidence of structural damage. Stage B is structural disease is there, but without any sign symptoms of heart failure. Stage C, both structural disease and prior or current symptoms of heart failure. And finally, stage D is the refractory heart failure requiring specialized intervention. Next slide, please. Pattern of ventricular remodeling, already I discussed, are different in heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. In reduced ejection fraction, you have volume overload, increased diastolic pressure, increased diastolic wall stress, series of addition of the new sarcomeres, the chamber enlargement, and finally there is eccentric hypertrophy. Whereas patient with the preserved ejection fraction, there is a pressure overload, increased wall thickness, and there is increased systolic pressure, increase in the parallel additional new myofibril, there is wall thickening, and there is concentric hypertrophy of the left ventricle without much increase in the left ventricular cavity size initially. Next. So pathophysiology, heart failure with reduced ejection fraction, damage to the cardiac myocytes, extracellular matrix leads to changes in the shape and size of the heart and function of the heart muscle called remodeling process. That there is stimulation of the secretion of the neurohormonal level in the blood, and this is the neurohormonal changes. The treatment is directed to correct this neurohormonal overactivation. There is these neurohormonal changes leads to vasoconstriction, fibrosis, apoptosis, hypertrophy, cellular and molecular alterations, and finally myotoxicity, and leading to hemodynamic alteration, salt and water retention, and thereby producing symptoms like dyspnea, edema, fatigue, maladapting, remodeling, and progressive worsening of the left ventricular function, which actually causes the increase in the morbidity and the mortality, arrhythmia and pump failure causing death. Next slide. Now again, elderly versus young. Now predominantly, if you consider the older patients and heart failure with the preserved ejection fraction, gender is usually female, physical finding minimally displaced apical impulse, and you can get S4 on auscultation. Pathophysical mechanism is age-related changes in the cardiovascular structure and function, oxidative stress, vascular stiffness, skeletal muscle abnormality. Potential target of therapy is the underlying cause, that means control the blood pressure, treat the coronary artery disease, exercise training, and peripheral target. Now coming to the heart failure with reduced ejection fraction, usually the younger patient, most often male, laterally displaced apical impulse, you can get S3, you can get MR or TR murmur, ischemic heart disease, neurohormonal activation, left ventricular remodeling, and finally dilatation is the pathophysiological mechanism. And the treatment, as I already told, that guideline directed treatment, that means you treat the neurohormonal changes using the beta blockers, RAS or ARNI, mineral receptor antagonist, and newly added the SGLT2 inhibitor. Next slide. Now, various diagnostic tests are available. We are being taught from our early age group, from the college life, that is do the best clinical examination. That is most important. So find out any elevated of the jugular venous pressure, particularly in the elderly, who cannot move around. And the chest X-ray can show the cardiomegaly, pulmonary edema, any infection. The 6 minutes walk test, ECG can show arrhythmias, atrial fibrillation, bundle band block pattern, particularly the LBB. Echocardiogram is the hallmark by showing the any structural changes causing the heart failure, and blood test, particularly the anemia, the thyroid disorder, renal disorder, electrolytes, and the diabetes, that means blood sugar estimation. As regards the biomarkers, these have both diagnostic, prognostic importance, as well as they can dictate the response to therapy. So when these biomarkers are elevated, BNP or NT-PO, BNP, you can differentiate the dyspnea between the lung cause or the heart cause. Next slide, please. Precipitation of the elderly patient in the clinical trials have tended to exclude the elderly. That is the problems. Not much randomized trials are available with them. More recently, several heart failure trials have focused specifically on the effect of therapies on the elderly, including the iPreserve trial. Irbesartan was used in heart failure with preserved ejection fraction. Mean age was 73. The senior trial, the mean age was 76, where nebivolol was seen in patient hospitalized with the heart failure. Cardiac insufficiency bisoprolol study, that is CBIS ELD study, the mean age was 73 years. And the ELITE study, mean age was 73, where losartan was shown to be very effective in elderly patient. And finally, the PEF chronic heart failure study, mean age was 76 with the perindopril. So next slide, please. And if you go through the most important, the trials in the heart failure with reduced ejection fraction, the ejection fraction less than 40%, if you look at to this slide, average age is around 63.8 plus minus 11. And most of these patients, including the ARNI trial, paradigm heart failure, the age was above 60. So there are several trials which are carried on with heart failure with reduced ejection fraction. Here, most of the patients are above the age of 60, showing thereby that this heart failure with reduced ejection fraction, most of the patients are elderly. They are included in these trials. Next slide. Next slide, please. General principles of the management in the elderly patient with chronic heart failure. The goals of treatment are to relieve the symptoms, slow the progression of the disease, prevent hospitalizations, and improve the survival. Incorporate the risk, benefit, and quality of life, including the end-of-life preferences. Assess for non-cardiac comorbidities like anemia, COPD, diabetes, hypertension, chronic kidney disease. Screen for coexisting geriatric syndrome like delirium, cognitive impairment, depression or anxiety, falls, this is very important, urinary incontinence, and functional capacity. Next slide. Pharmacological regimen, this is very important aspect in the management in the elderly. Understand the heterogeneous nature of the elderly population. Start with the lowest possible dose and reach to the maximum effective dose or guideline directed dose. Renal function must be considered and dose must be adjusted accordingly so that there should be a cardio-renal balance in pharmacological management of heart failure in the elderly with CKD. Assess the risk and benefit of each additional medications, and polypharmacy is really a problem in the elderly patients, resulting in compliance failure. Assess drug-to-drug interaction, drug-disease interaction. Assess the need for medication management like pill box, blister packs, home care medications for improved adherence. Medication reconciliation during the care transition from home hospital into the assisted living or long-term care facility should also be considered for better management in the elderly patient. Next. Now, these are the list of the drugs. As I already mentioned, various doses are given here, so I'm not going into the detail. Only thing I can say that try to start with the lowest dose and try to achieve the maximum targeted dose if the patient can tolerate and hemodynamically stable with all the drugs available for the guideline-directed medical therapy of heart failure. Next slide. DEFEAT Heart Failure Trial, a guide to management of geriatric heart failure patient. This covers the essential aspects of the geriatric heart failure management, diagnosis, etiology, fluid management, ejection fraction, and the treatment. Next slide. So it covers everything in elderly heart failure. Careful history and physical examination, as I already told you, often may help to make a clinical diagnosis of heart failure in older adults, determine an underlying etiology of the heart failure, determination of the fluid volume status by careful examination of the external jugular vein is the single most important physical examination during the initial and subsequent visits. Determination of the left ventricular ejection fraction is the single most important test after a clinical diagnosis of heart failure has been made, which should be used to guide the therapy in scenario of elderly heart failure patient. Next. Now, this is, can you go to the previous slide? As regards the use of SGLT2 inhibitor, the landmark trial, DAPA heart failure trial, where dapagliflozin was compared with the placebo. And if you consider the primary outcome, hospitalization from the heart failure, the death from any cause and death from cardiovascular cause, you can see there is a significant age in favor of dapagliflozin when you compare to the placebo. Next slide. And the summary of the result shows there is a reduction of the 30% heart failure related hospitalization, 80% reduction in the cardiovascular death, and 17% reduction in the all-cause death in patient with heart failure with reduced ejection fraction when you use DAPA and comparing with the placebo. Next slide. Clinical consideration in pharmacological management for heart failure in the older patient, type of heart failure, whether it is a systolic or diastolic or mixed, NOIH class, renal function, comorbidities like COPD, anemia, life expectancy of the patient, time to need to produce an effect on the therapy, goals of care or target the symptoms improvement, including the patient preferences, goals of pulse and blood pressure reduction with the heart failure medications, common drug interaction, that is increase or decrease concentration and resulting in side effects. So these are all factors must be considered when you treat heart failure in the older patient. Next slide. Next slide, please. Dosing guideline commonly used in the heart failure. I am not going to detail. Next slide, please. Dosing guideline of commonly used heart failure drugs to avoid heart failure. So one should avoid using NSAID, corticosteroids, non-dihydropyridine calcium blockers, antiarrhythmic class 1, and thioglitazone, glitazone group because they cause fluid retention and precipitation of the heart failure. Next. So in conclusion, heart failure in the elderly will continue to be an increasing health burden as this population represents the majority of heart failure patients and demonstrates worse outcome compared with the younger patient. Sparse evidence exists for the disease management in this patient due to two related issues, that is underrepresentation in the clinical trial and less frequent referral to the specialized attention. While elderly patients represent the majority of the heart failure population, have a worse prognosis compared with the younger cohort, targeted treatment strategies have been insufficiently developed for them. Present knowledge is limited by the enrollment of patients with heart failure with reduced ejection fraction in most of the trials, with the exclusion of those with increased frailty and the elderly. Next. Elderly patients with heart failure commonly have a complex profile characterized by multiple comorbidities, polypharmacy, social circumstances which may provide an additional clinical challenge requiring targeted and multidisciplinary approach. While elderly patients represent the majority of heart failure population and have a worse prognosis compared to the younger one, targeted treatment strategies have been insufficiently developed for them. Present knowledge is limited to the enrollment of patients with the, already I discussed that. With regard to the pathophysiology, new technique to assess the central blood pressure, aortic stiffness may be particularly important in the elderly patient with heart failure in order to provide insight into the exacerbating factors and potential therapeutic target. Secondly, heart failure diagnosis and assessment in the elderly may require adjustment of the trial metrics with respect of exercise capacity assessment and biomarker cutoff. Next. So thank you for your attention to this talk, and I am grateful to all of you for attending my lecture. Thank you very much.
Thanks to Professor P.S. Banerjee for your excellent talk. Now, as it is a presidential oration, so there is no scope for questions. But before ending this session, I just like to have some comments in this COVID era.
Ashokda,
Yes.
Ashokda, just 1 minute. It is a ritual to offer the presidential oration medal. So I am showing it in the screen. It is the presidential medal. And this is because of the virtual nature of the conference, so we cannot, we could not give it directly. So it's now.
You send it virtually. You send it to Professor Banerjee virtually.
Yeah. Thank you very much.
Thank you very much, Dash. Thank you.
Okay. This is gold medal.
I like to have one comment before ending the session. Okay.
Yes.
Okay. Just as Professor Banerjee has told about the different aspects of heart failure, but in this COVID era, I think one of the important cause of heart failure is COVID infection because of the viral myocarditis, because of the increased cytokine surge, because of the drug toxicity, and because of the increased prothrombotic condition giving rise to acute myocardial infarction or unstable angina in COVID patients. And that together can produce heart failure or exacerbation of heart failure or newer onset of heart failure. That is very important. Okay. Thank you.
Thank you very much. So,
yes, Dr. Dev, do you like to have some comment? We are having, it seems, not audible. Dr. Dev is not audible.
I want to see the gold medal.
Oh, you want to see the gold? Okay. This pure gold?
He wants to see the medal in gold.
24 karat gold.
Minalda, show it again, please. Minalda, show it again. Project it.
He is not interested in gold medal. He is interested in medal in gold.
You see?
Oh, yes.
Yes, thank you.
This is not gold.
So, Professor Khan, you are not satisfied with the gold medal?
No. This is not gold. This is not yellow metal.
This is not.
This is silver. I think, Dr. Khan, it is silver.
It is silver.
I think.
Okay, thank you.
I thank you. Thank you. I think you can go to the next session. Okay.
The next session is Presidential Conclave, Juthika Majumdar Memorial Oration. Our chairpersons are Dr. Manotosh Paja, Dr. Anjunal Dotto, and Dr. Ashok Kumar Kaur,
and Dr. P.S. Banerjee.
And Dr. P.S. Banerjee. Yes.
Is Dr. Paja here? Dr. Paja here?
Good afternoon, Professor Paja. Good afternoon, Professor Paja.
He is here?
He is here.
He is here, sir.
Very much.
Paja, please unmute yourself. Dr. Paja, please unmute yourself.
He is not here?
He is there. He is there. He is visible.
We like
he
to
is
see
not audible.
And he's talking also, but without unmuting. Dr. Paja, please unmute yourself.
You can ask the third party to unmute the Paja's mobile. Now they can do it from here.
Sir, we have sent a unmute request to Dr. Manotosh Paja. He has to just press that button and he'll be unmuted.
Dr. R.S. Majumdar is with us here also.
So I think somebody can help Dr. Paja to unmute.
So we will call him, we will ring him, We'll call him on his phone and let him know.
Please go ahead with the lecture.
Okay. Acha, Juthika Memorial Oration is. So can I proceed let
yes,
Dr.
yes,
Paja
please,
join?
please.
Yes.
Can you give
please.
Small resume of Juthika Memorial Oration? Small resume. Juthika Majumdar, wife of a respected R.S. Majumdar. She passed away only at the age of 48 years in 1988. Leaving behind Mr. Majumdar, Dr. Majumdar and his two sons. One of them is Dr. Alok Majumdar, an active CSI member and chief cardiologist of B.R. Singh Hospital, Eastern Railway, Kolkata. She was associated with many social and spiritual activities. She was an active member of the Red Cross Society of India. So we'll feel privileged and honored to have a lecture after her memorial. And the person delivering the lecture is none other than Dr. P.K. Dev, ex-president of the Cardiological Society of India. Dr. Dev, to coin his own term, has a compulsive desire of doing something or going in an unconventional way of solving problems of cardiological different types. So with these few words, let us see how non-conventional or what way he diverges from what is just a usual way of looking at the problems, and let us see what difference he has in his mind, and his knowledge, wisdom, and experience would drive us to the new of the problems. And he's going to deliver the Jutica Memorial Oration. Dr. Pradeep Dev, the podium is
Dr.
yours.
Dev, welcome for the address of memorial oration, pharmacoinvasive therapy, which is very important, burning problem of our country, particularly myocardial infarction. Pharmacoinvasive therapy, only way to protect our patient or myocardial infarction, whether it is a prospective or lytic or compulsion. Dr. Dev, please.
Oh, thank you. It is a proud privilege for me to deliver the oration, Jutica Memorial Oration. Respected chairpersons and my friends, may I have the first slide, please? First slide. First slide.
Okay.
Okay. I am going to talk on pharmacoinvasive therapy, Indian perspectives, logistics, and compulsions. So what the guidelines are dictating regarding pharmacoinvasive therapy, my oration will deviate from the existing guidelines. Please, next slide. Slide. Next slide.
Azunika, just click on the slide. Just move your mouse on the slide, yeah.
Definition. Pharmacoinvasive strategy consists of early thrombolysis followed by either immediate rescue PCI for patients with failed thrombolysis or non-urgent coronary angiography to determine the need for additional revascularization within 3 to 24 hours. This is the definition of pharmacoinvasive therapy. Next. There is proven superiority of primary PCI over thrombolysis, and it is universally accepted. Equally accepted is the fact that there is universal lack of PCI capable facilities in the majority of hospitals that receive patients with STEMI. Next. Superiority of primary PCI is there because along with overlying occluding thrombus, the procedure also tackles the culprit lesion. Next. So what is the current status of thrombolysis in India? Thrombolysis is currently the most practiced form of reperfusion strategy in India. Fibrin-specific bolus agents have some advantage over non-bolus streptokinase, but are more expensive and not widely available. Streptokinase is cheaply available, easily affordable, and most frequently used thrombolytic agent in India. The final decision regarding choice of thrombolytic agent depends upon the discretion and compulsion of the treating physician, whether which one is available. It is streptokinase or tenecteplase or something else, or nothing is available in the scenario at that time. Next. Next. Indian scenario is a difference. Pre-hospital thrombolysis with streptokinase, it is not done. With tenecteplase, it is rarely practiced due to non-availability of infrastructure. Pre-hospital adjuvant therapy, it is done. Trained pre-hospital paramedics and nursing personnel, very rarely available. There is unwillingness of Indian population to accept treatment offered by nurses and paramedics without a doctor in the scenario. Next. Successful thrombolysis patency reperfusion. We must understand what is successful thrombolysis. With successful thrombolysis, there is disappearance of symptoms and discomfort. More than 50% of HT7 resolution in 90 seconds should be, 90 minutes should be there. Earlier picking of CPK-MB and troponin. Reperfusion arrhythmia may be there in the form of ventricular rhythm, and coronary angiography is always gold standard. Any combination of these features should be there to declare a case to be successfully thrombolized. Next. Loopholes of diagnosis of thrombolytic failure. There are fallacies with chest pain analysis. There may be no chest pain at all. There may be atypical chest pain. There may be chest pain equivalent. So by looking at the disappearance of chest pain, it is not always possible to diagnose thrombolytic failure or success. ST segment resolution. It is not always there with left main thrombosis, left circumflex thrombosis, perfusion injury, or LVV. So by looking at the ST segment resolution more than 50%, not always possible to declare that it is successfully thrombolized. There is delayed ST resolution, particularly with streptokinase, up to 4 hours. So at the end of 90 minutes, it is not possible to dictate that it is successfully thrombolized, especially if streptokinase is used. Next. Inherent shortcomings of failed thrombolysis. Significant bleeding risk is there. Longest time of reperfusion. 1 hour for streptokinase infusion, 90 minutes to observe for the successful thrombolysis. Then you go for transfer PCI, the transfer rescue PCI to another center, and then do. In the meantime, you always cross 3 hours, initial 3 hours. So the success rate of failed thrombolysis with primary with rescue PCI is always hopeless. Longest time of reperfusion, difficult early and precise recognition of failed thrombolysis. Standby rescue angiography plus a team 24 hours a day is practically nowhere in India. Forced to perform in a time slot, which is advised to avoid in pharmacoinvasive therapy. So we always love to avoid failed thrombolysis, but failed thrombolysis is a part of the game. It is seen in 30 to 40% of the cases of thrombolysis with streptokinase and about 20% of cases of thrombolysis with tenecteplase. Next. Indian scenario with a difference. Delayed ST resolution is very common, up to 4 hours. Hardly any difference between off time, weekends, holidays, and weekdays in rural India so far as interventional cardiology is concerned. Financial and logistics are real concern in rural India. Next. Timetable. Door to needle time 30 minutes, door to balloon time 90 minutes, up to 120 minutes in transfer PCI cases. Very difficult to accept it or get it in Indian scenario. I'll discuss it with evidences in following slides. Next. Time window, the fundamentals of my oration. First hour is the golden hour, may be extended up to 3 hours. Following thrombolysis, a hypercoagulable period comes temporarily and persists for a period hour. Till the thrombolytic is washed away from the circulation, a temporary period of hemorrhagic diathesis persists. For bolus lytic it is 2 hours, for streptokinase it is 6 hours. So after thrombolysis, for next 3 hours, there is a combined period of prothrombotic and prohemorrhagic manifestation within this biological system. Next. Aspirin, thienopyridines, and GP2B3 inhibitors will aggravate the situation. That's so-called hemorrhagic diathesis. Up to 3 hours after bolus thrombolytics, 6 hours after streptokinase, a confused biological hemostatic system works within the system. Hypercoagulability of blood and bleed diathesis coexisting and cooperating simultaneously at the same time within the system. In pharmacoinvasive strategy, coronary angiography is recommended from 3 to 24 hours after thrombolysis, except in rescue PTCA where in failed thrombolysis, where immediate PCI should be attempted even during this complex biological system of prothrombosis and prohemorrhagic. Next. Lessons. Avoid initial 3 hours following thrombolysis for post-thrombolytic PCI on biological grounds to avoid this complex prothrombotic and prohemorrhagic situations. Avoid initial 6 hours if streptokinase is used. Next. Review of literature. COVA-EO study in South Indian Alexandria et al. In 2012. Tamil Nadu STEMI project 2013. STEP AMI 2016. Depending upon this, in fact, the STEMI Council was developed in India, and they came out with their own consensus document, along with API and also along with CSI. Next. Down memory lane, global experiences. Let us go through the global experiences with pharmacoinvasive therapy. This is the Egyptian experience. In Egypt, the scenario is similar to India. They use streptokinase. They have their own limitations of fund. They have their own wisdom also at the same time. Primary PCI versus pharmacokinetics therapy for ST elevation MI. Streptokinase was used in ECI. Pharmacokinetics strategy was an effective treatment option for those who could not undergo PCI within 2 hours. Next. Same in Egypt, the primary PCI and pharmacoinvasive therapy with equipotent results. Next. Stream study was done in Egypt. It also came with similar result, but in stream study, instead of streptokinase, tenecteplase was used, and instead of 1 to 3 hours, 1 to 6 hours delay was used. The results were similar. Primary PCI and pharmacoinvasive therapy producing similar results. Next. This is the Indian study, themselves, Alexander et al. They show that pharmacoinvasive therapy with fibrinolytic agents, a potent life-saving repurposing strategy in STEMI patients, even in metro cities and Tier 1 cities in India. They recommend that in metro cities and in Tier 1 cities in India also, due to inefficiency of transport service, inefficiency of ambulance service, and the non-availability of cath lab in most of the time because they're always engaged. They recommend that pharmacoinvasive therapy should be practiced in metro cities and Tier 1 cities in India. Next. This is in Canada, Ottawa Heart Institute. They recommend that up to a radius of 90 kilometers from Ottawa, they recommend primary PCI, and beyond 90 kilometers, they recommend pharmacoinvasive therapy because the results are ultimately the same. Next. This is Glacier 2 and Glacier 4. The studies are done in Spain and Portugal. The main study on which the pharmacotherapy, invasive therapy is standing today. They recommended that lies now and stent later. It was done in Spain and Portugal, and it is the basics, and it is the beginning of pharmacoinvasive therapy from Spain and Portugal, Glacier 2 and Glacier 4. Next. Dynamic study, the study from Denmark, Danish experience. Primary PCI has a few compulsions to choose as a better treatment strategy with only a trend towards mortality. So again, equipotent studies. Next, British experience, Royal Berkshire Hospital, UK. Pharmacoinvasive therapy may be a better option than direct primary PCI. There is transfer PCI. Next. French experience, first MI 2015, French registry data. Pharmacoinvasive strategy is a suitable alternative to primary PCI. Next. Indian experience from CREATE registry 2008. It was done in 50 centers in India. Patients in India who have SES have a higher rate of STEMI compared to developed countries. Patients' door-to-needle time is 60 minutes. Look at it. The ideal time is 30 minutes. Hospital indoor thermolysis time minutes. Ideal time is 30 minutes. And thrombolysis is done in 58% of cases only. In 96% it was streptokinase, and PCI was done in 8% only. So this is the Indian scenario, and we are talking about primary PCI, pharmacoinvasive therapy, and so many spectacular things. Next. Kerala SES registry 2012. 30% has STEMI. 41% receives thrombolysis, mostly streptokinase. Symptom onset to presentation is more than 6 hours. Look at it. It is a fun. More than 6 hours. Less than 1/3 patients receive thrombolysis within 30 minutes door to receive time. That means 2/3 patients did not receive thrombolysis within the stipulated time frame. This is the Indian scenario on record with evidence in our hands today. Next. Lesson. Thrombolysis is a perfusion strategy of choice by compulsion in India, and thrombolytic failure is a must-know for every physician practicing in India. And primary PCI center and rescue PCI center should be there for 24 hours operative in India, where thrombolysis is practiced. Next. First medical contact to first medical history. A threefold increase in hospital mortality is reported when door to balloon time exceeded 2 hours, and similarly when door to needle time exceeded 1 hour. Next. Next, India's facts. Look at it. The population of India is 1.3 billion. 45 million people suffer from CVD. 2.3 million people die from CVD every year. Around 1,400 cath labs only. Around 1,400 cath labs only are available in Tier 1, Tier 2 cities. It was presented in NIC 2019 in Lucknow. There is growing demand for cath labs in Tier 3 and Tier 4 cities and towns. But who will build it? Even pharmacoinvasive therapy is too distant a dream for Indians. Next slide. Distribution of wealth in Indian population. Top 1% of Indian population owns 60% of wealth in India. Top 10% of Indian population owns 80% of wealth in India. Bottom 10% of Indian population owns 0.2% of wealth in India. Bottom 50% of Indian population owns 0.8% of wealth in India. Source, Oxfam Annual Study, World Economic Forum 2018. So with this study report of your wealth distribution, you are looking for pharmacoinvasive therapy. There is planning 100% coronary angiography in 100% cases after myocardial in all over the country. Where the 50% of the Indian population owns only 0.8% of the wealth of the country. Next. Hard fact till date. Standalone streptokinase thrombolysis still dominates the national scenario. Ischemia guided coronary angiography should be the preferred strategy under such circumstances. National awareness and preparedness is necessary for pharmacoinvasive therapy. Logistics and compulsions should be taken care of by policymakers. Next. This is the flow chart given by CSI in their recommendation. Where possible in metro cities, go straight for primary PCI. Otherwise, go for pharmacoinvasive therapy, and in rural areas, go for streptokinase thrombolysis and wait for angina guided treatment. Next. Final statements. Primary PCI should be done in ideal situations. It is the treatment of choice, but difficult to achieve in Indian scenario, even in metro cities and Tier 1 cities. Pharmacoinvasive therapy, which is equally effective, should be the treatment of preference in Indian scenario if logistics permit. Next. Final slide. Streptokinase continues to be used. Routine CAG might be done, I repeat, might be done following streptokinase thrombolysis after 6 to 24 hours, not 3 to 24 hours, if logistics are favorable. Rather than routine CAG, ischemia-guided CAG should be the preferred strategy in compelling Indian situations with inappropriate logistics. Thank you very much for your kind hearing. Thank you.
Thank you, Dr. Deb, for your excellent insights into the so often spoken and relied upon procedure of revascularization, that is pharmacoinvasive therapy. Whenever we talk in terms of pharmacoinvasive therapy, we have a feeling that we can purchase some time by giving thrombolysis as early as possible so that we feel more confident and complacent to do the procedure within 24 hours time. That is okay so far as logistics permit, but you have rightly pointed out we have a lot of areas where even this is not possible, and there our primary aim should be to do thrombolysis as early as possible. And since streptokinase takes a longer time to act, so obviously the timing when you are using streptokinase because of financial constraint should even be done earlier than the bolus thrombolytic agents. Since an oration does not allow usually questions, so I would hand over the mic to my senior colleague, Dr. Professor Mantosh Panja, for his comment. And finally, we'll have a look at the medal for the orations. And one just small comment I take, the latest ESC guideline, it is for the academic interest, the latest ESC guidelines has leveled the time from 2 to 24 hours rather than 3 to 24 hours, which was the earlier guideline preference. And secondly, the important thing about invasive is that even if it is 24 hours so far as angioplasty is concerned, but thrombolysis must be done early, and that is rightly pointed out by Dr. Pradeep Deb repeatedly, that we must do thrombolysis in time, and that is the first foremost important thing, particularly in our country.
Thank you, Doctor, for a comment. Am I audible to you, Doctor?
Yeah,
that is only one concluding remark in the presentation, Doctor. Particularly the COVID situation, all the SKY, European guideline, TCT-MD, and the American College, their guideline, they recommend that is the role of thrombolytic after Markov infarction if the patient is stable. Okay. Second indication is the dot to balloon time, not in the time. That two situation, the role of thrombolytic is there in the COVID situation. Other situation, definitely primary angioplasty is the best. And until now, all the guidelines recommended in spite of the COVID positive, and the primary angioplasty is best. Okay.
If there is any other comment from any of the senior president or ex-president present there, Ashok, like to make a small comment?
Unmute. Record not audible.
Sir, please unmute yourself. Yeah.
Okay. So I think Dr. Dev has emphasized the role of pharmacoinvasive therapy in Indian scenario. But still, what Dr. Paja has said is correctly said that if the logistics are available, definitely primary PCI is superior to pharmacoinvasive therapy. But in Indian scenario and for economic reason, transport reason, various causes are there. So still, I think in rural areas, there is some role of thrombolytic therapy, provided it is given in the early hours after the onset of the chest pain, because more and more late is there. So there is chance of more remodeling of the myocardial cells as well as the enlargement of the heart. So there will be no use of giving pharmacoinvasive therapy. So early institution of pharmacological therapy, followed by, if necessary, angiogram and subsequent revascularization, it should be done. But that should be remembered by all the physicians who are practicing in the rural area. Thank you.
Dr. Kaur, brief.
Just I like to have a comment regarding these thrombolysis in COVID situations, because there are some suggestions that in COVID situations, thrombolysis is a better choice, considering the other logistics, and particularly as because it is a prothrombotic condition, COVID infection. So the thrombus burden, we know that thrombus burden is much more in the mind in COVID situations. So in that perspective, I think I just like to know from Dr. Dev, the thrombolysis is a better effective choice, or is a better choice than primary PCI in COVID situations with acute MI.
Dr. Dev, please, quick.
Look, primary angioplasty is always the treatment of choice. But in COVID situation, I don't know why the primary angioplasty can be done if the patient is COVID negative. In COVID positive cases, how many cardiologists will go for primary angioplasty? I don't know.
No, but
Dr. Dev, they should be.
Our initial CSI recommendation was that we should go for thrombolysis in preference to PPE. But if there is a dedicated cath lab, if we have PPE kits for all the technicians and nurses, then COVID positive or COVID negative STEMI should be treated equally. But the question is that whether thrombolysis or antithrombotic agents should in particular be used more aggressively in the COVID background because of the pro-coagulant.
Yes. There is no contraindication of using thrombolytics in COVID situation.
Dr. Dev, only one point, all the European guideline or SKY guideline or TCT guideline mention, that is the primary angioplasty is ideal, accepted to everyone. Provided that
I didn't, Dr. Panja, I did not tell it is not ideal. I just respected the poverty of my country.
Okay, only question of that.
I just respected the logistics of this country.
Okay, Dr. Dev, only one.
What is applicable for this country?
Okay.
Dr. Only one comment. There should be a balance between the patient benefit and the cath lab workers' protection. That is the important issue.
Minal, like to make any brief comment, Minal?
I think Minal's session is on COVID.
My lecture is
so
on.
Minal is going, yes. So
he's going to talk next.
Yes.
Minal, do you like to make a brief comment?
No, my
Why
lecture
he
is
will
on
comment? Because he's going to give the lecture,
cardiology,
na?
so I'm going to
Okay.
talk on this particular
Yeah,
subject.
Okay.
that's right.
Maudalda,
Yes,
please
that's
wind up.
fine. That is the, so ladies and gentlemen, Dr. Dev has done a wonderful oration for benefit of our society and benefit of the people in case of market infarction. Thank you, Dr. Dev, for excellent presentation.
Thank you.
Okay. I think then next oration, Sushila Bala Kundu Memorial Oration. I think I request Dr. Datta to introduce this regarding the few words regarding Sushila Bala Kundu.
Do I have the resume?
Yes, it will be there.
Yeah.
Sushila Bala Kundu is the beloved mother of Dr. S.C. Kundu. Late Sushila Bala Kundu departed from the heavenly abode in August 1992 at the age of 80 years. This lecture has been instituted by Dr. S.C. Kundu in the year চলে গেল কেন?
এটা আছে আছে আছে। ও স্লাইডে চলে গেল।
May I get the slides?
আধুনিকা
Dr. Jayantu Saha, please look after. Dr. Jayantu Saha, can you focus the slides?
In any case, our Reverend Dr. S.C. Kundu, for his love and respect to his mother,
Came and start.
had instituted this particular memorial oration in the year 2000, dedicated to the memory of his mother. And we have an equally competent and expert cardiologist of great repute, the President of the Cardiological Society of India, Dr. Minal Kumar Das, to deliver the important memorial oration. Dr. Minal Das, please.
Minal Kanti, not Kumar.
Minal Kanti.
Minal Kanti Das.
Dr. Das will talk on the subject of role of cardiologists in COVID-19 pandemic situation. Dr. Das, please.
Yeah. Is my slide visible?
No, sir. Kindly share it. Kindly share it again.
Is it now visible?
Yes.
Yes.
Good evening, everyone. And it's a real honor to me to give me the chance to speak on this very, very important topic, that is role of cardiologists in COVID-19 pandemic situation. And I'm really delighted to speak on this topic in memory of Sushila Bala Kundu. And this is an oration which has been dedicated by our very much respected teacher, as well as who was also the General Secretary of Cardiological Society of India, Dr. S.C. Kundu, as you have been already informed by Dr. Ranjanlal Datta. Respected chairpersons, my all mentors of Cardiological Society of India, who has given me this position today to speak on this subject. I've got some disclaimer or acknowledgement. Most of my speech will be actually based on some of my experiences, which I gathered over the last 8 months while working even at the remote part of the Bengal during the COVID, as well as the Amphan scenario. So it's from the ground level, I'll be speaking on the role of cardiologists in COVID pandemic scenario. What I have done, actually, I'll be aiming to fulfill the aim of the Cardiological Society of India, that is, where CV diseases are prevented, it should be possible, controlled when necessary, and treated when appropriate. So this is the aim of Cardiological Society of India. And I have used the word cardiologist, that is CARDIOLOGIST, as the mnemonic to describe the various facets which we must know during the time of COVID scenario. Right now, will have to be a COVIDologist. So a cardiologist will have to be a COVIDologist as well, because of the fact that the definition itself indicates that it's an acute manageable immunologic thrombogenic inflammatory viral notifiable disease. And with this background, there is a very, very high thrombogenicity, which is very much focused. And as cardiologists, we'll have to really focus on this particular aspect in various facets. Now, why the cardiologist should know COVIDology? Because of this slide, where it has been shown that the cardiovascular diseases have got more implication in terms of fatal outcomes of patients with coronavirus infection. Similarly, with the hypertension as well as diabetes mellitus also, there can be actually increased mortality, as you can see, that 21.3% versus 11%. And more is the troponin I test, and more is the positivity of COVID, the more is the mortality. So that has been shown here. Now, as COVIDologist, cardiologist, you must know certain things in the form of the various basic aspects of the endemic, what is known as the pandemic, regarding the travel history, chest X-ray, then the test, CT scan, IgM. Though we may not know the detail of everything, but at least some of the terminologies we must know, like D-dimer test, CRP, then serum procalcitonin, LDH, and all these IL-6 and levels, and of course RT-PCR, which is very commonly used for diagnosing COVID scenario. Now, same way, chest X-ray, which is very, very basic test, must also be known to all the cardiologists. There are various patterns, pattern 1 to 6. I'm not going into the detail of it, but definitely when we are dealing with the case of cardiovascular illness, which I am coming later on, you'll see that various changes will give you some indications when the patient is having coronavirus or COVID-19 infection. Similarly, some aspects of HRCT, CT scan of the thorax, also give you some help, because many of the management principles, even when a patient is presenting with acute myocardial infarction or with cardiogenic shock or with cardiac failure, you'll have to deal in a different way as compared to the management of the various diseases in peaceful time. You'll have to know about the comorbidities and the various advisories. Like age is very, very important. Diabetes, hypertension, I have already told. Coronary artery disease, heart failure, and CKD. They are very, very important. Similarly, you'll have to actually know how to safeguard the various doctors who are dealing with various aspects of patients by safeguarding them. You'll have to increase the public awareness, and you'll have to listen, learn, and adapt, apart from taking the various safety measures which already possibly you are taking care of. This is a very important slide, because this has come to all of us as a very much boon during the COVID era. That is the universal definition of myocardial infarction, and the value of the troponin I test in determining the differences between the COVID induced myocarditis vis-a-vis acute myocardial infarction, which could be type 1, type 3, type 4, type 5, except the type 2 where the myocarditis can occur. And now with all these facets known to us, the Cardiological Society of India actually acted very fast in the very early period, and we came out various position statements, especially in terms of the management of acute myocardial infarction, heart failure, then you know the hypertension guideline, and also how to do the non-invasive tests like echocardiography and all. And CSI position statement on reperfusion strategy of acute myocardial infarction has been actually widely accepted all across the world, not only in India, but also across the world, as I'll show to you. And there are various facets like confirmed cases, suspected cases of COVID-19, and patient with low probability of clinical suspicion of COVID-19 cases. And this is the algorithm which has been actually very, very nicely demonstrating the various aspects, especially mentioning the role of thrombolysis in acute myocardial infarction when the patient is presenting even to a period of up to 12 hours as compared to the 3 to 6 hours or even 1 hour golden hour level. You have to take care of the patient even up to the 12 hours, because the logistics here in COVID scenario is very, very different from that in the peaceful time. And that is why up to 12 hours, you can go for the thrombolysis if there are actually chest pain and STD changes. And after 12 hours, of course, you should follow the, as usual, guideline of the primary PCI. But having said this, actually, whenever there are facilities available, PCI capable centers are available, PPE facilities are available, all the cares are there, then possibly you'll have to take care of the patient with the proper knowledge of the acute myocardial infarction. And that's why I told the academic knowledge is very, very important even during this COVID scenario. Now, same way, the recommendations regarding reperfusion strategy in AMI and in STEMI also, whenever there is possible, it is the non-invasive method, rather non-interventional method you should accept if the patient is hemodynamically stable. And if unstable, then you should follow the guideline as usually for the PCI. Now, with this background, actually, the role of the burden of thrombus again has been very much highlighted, especially after the publication of the London study, which has shown that the thrombus burden is very, very important, and thereby the STEMI in the STEMI during COVID-19 scenario is basically a rainbow phenomenon, but the various facets can be found in the form of non-obstructive coronary artery disease, then large thrombus burden, multivessel thrombosis, then instant thrombosis. Then there can be the differences in the myocardial blast as compared to the peaceful time, and there can be various outcomes. And all this knowledge must be there, and you must adopt, and of course you must adapt to all these theoretical backgrounds while taking care of the proper care of the unstable angina or ACAS or acute myocardial infarction. And the various guidelines outside India also, like the like ESC, they have also highlighted the role of PPCI whenever it is feasible, whenever they come in the right time and to the right hospital. Otherwise, one should take care of the patient with the fibrinolysis. Now, so for the stable coronary artery disease concerned, this has been discussed widely during the COVID season. That ischemia trial has given a lot of inputs, and that's why we'll have to follow the rather non-interventional techniques to give the supportive therapy to the stable coronary artery disease, and only in cases where it is not feasible or not possible to take care of the patient, then you will go for the interventions. So for the R is concerned, cardiologists are, you are a revered doctor, and you are revering the other people, the patients, and that's why you'll have to take care of the staff, and you'll have to take care of the patients in all the possible ways that are available with you. And that's why all the methods of taking care, the special care during the COVID scenario must be followed in the form of hand washing, in the form of social distancing in the form of taking care of the face and eyes, and whether it is in critical care unit or procedure, or during echocardiography, you'll have to warn the patients in the maximum possible way. Same way. So for the D is concerned, you are a doctor, not only cardiologist, you are a doctor. So all the responsibilities of doctors and the drug therapies you'll have to know. And this is the guideline regarding the ACE2 and SARS-CoV-2, which have been put forward by the Cardiological Society of India and all other societies, that ACE2 and inhibitors are to be continued while during the COVID scenario is also there when the patient is suffering from cardiac illness. The chloroquine knowledge is again very, very important, because this is a drug which has been recommended by the ICMR in the very early stage, or as a prophylactic measure. You must note the A, B, C, D, E, F, and also the drug-drug interaction, especially in terms of the QT prolongation. Now, in the confines of the pandemic, actually, hospitals were overwhelmed and doctors were as well overwhelmed, and failure to prioritize the patients in terms of care were also compromised, and logistics were compromised. PPCI, though helpful to fix the CAD, but not the pneumonia, thus delaying the potential intubation and prone ventilation, and lack of understanding of the disease when it was overt was also there. And fear gripped everyone. To a great extent, many, if not all, actually failed in delivering the right kind of treatment in the initial period of COVID scenario. But thanks to some brave hearts who proved by sacrifice that doctors are doctors. Similarly, the doctor cardiologist will have to take care not only in terms of the knowledge, but also the hemodynamic stability, the clinical outcomes of various diseases like arrhythmias, coronary events, thrombotic burdens, and heart failure management with all the available guidelines. But again, the stress is a very, very important factor that has been actually revealed during this time of the COVID scenario, and stress-induced cardiomyopathy, especially the Takotsubo, has also been highlighted during this particular season, and they must be taken care of in the proper way. So for the I is concerned, I am possible. We are not impossible. We are possible, and we can do our things not only in the emergency, but also in ICU, critical care, echo lab, and cath lab, and everywhere. And we must be one. We must be one, and we must work in a teamwork. This is seen during the COVID period, and we were working together to take care of the patient. And of course, we must be a leader, not only as a doctor, but as an individual, as an aid to the organization, and everywhere we'll have to lead from the front, and we'll have to believe in ourselves, as well as we'll have to make others to believe. We must be selfless and not selfish. We must be empathetic and not sympathetic, and let's live happily. Let others live peacefully. And we must be fearless, we must guide, and we must also be inspiring. And these are some of the points which I'm going to summarize, that as the cardiologist and COVIDologist will have to also know the various kind of therapies, will have to be trialists and target-oriented, like hypertension and diabetes, and with the comorbidities must be highlighted. Men and women are no different in COVID-19 scenario. Risk factors, when multiplied, they actually further accentuate the COVID mortality and morbidity. And in COVID-19 infection, the inflammation-induced thrombus burden must be taken care of. Best procedural aspects should be taken care of, and logistics must be taken care of, and accordingly, thrombolytic therapy or PPCI must be taken care of. SCAD, I have already said, ACERB should be continued, and increasing the awareness amongst everyone should be the primary guideline. And we must realize that we are doctors, and we'll have to actually be coronated with the corona. And that's how we'll have to take all the responsibilities during the time of COVID scenario. Thank you very much for patient hearing.
Am I audible now?
Hello.
Yes, Dr. Kaur, we can hear you. Unmute, unmute, unmute. Unmute. You are not audible.
Now it is audible? Now audible?
Yes. Now you are audible. Yes.
Okay. Dr. Das, just after you see this management of STEMI during the COVID situation, COVID positive patient, after revascularization, whether it is primary PCI or thrombolysis, you will prefer DAPT, routine DAPT, or vascular dose of rivaroxaban and single antiplatelet therapy.
I think
considering the high thrombotic burden.
Yeah, with the high thrombotic burden, there has not been any guideline regarding the use of the anticoagulant, but definitely the antiplatelet with the DAPT as per the guideline. Though there has been the changes in the guideline to some extent as per the ESC in the last August, whether the single antiplatelet agents can be started after the 7 days or not. But with this high thrombotic burden, especially in the COVID scenario, I think the DAPT should be the standard guideline, which the CSI also followed in their guideline, and that should be continued.
No, you see, Dr. Das, as there is a highly thrombotic condition because high thrombus burden.
Yeah,
anti-thrombotic drugs will be much more better effective than antiplatelet.
Yeah,
even if you use dual DAPT, chance of from stent thrombosis will be very high. So
Yeah,
whether you are going to use the vascular dose of rivaroxaban 2.5 BD plus single antiplatelet.
Yeah, this has been actually not as per the recommendation as yet now in the guideline. But I think there is a scope of using anticoagulation initially, possibly with the low molecular weight heparin twice daily, 60 milligram or 1 milligram per kg body weight, or you can use the rivaroxaban, as you have already said, that 2.5 milligram twice daily. And there has been Commander trial, which has actually highlighted the use of, to some extent, though it was a negative trial, but there is a scope of using it in the COVID scenario, though the guideline has not yet been put
recommended
direction.
Dr. Das, there has been suggestions that NOACs has not only been not recommended, it has been suggested that NOACs better should not be used. If necessary, you give heparin, because then the control will be in your hand. You know whether the dose is high or dose is low. So for first few days following thrombolysis or following PCI, you can give heparin, keeping and watch on the P time and ACT and other things. In any case, thank you. Yeah, please.
I think you should conclude the session. Time is up.
Except that actually the heparin, unfractionated heparin will definitely give age because of the monitoring, but low molecular weight heparin has come of age, and that can be used as well. But so far the rivaroxaban is concerned, which is very commonly used, and nowadays in the thrombotic burden scenario, whether it should be used or not, I think we'll have to wait for a few more months, so in the form of guideline.
Yeah, yes.
Thank you, Dr. Das.
More
Thank you,
randomized
Dr. Das, for your excellent deliberations. A cocktail of literature and science, a cocktail of philosophy and performance, and a cocktail of dedication and service to the humanity.
Mankind.
From your own groundwork, from your own personal experience, you have made certain important comments and observations, and we are proud of that. Thank you very much.
Thank you.
Thank you, co-chairperson. Thanks.
We conclude the session, and I ask Dr. Jayanto Shah to switch over the next session. Thank you, Dr. Das.
Thanks, everyone.
Jayanto is there. Jayanto,
Yes, sir. Sir, I'm here. Next is the inauguration part. So
Good evening to all the esteemed faculties, delegates. On behalf of the CSI West Bengal branch, it is a pleasure to welcome you in the inauguration of Update in Cardiology 2020. We would like to welcome all the dignitaries. I would like to call upon Chairman Reception Committee, Dr. Mrinal Kanti Das, Chief Advisor, Dr. P.K. Deb, President CSI West Bengal branch, Dr. P.S. Banerjee, Honorary Secretary CSI West Bengal branch, Dr. Monoranjan Mondol, Program Coordinator and Treasurer CSI West Bengal branch, Dr. Debobroto Roy, and Organizing Secretary, Dr. Prakash Kumar Hajra, and Dr. Jayanto Shah, Scientific Chairperson of Update in Cardiology. Now, let's start the ceremony with the blessings of the Ma Saraswati.
Good.
Now we would like to felicitate all our dignitaries. Dr. P.K. Deb, the Chief Advisor. Now we would like to felicitate Dr. P.K. Deb, the Chief Advisor of the conference. Then we would like to felicitate Chairman Reception Committee, Dr. Mrinal Kanti Das. Now we would like to felicitate Dr. P.S. Banerjee, President CSI West Bengal branch. Then Honorary Secretary CSI West Bengal branch, Dr. Monoranjan Mondol. Program Coordinator and Treasurer CSI West Bengal branch, Dr. Debobroto Roy, and Organizing Secretary of Update in Cardiology 2020, Dr. Prakash Kumar Hajra, and the Scientific Chairperson of Update in Cardiology 2020, Dr. Jayanto Shah. Now, I would like to request Chairman Reception Committee, Dr. Mrinal Kanti Das, to share his speech with us.
Good evening, namaskar. I have the great pleasure to welcome you all to this annual brainstorming function that is Update in Cardiology virtual platform organized by CSI West Bengal branch. Under the able leadership of Dr. P.K. Deb, Dr. P.S. Banerjee, Dr. Manoranjan Mandal, Dr. Debabrata Roy, Dr. Jayanto Saha, Dr. Prakash Hajra, and all other team members. The intense scientific conversation amongst ourselves will open up new vista of knowledge in this challenging time of COVID-19. I'm sure your active participation will enrich all of us and ensure benefits to patients. Thanks and regards. Long live CSI.
Thank you, sir, for your warm welcome. Now, I would like to request to share a few words with us to Dr. P.K. Dev, Chief Advisor of Update in Cardiology 2020.
Thank you, senior dadas and friends. It's a proud privilege for me to be in the inaugural function of the Update in Cardiology. There was a turmoil whether this year, due to the COVID scenario, whether on there will be the Update in Cardiology. In fact, it was initially postponed. Then it was decided that we will go for the Update in Cardiology in a different way, in a different form, and it is here. I am very happy that at last Update in Cardiology is there, and it is being shown by being presented by Dr. Jayanta Saha and Dr. Prakash Mandal and other guys with great success. I am very happy that it is here, and the program has already been inaugurated. Thank you.
Thank you so much, sir, for your for sharing your thoughts with us. Now, I would like to request Dr. Jayanto Shah, Scientific Chairman of Update in Cardiology, to share your thoughts with us, sir.
Welcome everybody to the Update Cardiology this year. Unlike previous years, this had to be an online program due to the pandemic situation, as we know. I hope we all attendees could brush up our knowledge in the daily clinical practice with this program. And I have tried to include most of our young brigade in the program so that new thoughts could stream in. Now, I would like to express my sincere thanks and gratitude to Dr. P.S. Banerjee, our CSI President, CSI West Bengal Branch, Dr. P.K. Dev, our Chief Advisor, Dr. M.K. Das, President, CSI, Dr. Manoranjan Mandal, the Honorary Secretary, CSI West Bengal Branch, Dr. Debabrata Roy, Program Coordinator and Treasurer, CSI West Bengal Branch, Dr. P.K. Hajra, our Organizing Secretary, for their contribution, for their constant support and guidance in every step for me. I would like to thank all the international, national, and local faculties for their active participation in the conference. I must appreciate the hard work of all our CSI office staffs, especially Adhunika Das, for her serious and sincere efforts throughout. At the same breath, I must recognize the contribution of the industry people for their support and to make the conference a grand success. Last but not the least, I must thank our technical team director, Mr. Raghu, and his team from Club Class for supporting us with creating this virtual platform. Thank you.
Thank you so much, sir. Next, I would like to call Dr. Debabrata Roy, the Program Coordinator of Update in Cardiology 2020 and Treasurer, CSI West Bengal Branch. Sir, please.
Sir, kindly unmute. Sir, kindly unmute.
Sir, kindly unmute, sir.
Sorry. Good evening to all the dignitaries on the dais and off the dais. I'm really grateful to be a part of this fantastic program that has been chalked out by Dr. Jayanto Saha. This has been a great team effort under the mentorship of Dr. P.K. Dev, Dr. M.K. Das, and Dr. P.S. Banerjee. I wish all of you will enjoy the great scientific content that has been assembled under this program. Thank you. Long live CSI and Jai Hind.
Thank you so much, sir. Now I would like to call Dr. Manoranjan Mandal, Honorary Secretary, CSI West Bengal Branch. Sir, please.
Yes, am I audible?
Yes, sir, you are audible. Yes, sir.
Yes, yes.
Good evening to all the dignitaries of the present in the dais of the inauguration and dignitaries of the dais. Actually, update cardiology is just like Vijaya Sammilani of the cardiologist of Bengal and some outside Bengal. This year, by the grace of Corona, we could not assemble for our Vijaya Sammilani physically, but we have assembled virtually. And our update is in the right tune, that all the lectures are of good standard, and it has been program crafted by Dr. Jayanta Saha is very good and informative. I wish the conference all success.
Thank you so much, sir. Now, the very special moment has arrived. On behalf of CSI West Bengal branch, with utmost pride and humbleness, we would like to present the Lifetime Achievement Award to Dr. Avani Kumar Vishwas. And I would like to request Dr. Monoranjan Mondal, please read out the scroll, sir.
This is the scroll. Yeah, I am going to read out the scroll. Update in Cardiology 2020, organized by CSI West Bengal branch. Awarded to Professor Dr. Avani Kumar Vishwas, MS General Surgery, MCH Cardiothoracic Surgery, MNAMS Cardiothoracic Surgery. Dr. Avani Kumar Vishwas started his medical career as an MBBS student of NRS Medical College, Calcutta. He has been a brilliant student and obtained the second certificate of honors in Pan Memorial Anatomy Dissection. After completion of MBBS, he obtained his MS in General Surgery from Calcutta University in 1976. He thereafter trained in cardiothoracic surgery from IPGMR and SSKM Hospital in Calcutta. He obtained MCH cardiothoracic surgery from Calcutta University in the year 1981 and also got MS cardiothoracic surgery from National Board, New Delhi in the same year. He attended 52nd International Circuit Course in Cardiology organized by American College of 1983 and undertook advanced training in cardiovascular surgery of Philippine Heart Center for Asia, Metro Manila, Philippines, and from 1983 and 1984. He started his illustrious career as a teacher at IPGMR and SSKM Hospital and then moved to the Calcutta National Medical College and Hospital, where he served as a lecturer and then as a professor. He has been also a visiting professor of Tripura Medical College and Dr. B.R. Ambedkar Memorial Teaching Hospital, Agartala, Tripura. He also served as consultant cardiothoracic surgeon at K.S. Rai TB Hospital, Kolkata. Presently, he is attached to the consultant and Kothari Medical Center Research Institute. He is an astute academician and has several publications in peer-reviewed journals to his credit. He is a member of West Bengal Medical Council, Indian Medical Council, Indian Medical Association of Cardiovascular and Thoracic Surgeons, Cardiological Society of India, and Indian Medical Association. All through his career, he has been a brilliant student, astute clinician, analytical academician. CSI West Bengal branch is proud to confer upon him the Lifetime Achievement Award 2020.
Hello. Thank you so much, sir. We are proud to felicitate him with the Lifetime Achievement Award. I request Dr. P.K. Dev to hand it over the silver plaque virtually to Dr. Avani Kumar Vishwas.
Done. Done.
Raghu, it's a plaque.
Plaque. Share plaque.
Plaque. Share plaque.
Okay, fine. Nice.
Share shawl.
Yes. Now I request Dr. P.S. Banerjee to present the shawl to Dr. Aboni Kumar Vishwas virtually, sir. Sir, Dr. P.S. Banerjee, sir.
Yes, it's a beautiful shawl, and I deliver it to Professor Aboni Kumar Vishwas and expect him a long life with a good health. Thank you very much.
Thank you, sir. Thank you so much, sir. Now, I would like to request Dr. Prakash Kumar Hajra, Organizing Secretary of Updating Cardiology 2020, to share his thoughts with us.
Hi friends, respected dignitaries, my seniors, juniors, past and present members of the society. And it's a great moment and great opportunity for me to do something for our beloved society and the prestigious society internationally recognized. And it's a time to thank all the supporters, starting from Adhunika to Professor Deb, Dr. Banerjee, all I'll be repeating. Some could not participate in this program because of their physical reasons, but I'm sure their blessings are with us. And in the virtual platform, it's my duty to say thanks, but thank you all from a different pharmaceutical sponsorship like AstraZeneca, Sun Pharma, Torrent, Cerdia, and other industries. I'm sure it is a great moment for all of you to acknowledge the new informations on the virtual platform. And it gives me immense satisfaction to be associated with these prestigious organizations. And with the full guidance of my seniors, it was only possible to deliver a successful mission. But in spite of that, there will be some lacunas, some deficiencies. Please excuse the whole team for that. I'm sure with time we will learn, because this is especially a different kind of a new normalcy. And with time we'll gather more knowledge, more expertise, and wish the whole CSI a grand success. Happy Diwali and Bijoya greetings, my namaskar, my pranam to all of you. Thank you very much.
Thank you so much to all the dignitaries to enlighten the inauguration ceremony with all of your presence and participations. Thank you so much. Now,
can I move on to the next session?
Yes, now we are moving to our next session, and the session is valves, and I would like to request the chairpersons and the moderators to proceed the sessions. The chairpersons are Dr. Ravindranath Chakraborty, Dr. Kunal Sharkar, Dr. Alok Mujumdar, Dr. Aniruddha De, and the moderators are Dr. Devdatta Bhattacharya, Dr. Devika Chatterjee, Dr. Satyajit Bose. So please proceed the sessions.
Thank you.
You ask Jayanto to start the session. Jayanto is there?
I'm here, the session.
Start the session.
Dr. Rao is here. Dr. Rao has joined?
Yes, sir, joined. Yes, joined, sir.
Join, sir.
Dr. Devdatta Bhattacharya is here. Dr. Devdatta Bhattacharya?
Yes, I am here.
Yes, sir, he is joined.
So let us start the program.
Okay. So this is a 1-hour session that is dedicated to valvular heart disease. And can you hear me all?
Yes, sir. Yes, sir. We can hear you.
Okay. So, and the first lecture is by Dr. Ravinder Singh Rao. He is very well known for as an expert in structural heart disease and complex coronary interventions. At the moment, he is working as.
Thank you so much, sir, for taking my name, sir. Thank you.
At the moment, he is the director of TAVI in EHCC Hospital in Jaipur, and he is a senior interventional cardiologist there as well. So I invite Dr. Ravinder Singh Rao to begin his lecture. So the lecture is in 2 parts, but I would request him to finish within 20 minutes so that we have 5 minutes for discussion in the end, and then we will go to the other presentations of this session. Dr. Rao, the screen is yours.
Good evening, Dr. Bhattacharya, and good evening, everyone and all the esteemed panelists and chairpersons. At the outset, I would like to thank the CSI West Bengal organizers for making me a part of this program and academic agenda. Without wasting any further time, I would start with my topic, present status and future directions. And also there was a talk about step-by-step TAVR. So, this can be really long. So I've tried to mix my slides so that we try to finish it on time. Can you all hear me, sir? Can you hear me?
Yes, sir. Yes, sir.
Yes, we can hear you.
Right. So this is one of my favorite slides which I like to share with all the audience. That which of the following is the most deadly disease? Severe inoperable aortic stenosis, lung cancer, colorectal cancer, breast cancer, ovarian cancer, and prostate cancer. The 5-year survival rate of severe inoperable aortic stenosis is 3%, which is dismal and carries a poor prognosis than majority of these malignancies. That means there is no medical management for aortic stenosis. This is the whole spectrum of aortic stenosis which we see in our clinical practice. There are patients who are low risk, intermediate, and high risk. Let me explain what is this risk about. This risk is about the chance of a patient dying during the surgery. So when a patient comes with a valvular heart disease to us, we evaluate his possible mortality rate if that patient was supposed to undergo an open heart surgery. I'm not going to go into detail because we all are very well aware of the intermediate and high risk data, how TAVR was non-inferior to surgical AVR, and this led to the US FDA approval of TAVR even in intermediate and high risk patients. Now we have data even in low risk patients, NOTION trial, PARTNER 3 trial, and low risk Evolute Art trial. So even the low risk trial, TAVI was non-inferior to surgical AVR. In fact, the transfemoral TAVR was statistically superior than surgical AVR. But this is again a very interesting slide. Sometimes when we see patients at clinical practice, we feel that, the STS score is high, so probably this patient will do better with TAVR. But let me tell you, the mortality is directly related to STS score. What does that mean? That irrespective of aortic stenosis, these patients will die from their comorbidities. And this is actually what was seen in the low risk trial. So if you look at the TAVR mortality or TAVR complication rate was lower in the low risk trial compared to the high risk trial, because in the high risk trial, the patients carried so many comorbidities, they succumbed to them and not to aortic stenosis. And that is why the survival was only 50% at 5 years in patients who were enrolled in PARTNER 1 trial. That doesn't mean that TAVI patients will die in 5 years. That just meant that patients had so many comorbidities that they succumbed to them. So this is again which shows that the transfemoral TAVR was not inferior to surgical AVR, and that is why more than 90% of the TAVRs at present are being done by transfemoral approach. But this is the data from the latest PARTNER 3 trial, which is actually a low-risk trial. So you see in the TAVR patients, death from any cause of stroke was 8.5%, surgery 15.1%, stroke rate 1.2% in the TAVR, surgery 3.1%. So this was a big myth. The stroke rate was more or higher in the PARTNER 1 or the high-risk core valve study, because those patients were having a lot of comorbidities, and the device which were used was 18 French, 20 French, 22 French. With the late generation device, which is 4 French and steerable catheters and more flexible devices, the stroke rate has come down. Permanent pacemaker with the balloon expandable Sapien 3 valve was 7.3%, surgery 5.4%, and new atrial fibrillation in TAVR patients 7%, surgery was 40.9%. So clearly the TAVR was not inferior to surgical AVR even in low risk patients. These were the type of patients which were being treated with TAVR in 2007. At present, we would not like to treat these patients with, with aortic valve replacement. Sorry, this slide I have borrowed from someone, but this is how we want our patients in 2017 onwards, when the patients were being enrolled in the low risk trial and they are purely percutaneous conscious sedation, no central line, no Foley's approach. So patient procedure planning and careful selection is very important. And this is I've mixed something like a step-by-step also. So the most important thing when we evaluate a patient for TAVR is, can the procedure be done by transfemoral approach? Remember that I had shown that the TF TAVR is actually better, statistically superior than surgical AVR. And then based on the femoral axis, I would sometimes go ahead and choose my device, because there is a certain device which can only go from the smallest femoral artery. So when you plan the procedure, you look at the patient characteristics, vessel size, valve size, and what type of sedation method will be used. Again, as I said, this is very important. Your ultimate goal has to be a transfemoral TAVR at present and under conscious sedation. So obtaining a femoral axis is the most important. Safely obtaining the femoral axis is one of the most important step in TAVR. It has to be a single anterior wall puncture. It can be a fluoroscopy guided. It can be a pigtail guided. It can be a road map or an ultrasound guided, but very important. And then you can put a stiff wire to look at the tortuosity of the vessel. And here you can see how you advance a big size sheath always over a stiff wire and under fluoroscopy examination. Next step is the aortogram. The angle of the aortogram is a CT scan derived angle. And here you need to find a coplanar view. You can follow the right cusp rule if all your three cusps are not in a straight line. Then crossing the valve, the LAO view or the sometimes AP view or an RAO view, but most preferred view is the LAO view, and an Emplatz family of catheters. It could be an AL1, AL2, AR1, AR2, depending on the route and the angulation. And you orient the Emplatz catheter towards the jet, and you can use a straight tip thermo wire or a straight tip Teflon wire. But this is my, I use AL2 for a bicuspid and an AR2 for a tricuspid valve. But this is very important. Everything has to be in your field of view, and then you advance your catheters. The next one is you exchange for a stiff wire, and this has to be done by using a pigtail, and this is how it shows you how you can assess the horizontal. If the level of pigtail and the level of your stiff wire is the same plane, then it's a horizontal aorta. And then you can choose your valve. There's a pre-dilatation. You can use a balloon to pre-dilate the valve, and the pre-dilatation balloon is equal to or smaller than the size of the short axis. And when you do a rapid pace, pressure decreases, inflate, deflate, and stop pacing. But make sure before you do a pre-dilatation, your valve is prepped and ready to go. And then when the valve is going across the arch, this is an example of a Sapien 3 valve, you make sure such type of calcium might be present, and your valve can go and hit that calcium, and there can be an ascending aorta or an arch dissection. Very important, the wire in the LV and the valve advancement across the arch has to be in the field of vision. And then once you cross the valve, you position the valve in such a way, like this is an example of a Sapien 3 valve, and you do a rapid pacing, the blood pressure goes down, you inflate, you deflate, and you stop pacing. And this is, then you remove the pigtail and you do hemodynamics. And this is just an example of how a TAVI can be done in an extremely horizontal aorta, where you see the Sapien 3 valve has been implanted in the annular position. So what about a self-expanding valve? This was step-by-step of a balloon expandable valve. The CT scan is must. So you look at the annular size, you look at the short axis dimension, long axis dimension, and various other features which could be present in patients with transcatheter in their heart. So this is just an example where a patient had an LV apical clot, and now patient was going into heart failure. Despite giving 4 weeks of anticoagulation, the clot still persisted, and that is because there was stasis of blood. This was a TAVR done by putting spider filters, and this is how a self-expanding valve is deployed. You don't need a rapid pacing, but you want to deploy them as high as possible, and then you go a slow release once the valve makes anchoring position, and then you go ahead and release. So the reason I wanted to show this example here is because now even the self-expandable valve, you want to deploy them as high as possible so that there is no complete heart block. Then we also come across patients who have coronary artery disease, and then it's a very difficult situation. Do you do TAVR or coronary artery disease first, or TAVR first, or both in the same sitting? We have been doing both in the same sitting, and now almost around 25 cases where I've done PCI plus TAVR concomitantly, and we haven't seen any red flags. What about patients with presence of mechanical mitral valve? Again, you have to be very careful in what type of valve you choose, because if the valve obstructs or interacts with the mechanical mitral valve, the leaflets can be obstructed and the mechanical mitral valve might not function. So this is an example of an evolute R in presence of a mechanical mitral valve. All cases are being done under conscious sedation. This example I have chosen, which is going to help us to understand what are the complications which can happen in a TAVR and how to choose a valve. So 84-year-old patient, severe AS, LV dysfunction, COPD, diabetes, prior PCI, EF is around 20%. You can see a valve area of 4.4. But this patient has a baseline trifascicular AV block. Now, suppose this patient develops a complete heart block post-procedure and requires a pacemaker, his EF will not recover. And bad CAD. So very important for us to understand how much CAD to revascularize, because in these elderly patients, sometimes it is the aortic stenosis which is causing them symptoms. So to throw some light on the CT scan, it is very important to identify the coplanar angle. So this is an example of a concomitant TAVR and PCI, a 14 French axis. In the right common femoral artery, ProGlide, 6 French left common femoral axis, BAV, PCI, TAVR, and PCI of left main LED alone. The reason why we do this is, suppose a patient of TAVR develops a hemodynamic compromise, only way to revive him is to fix the valve. So this is a BAV with a small balloon, and then a cutting balloon PCI of left main, and then a SAPIEN 3 valve, so that you can avoid a pacemaker implantation in this patient. There can be a lot of discussion which you can discuss later on, how you can avoid rapid pacing in a patient who has LV dysfunction. So this is how at present we do TAVIs. There's local anesthesia, no Foley catheter, no central line, percutaneous and femoral. So how we have advanced now, this is an example of a transcatheter double valve replacement, a valve-in-valve in the aortic and a valve-in-valve in the mitral position. So presently we would replace the aortic valve first, and this is an aortic valve being replaced with an evolute R valve and a coronary protection. The reason you want to do this is because you replace the mitral valve first. Mitral valve is going to project into the left ventricular outflow tract, and that can cause obstruction. So this is an evolute R valve which is being used for a valve-in-valve in aortic position with coronary protection, because the valve which is there is trifecta and it can occlude the left main, the coronary arteries. For a valve-in-valve procedure, you need to do a post-dilatation to optimize, either by doing a fracturing or by doing expansion of the annular frame. And then a transseptal SAPIEN 3 is being deployed inside a mitral valve and inside the tissue valve. This few steps which are important here is a balloon atrial septostomy, very important. And then this is flossing. You would advance the inflated balloon from IVC across the mitral valve annulus, mitral valve prosthesis, to make sure the valve doesn't get stuck. And then the SAPIEN 3 is being deployed in the mitral position in valve under rapid pacing. So this is how a transcatheter double valve replacement looks like. Post-procedure, you can see a balloon expandable mitral position and a self-expanding evolute R position. This is a valve which I did it in the MAC position, mitral annular calcification. We discharged the patient on 4th day. Patient has a history of radiation because of Hodgkin's lymphoma and had a forcing aorta. So these are the all advancements which we have progressed now from doing simple TAVRs to valve in valve, and now also mitral valve in MAC. But very important for the success of procedure, the patient's characteristic and proper patient selection is very important. So this is, I would like to share our experience of TAVR and its outcome at a single center here. This is our pre-procedure workup, pre-TAVR, peri-TAVR, and post-TAVR. This is the whole profile of patients. Average age is 72, 36% are female, 63% are male. All patients were symptomatic. Some patients had baseline abnormality, but interestingly, 31% of patients had bicuspid aortic stenosis. And this is what people have observed even in Southeast Asia, where close to 30 to 35% of patients have bicuspid aortic stenosis. All patients were done under conscious sedation. Mean procedure fluoroscopy time was 24 minutes. Mean procedure time was 61 minutes. Mean contrast volume 82 ml. Pre-dilatation was done in 54%. All were done percutaneously using a ProGlide. No surgical cut down was required pre or post. Intra-procedure death was 0. Majority of patients got 23 or 26 mm valve, and 2 patients required femoral artery stenting. All-cause mortality was 1, procedure mortality was 0, stroke was 2, disabling stroke was in 1 patient, 0.9%, non-disabling stroke was 0.9%, pacemaker implantation rate was 5.7%, severe PVL 0.9%, and 87% of patients had no PVL. Average ICU stay 26.4 hour, average hospital stay 5.4 day. Again, this is the graph representation of the outcome. The mean gradient decreased from 47.5 to 9.03, and peak gradient decreased from 75.7 to 16. 6 patients who received pacemaker out of 105, 3 had trifascicular AV block, 2 had atrial fibrillation, and 3 received self-expanding valve, 2 received SAPIEN 3, and 1 received MAIA valve. We also compared our outcome with the standard low-risk trial, that's PARTNER 3, Evolute, and Notion. The average STS score of PARTNER 3 was 1.9, Evolute R 1.9, Notion 2.9, and our STS score was 3.9. Permanent pacemaker implantation rate 6.6% in PARTNER, 17% Evolute, Notion 34%, 5.7%. Mortality was 0.2 for PARTNER, 0.5 for Evolute, 2.1 for Notion, so 0.9. Stroke was 0.6, 3.4, 1.4, and 1.8. And moderate to severe PVL was 0.8, 3.5, 15.3, and 1.9%. Thank you very much for your kind attention. I think rest all we can have a discussion, because otherwise this topic becomes very lengthy. Thank you all the organizers, and thank you all the chairpersons and esteemed panelists.
Okay. If you can, all right. Thank you, Dr. Rao. That was an excellent speech. So I think we might have some chairpersons with us. Is Dr. Kunal Sarkar here? Dr. Kunal Sarkar, is he present? Dr. Jayanto Shah, is Dr. Kunal Sarkar present? Would you like to?
I don't find him here.
Okay, is Dr. Ravin Chakraborty present?
No, sir won't come. Sir is somewhere else.
So, okay, so it is, the session is now.
You continue.
The session is now open for questions. Would you like to ask anything, Jayanto? And then I will have a couple of questions maybe. And if there are any other questions, can you put it in the chat box so that I can follow it up?
Hello? Hello?
Yes, Dr. Kaur.
Can you hear me?
Yes, we can hear you. If you have a question, go ahead.
Yes. I have got one question to Dr. Rao. Now, Dr. Rao, you said that 1/3 of the patients are bicuspid aortic valve. And we know that bicuspid aortic valve, regarding the alignment of the aortic valve, regarding aortopathy, is a complex situation to put it. So how you tackle the situation in bicuspid aortic valve? in 1/3 of the patients?
So that's a very good question, sir. So bicuspid aortic valve, there was a latest study which was published in JACC. So when the first generation TAVR was used, the outcome in bicuspid aortic valve was poorer compared to the tricuspid aortic valve. But with the latest generation valve, where there is a skirt on the outside, the frame is higher, the valves are repositionable, the outcomes in bicuspid valve are comparable to the tricuspid valve. But few technical details which I am always interested in when I'm doing a bicuspid aortic valve is what type of bicuspid is it? Type 0, type 1, type 2. Type 0 is fairly, I would not say easy, but kind of fairly straightforward because there are two equal sized cusps with an opening in the center. The challenge happens in type 1 and type 2 where two of the cusps are fused and the opening can be very eccentric. The number 2, which I am interested in, the disease of the aorta. What is the size of the aorta? So if a patient has an aortopathy, clearly they are not a candidate for a TAVR so sometimes you would come across bicuspids where patients are inoperable. So then we would do a TAVR. Otherwise, they should undergo Bentall. So clearly you need to look at the ascending aorta size. You need to look at the morphology of the bicuspid. You need to look at the LVOT calcium. But last comment, sometimes a bicuspid valve can be low risk for surgery, but it can be a high risk for TAVR, depending on the anatomy. So we have to be very careful. The low risk patient does not mean low risk for TAVR. Anatomically, that can be a high risk for TAVR if there are certain challenges involved.
Dr. Rao, Dr. Panja here, Dr. Devdatta.
Good evening.
Good evening. Which valve record the lower incidence of need for pacemaker implantation? Which valve now at current data?
That's a very good question. If you ask me the data, so at present the data of Merrill MyValve shows the lowest pacemaker implantation. That is not only in India but also in Europe. The number 2 is Sapien again, and number 3 is Evolute R. But at present, in the past 1 year, the technique of deploying these valves is changing. So we are deploying them very high. So remember, it is the pacemaker implantation is not happening due to the valve. The pacemaker implantation is happening because a certain type of valve tends to go deeper into the LVOT and interfere with the conduction system. If we are able to deploy all valves very high, almost at zero position and above, at the level of annulus, the pacemaker rate is low. And that is what I showed for my own data set. The pacemaker rate is equal in balloon expandable and self-expandable.
Next question, which valve is more durable than any other valves? More durable?
So at present, we have data only on Edwards Sapien 3 and on self-expanding Evolute R. So both the valves have lasted as long as their surgical counterparts. We have data up till 8 years. Surprisingly, the Notion trial involved the Evolute R or the core valve. At 6 years, the degeneration in the surgical valve was 28% and the degeneration in the TAVR was 6.8%. The Indian valve, we don't have very long-term data. So at up to 8 years, both the valves have lasted equally long. But now the scenario will be very interesting. What happens beyond 8 years? Because one leaflet is a bovine pericardium with anti-calcification, another leaflet is a porcine pericardium with anti-calcification. One leaflet is intraannular, which might be affected by the annulus. Another leaflet is supraannular, which is protected by the movement of the annulus. From now onwards, we need to wait for the data.
Okay, thank you very much.
Okay. Any other questions from any of the other experts? I hear that Dr. Devika Chatterjee has joined. Devika, do you have any questions regarding echocardiographic assessment prior to TAVR? Devika, can you hear me?
Yes, I can hear you. It was a very, very nice presentation, Dr. Rao. I must congratulate you. I want to know one thing. Do you use transesophageal echo part procedure Like here in our institution.
No. So at present, there is no. So the transesophageal echo was used back in 2010. Why do we want to go 10 years behind the back and then start? At present, there is no role of transesophageal echo for TAVR implantation. The only TAVR which I have done by TEE is a contrast, zero contrast TAVR. This patient had a renal transplant and the baseline creatinine was 2.5. So I did a TEE upfront to do the annulus measurements by doing a 3D TEE. But if you ask me, there is no role of TEE during TAVR. The only indication of TAVR, TEE is if you want to evaluate the mechanism of paravalvular leak post-TAVR.
Right.
What circumference is involved, where it is involved. Otherwise, no, it is not required for procedural steps.
So if you suspect a paravalvular leak, what do you go for? Like transthoracic echo? Because patient is in that position, an aged patient with low, echogenicity and optimal images.
So
how do you tackle that?
There are three ways to assess the paravalvular leak. Number one is hemodynamics. Number two is aortogram, and number three is the echo. So I'm more of an interventionist, so I would rely on first two. So what I would do a hemodynamic assessment. I would calculate the AR index. AR index is the difference between the LV/EDP and aortic diastolic pressure divided by 100. If it is more than 0.25, there is no significant AR. Number two, I would take an aortogram. But let me tell you, we need to understand the mechanism of paravalvular leak. Even while I'm deploying the valve, if I know that my valve has dived in, I will have a paravalvular leak, and that can only be corrected by putting another valve. Or if my valve has embolized, or upfront, I know from the CT scan that there is a calcified chunk or at some position in the annulus. So, you need to anticipate and plan that what would be the region of paravalvular leak. If the valve is implanted in the right spot and the sizing is done based on CT scans, with the use of latest generation valves, we rarely see any significant paravalvular. But to answer you, I rely on these two things.
Okay, thank you, Dr.
Okay, thank you very much. That was wonderful, Dr. Rao. And we are coming to the end of this session. Dr. Rao, don't go away, because at the end of the whole session, if there are any other questions, you can answer them. For now, we are going to the second lecture of this session. So, Dr. Shah, will you please invite the speaker?
Thank you so much.
Devdatta Majumdar. Yes, join. Devdatta Majumdar.
Yes, sir, joined.
Please start your session.
Is the moderator there in the session?
I am
okay, you are the moderator. Go ahead, Devika. Sorry.
Devdatta Majumdar is going to speak on the echocardiographic challenges and pitfalls in multivalvular heart disease, which is a real challenge because most of our guidelines are on single vessel valvular heart disease. And moreover, there is a change in the pathophysiology impacting the hemodynamics. So it's a real problem, and a problem for decision making, problem for timing of intervention. So let us hear from Dr. Devdatta Majumdar, who is an interventionist in Rabindranath Tagore Hospital in Calcutta, with a knack for echocardiography. So he's the right person to talk on the pitfalls of echo for assessment of multivalvular heart disease. Let us listen to him.
Yeah, good evening to all of you. Respected seniors, teachers, it really has been a matter of immense pride and privilege to be sharing this platform with the doyens of cardiovascular medicine. Thank you, madam, for those kind words of introduction. I would prefer myself to be called as a holistic cardiologist with a keenness for maybe both intervention as well as echocardiography. I am a learner in both the fields, so I'll try to do justice to this very important topic of what are the likely pitfalls of multivalvular assessment when we do it by echocardiography. We know that in spite of the pitfalls, echo would continue to remain as the most common and the most important imaging modality when we speak of, given its easy accessibility and knowledge, that would be the imaging method of choice. But there are pitfalls that we know, and I'm going to discuss on some of them given the time that I have. So just to introduce, we know that my talk would be limited to multivalvular heart disease and not maybe on mixed valvular heart disease, again due to lack of time, sake of time. So multivalvular disease is a combination of stenosis or regurgitation, or both of them on 2 or more valves of the heart, which is well known. And multivalvular heart disease is mostly acquired, then congenital is again well known to all of us. And the European Heart Survey has revealed, and it is almost akin to what we encounter in our day-to-day practice in our own country, that rheumatic heart disease continue to be the predominant reason behind multivalvular heart disease, closely followed by degenerative valvular heart disease. So the reason this topic was brought forward, I feel, is there's no pitfall as far as diagnosing individual valve disease is concerned by an echocardiography. Echocardiography again continues to be the main modality of imaging. The pitfalls only stems from when you speak of assessing the severity of individual valve disease, and it is important that we assess the severity of individual valve disease because that actually guides our management strategy. So what are the hemodynamic factors from which, from which the pitfalls of echocardiography stem from? And these are the factors that we tend to encounter in echocardiography when we try and assess the severity in a given multivalvular scenario. One is a low flow, low gradient stenosis, which I would try to highlight. Mixed valve disease may be associated with increased antegrade flow and gradient if we are relying on Bernoulli's principle, I would like and highlight. So the continuity equation, which is a very, very important equation that we rely on to assess valve area in the aortic and mitral especially, is inapplicable when we know that the transvalvular flows are unequal. Any severe valvular heart disease, I'm speaking of mostly severe semilunar valve disease, stenosis of the aortic or the pulmonary valve may induce or increase upstream secondary mitral valve or tricuspid valve regurgitation. And very importantly, the commonly used pressure half-time derived methods may prove to be invalid in the presence of in multivalvular heart disease, where we know that the LV compliance is altered. So we would like to speak on every one of them. So just to begin with examples, that when you speak of how does aortic valve stenosis affect the quantification of mitral valve regurgitation, these are the common caveats that we encounter by an echocardiography, that we know that because of the increase in LV systolic pressure, there would be an increase in mitral regurgitant volume. So that might obviously overestimate the degree of regurgitation. Another thing is obviously that would also increase the area of MR-jet using color flow mapping. But what would be relatively unaffected, we know, is the mitral, the EROA, the effective regurgitant orifice area, which is done most commonly by a PISA method. So the solution to that would be, so we either use PISA echocardiographically to have an exact estimate of MR severity and not rely much on the regurgitant volume, the fraction, and the color flow area. But the best way forward in today's era, when you are speaking of assessing the severity of regurgitant valve lesion, that has to be the gold standard cardiac magnetic resonance. I would spend a slide or two on how do you do that in a cardiac MRI. This is just a pictorial representation of what I already said, that due to the presence of AS, there's an increased transmitral gradient, and you tend to overestimate the severity of MR when you rely on the flow area and the regurgitant volume, but not when you rely on EROA derived from the PISA method. The other way around, what effect does mitral valve regurgitation have on quantifying the severity of aortic valve stenosis? And we can understand that due to the presence of MR, obviously the net amount of forward flow through the aortic valve would be reduced, and you tend to produce what is known as a paradoxical low flow, low gradient aortic valve stenosis. So obviously, these are the pitfalls that we have in echocardiography. Just a pictorial representation. One more obviously is that when you have both systolic streams in the form of aortic stenosis and mitral valve regurgitation, we tend to at times confuse between the two. But there's no reason why we should be confusing it, because we know MR is a holosystolic flow, and the spectral Doppler gradient is much more than what is found in aortic stenosis. And you have the isovolumetric phases spared. It is only an ejection timing which is there in aortic stenosis. But these are the pitfalls, definitely, that both the jets can be mistaken one for the other. But we said that is not a major problem. We also said that the presence of MR would give rise to a low flow, low gradient aortic valve stenosis. And the way forward is that if you have to exactly assess the aortic valve severity, the aortic stenosis severity, the best way forward is to do a MDCT, planimetry of the aortic valve by an MDCT, or by looking at the calcium scoring. We know that if it exceeds around 3,000 units in males and 1,600 units in females, it is almost very likely that you're dealing with a severe aortic valve stenosis. So if you are dealing with a regurgitant lesion, the way forward has to be a CMR. And if you're dealing with a stenotic lesion, mostly the aortic valve stenosis, the way forward is a CT. Now you deal with two stenotic lesions of two left-sided valves, and we can understand what, and we would like to see what effects one has on the other. As far as pressure half-time calculation is concerned, we know due to the increase in LVEDP, the mitral valve pressure half-time would tend to be less, and you would tend to underestimate the severity of the mitral valve stenosis. I mean, you would overestimate the valve area if you're relying on pressure half-time in the presence of aortic valve stenosis. So that is one of the caveats. And we also said that the presence of mitral valve disease on aortic stenosis is that you create what is known as a low flow, low gradient MS with a preserved EF, also known as a paradoxical low flow, low gradient aortic stenosis. And we said the best way to assess aortic valve area there is a CT scan, either by a Argardson score or you do a direct planimetry. By the way, direct planimetry of the aortic valve can also be done by a 3D echo, either transesophageal or transthoracic. So these are the solutions of the likely pitfalls that we have in these combinations. The other way around, mitral valve affecting aortic valve, we already said, just a continuation of the low flow, low gradient concept, and we already spoke of the solution. Now coming to a regurgitant and a stenosis lesion, that how aortic valve regurgitation would affect MS, one thing is certain that both are again diastolic flows, and one jet can be confounded with the other. The continuity equation is unreliable to calculate mitral valve area, though continuity is most commonly used for the aortic valve. But when the transvalvular flow is unequal, secondary to the presence of AR, you cannot rely on continuity equation to calculate mitral valve area. There, of course, you have to choose another valve which is devoid of regurgitation, and the RVOT would be a better option than, provided you don't have a shunt lesion also coexisting. So these are factors which confound. So MS pressure half-time, we already mentioned that you have AR, the decline of the gradient is rapid, and you tend to overestimate the valve area and underestimate the severity of mitral stenosis when you use the pressure half-time. And the way forward is, so when you are speaking of assessing exactly the mitral stenosis area, the planimetry is a better method compared to the others, and if it ideally can be done by a 3D echocardiography, is the gold standard of assessing the severity of mitral valve stenosis. As we already said, that if aortic valve cannot be used for the continuity, we can jolly well use the pulmonary valve, because we understand that to use the AV valves is more problematic echocardiographically, because we understand that the tricuspid as well as the mitral annuli moves more during systole compared to the semilunar valves. So whatever has to be done, the priority is on the semilunar than the AV valves. Now coming to both regurgitant lesions together, that is AR and its effect on mitral valve regurgitation. Yes, because both are having regurgitant lesions, you can't rely on volumetric methods, so continuity equation doesn't hold true here. Another, that when you use the VTI ratio between the two, again, is unreliable. So when you speak of aortic regurgitation along with MR, we said previously also with AAs that PISA is a method as well as vena contracta to assess the mitral regurgitation severity. So the parameters which are less affected by the presence of AR is the PISA method, unless, of course, very rarely you have a posteriorly directed jet of aortic regurgitation, which is hampering the measurement of the PISA, or else you can have a very, very severe MR which might confound the assessment of PISA. Otherwise, more common than not, PISA method calculating the EROA as well as the vena contracta of MR gives you a fair idea of the severity in spite of the presence of aortic regurgitation. But we also mentioned that to assess the best way of assessing the regurgitant severity of regurgitant lesion today's date has to be a cardiac magnetic resonance, CMRI. So that's just a pictorial representation of what we said. If you have a regurgitation of only one valve, obviously continuation does hold true. In trying to exactly assess the regurgitant volume, by utilizing this principle of stroke volume of the mitral is equal to the stroke volume of the aortic, but it is not true when both of the valves are showing a regurgitation, and there is only one of the solutions would be when you use a right-sided valve, preferably the pulmonary valve, or you can directly measure forward and reverse flow exactly by a CMRI. And the method used we will discuss is what is known as a phase contrast velocity mapping. So just a few examples before maybe ending my talk is one of them is a young female with an aortic stenosis and mitral valve stenosis presenting with symptoms. And we can see here that both tends to be underestimated. Each one underestimates the other. When we had used the PHT, the valve area was, the MVA was 1.65. The area was overestimated. The stenosis severity was underestimated. But when you did a planimetry, you can see jolly that the exact valve area was 1.2. The same happened with the assessment of aortic stenosis. When you had a very low gradient, the peak gradient as well as the mean gradient doesn't confer with severe aortic stenosis, whereas the patient really had a severe aortic valve stenosis when we did it by CT scan. So when you have both stenosis of these two valves, both tend to be underestimated. This is one of the major pitfalls that we encounter by an echocardiogram. Example number 2, where you have a mixed aortic valve disease along with mitral valve regurgitation, and which depicts that the ejection fraction is maintained, preserved, the aortic valve is calcified, and you have a posteriorly directed jet mitral valve regurgitation. We can see a zoomed view where we are trying to measure the continuity equation to assess the aortic valve area. The gradient across, due to the presence of MR, is obviously less compared to the degree of, you can see the severe calcified aortic valve leaflets. So we are hence underestimating, if you are using the gradient method, the valve area by continuity was around 0.75, conferring to a severe AS. But when you did a CT scan, the gold standard method, the exact area was, the severity of regurgitation decreased, but you had a, an Agarson score of around 2,300, which actually showed that he is having a true severe aortic valve stenosis. So when you have to assess best way aortic valve area, planimetry of the aortic valve by a CT or looking at the calcium score is the way forward. And the third example is actually a rheumatic mitral and mixed mitral and aortic valve disease, where you have aortic valve regurgitation along with the mitral valve stenosis. Here we can see that if you are relying on the pressure, the pressure half time, the mitral valve area is around 1.5 centimeters square. So it tends to overestimate the mitral valve area and rather underestimates the severity. Whereas if you are using a planimetry by a 3D echocardiography, the exact valve orifice is 1.1 centimeters square. So that again proves that the best way of assessing mitral valve severity is to do a 3D planimetry, 3D either transesophageal or transthoracic.
We've got 1 minute left.
Yeah, I only have one slide, thankfully. So maybe 2 slides. So the primary modality, in spite of all limitations, is still echocardiogram, and it would continue to be an echocardiogram. The secondary solutions we said can be either CT scan or an MRI. We mentioned that the role of CT scan in the assessment of aortic valve stenosis severity. I would end my talk by just showing this, that the best way of imaging, assessing the severity of regurgitant lesions, more for the aortic and maybe a bit less for the mitral, but both can be done by this. This is what is known as a phase contrast velocity tracking, where you do up, the point of interest is just distal to the aortic valve leaflet in the ascending aorta. You have an anatomical image in place, you have a physiological image in place, and then you try to assess the velocity with each pixel of this image, and then to try to have a tracing of this type, where this is the forward flow across the aortic valve, and this is the regurgitant flow, the presence of aortic valve regurgitation. You can see the forward is 138, the reverse is 70, so the regurgitant fraction is around 51%. This is across the aortic valve. So the best way to assess aortic regurgitation severity as well as MR severity is this method, which is devoid of any confounding variables. We are aware of the limitations of CMRI, but that remains as the gold standard beyond echocardiogram. So thanks again for the opportunity. It was an honor to be presenting in this forum. Thank you.
Devika, please take over.
Yeah, thank you, Devdatto, for a beautiful presentation. You have covered everything. I think we are running short of time. So
No. You can have a 3-minute discussion here, and Dr. Bhattacharya is there. You can bring back the discussion after.
At the end of the session. At the end of the session, after Dr. Sukhan Mukherjee has talked, then after that.
Okay, fine. So no question now.
So at the end of the session, after Dr. Shushan Mukherjee has given his talk. Dr. Mukherjee?
Yeah. So I'll share my screen, I think. Are we seeing? Yeah. Just a minute. Just a minute. Is my screen seen?
No, sir. No, sir.
Are you?
So kindly
Again.
open your PPT and then.
Yeah, I opened it. Just a minute. Yeah, it's coming. Just a minute. Yeah. Share. Do you see? No?
No.
Not yet.
Sir, alternatively, you can share the presentation with us. We will share it on your behalf. If you can put it to us on WhatsApp, that's also good.
No. Don't do that.
No, we are just.
Maybe Devdatto is still sharing. Can you stop sharing, Devdatto?
No, sir. No. Already we stopped. He stopped.
Okay. I'm here, but closer. My presentation is open.
Yeah, so your presentation or is your presentation open in your desktop or any other folder?
Yeah, on my desktop. Can you see?
Okay. No. Can you click the green share button?
Yeah, now you can see it.
Now you can see it.
Sorry for the inconvenience. And good evening, everybody, and thanks for the opportunity of presenting this talk. This is about functional tricuspid regurgitation, often the ignored valve till late when it was found that the tricuspid valve is of metal, actually. You can't ignore this valve when you're treating various diseases. If you look at the tricuspid valve, it has 3 leaflets and is surrounded by various important structures, mostly anteroposterior, anterior leaflet, the posterior leaflet, and septal leaflet, which has a sinus of Valsalva at one end and the coronary sinus at the other end, and bundle of is an IV node. But if you look at the anatomy, the tricuspid annulus has a bimodal shape with an anteroposterior high points and mediolateral low points. So this is important to know the structure in real-time 3D echocardiography, because it will determine the presentation of tricuspid valve pathology if it is seen. So what happens is, in a normal tricuspid valve, or if it's motion, it's usually there is a perimeter contraction, there is expansion contraction at the anteroposterior level, and there is a saddle shape change in the long axis motion, which are the 2 axes of motion. But how does the functional TR happen? There are few factors that are variable contributors for functional tricuspid regurgitation. One is the preload, the ventricular end-diastolic volume, the afterload, the impedance to ventricular emptying, and the right ventricular function. These 3 are variable factors, whereas a tricuspid dilatation, which can be measured objectively, is actually one important aspect that can also contribute to the functional TR. Yeah. So if you look at the annular dilatation, that often happens in the anteroposterior segments, and gradually the annulus dilates, and it causes, this is a cardiologist's definition and the surgical definition of an annular dilatation. But what we look on the table, when we look at it, we usually measure the anteroposterior, the commissure between the anteroseptal and the anteroposterior. So this is a surgeon's view, whereas the cardiologist would measure a different view of the valve to look at the diameter. With functional TR, what happens is the annulus becomes larger, it becomes more planar and circular, and causes the regurgitation. How do we assess the TR? The echo assessment for a functional TR, usually it's an apical force chamber view where the diameter as well as the tethering height is measured, and another aspect is measuring the tethering area. So these three aspects are drawn by an echocardiographer to see the add into the knowledge of functional tricuspid regurgitation. Now, this was a landmark paper by Dreyfus from Harefield in 2015, which had looked into functional tricuspid regurgitation, the disease process, whether it could be the left-sided heart disease, which causes left ventricular afterload with or without pulmonary hypertension, causing right ventricular remodeling and tricuspid annular dilatation, or chronic atrial fibrillation, which causes altered right ventricular function to cause annular dilatation, which causes abnormalities of tricuspid anatomy and valvular function and lead to functional tricuspid regurgitation. The assessments majorly are divided into three aspects. One is color flow jet visualization of evaluating the PISA radius. This is not the only measurement, as because if we tend to rely more on color flow measurements, that there are various flows happening when in a tricuspid regurgitation. So this has to be combined with the 2D and echocardiography coupled with 3D imaging to accurately measure the annular diameter, as well as leaflet coaptation mode, the leaflet coaptation height. And if we now if we stage the regurgitation, there could be stage 1 where the TR severity could be none or mild with an annular diameter less than 40, with the coaptation mode would be normal, body-to-body coaptation, where the patient does not require any treatment actively. Stage 2 is a mild to moderate severity with an annular diameter more than 40, the abnormal coaptation mode, but there would be an edge-to-edge coaptation, however, with a tethering height less than 8 millimeter, and a concomitant tricuspid valve annuloplasty is recommended. In severe tricuspid regurgitation, the annular diameter, of course, will be more than 40. The coaptation mode will be grossly abnormal. There won't be any coaptation, and the tethering height will be more than 8 millimeters. Where a concomitant tricuspid annuloplasty with valve augmentation may be required, or a valve replacement may be required. Tricuspid was often the ignored valve. We all know it affects various aspects of tricuspid therapy. When we do valve surgery for left-sided heart disease, when we do LVADs, we often have to control the tricuspid regurgitation also. And these are papers from surgeons. This is from Antonio Califiore in 2009, which showed that moderate to severe TR should not be left untreated at the time of mitral valve surgery to achieve a better midterm clinical outcome. And this was from Dreyfus again, which say that the remodeling of the tricuspid valve based on tricuspid dilatation, and not only on the regurgitant jet, improves functional status irrespective of the TR grade, Now, if you look at the impact of concomitant tricuspid annuloplasty on tricuspid regurgitation on tricuspid on right ventricular function, pulmonary artery hypertension after repair of mitral valve, definitely the survival is better when we add a tricuspid annuloplasty than when we don't have a tricuspid annuloplasty. And concomitant tricuspid annuloplasty is safe, effective, and associated with improved long-term right-sided remodeling. Thus, routine treatment of moderate tricuspid regurgitation or tricuspid annular dilatation at the time of mitral valve repair seems to be beneficial. Coming to another paper, which again says that yes, TR is there's a frequent recurrence of severe MR with a normal LV ejection fraction, and is associated with older age female gender and a higher right ventricular systolic pressure. The TR is independently associated with a higher mortality, while mitral valve surgery seems to offer a survival benefit. It has also been seen that the recurrent TR surgery for recurrent TR carries very high mortality rates. Thus, the tricuspid regurgitation has to be fixed at the primary during the primary surgery to prevent to give better functional status. How do we manage a functional TR? The principles are tricuspid annuloplasty are performed at the time of mitral surgery to improve functional capacity in functional tricuspid regurgitation. Tricuspid annular dilatation seems to be the underlying mechanism and the reliable indicator of tricuspid valve pathology compared to tricuspid regurgitation jet. The aim of treating tricuspid annular dilatation at the same time as of mitral surgery is to prevent future treatment of symptomatic TR. This is because once the tricuspid annulus is dilated, its size cannot come back to normal, and it goes on dilating further. Thus, treating a tricuspid dilatation impacts the right ventricular function and prevents subsequent deaths. These are the current indications for tricuspid valve indications for primary and functional tricuspid regurgitation, where the class 1 indication is a severe TR in patients undergoing left heart surgery. But what is added new, this latest guidelines, is the tricuspid repair for functional tricuspid regurgitation of any severity with annular dilatation. Thus, annular dilatation has come into play as an important predictor of tricuspid valvular problems post mitral valve surgery or any kind of surgery with long-term outcomes. And symptomatic severe primary tricuspid regurgitation refractory to medical therapy, or a class 2B indication is tricuspid repair for moderate functional TR and pulmonary hypertension patients undergoing left-sided valve surgery, or primary severe TR with right heart failure. This is a type 2B indication. If you look at the tricuspid valve regurgitation incidence rate, we find that approximately 50% of the mitral valve disease should have tricuspid valve treated. And surprisingly, in degenerative valvular mitral regurgitation, the incidence seems to be the highest, about 70%, whereas in rheumatic heart disease, about 23 to 37% need tricuspid valve repair, depending upon the various aspects of when we treat rheumatic heart disease, whether the patient has pulmonary hypertension, atrial fibrillation, along with annular dilatation, all those aspects. So there is a decision-making process while we look at the tricuspid valve in functional tricuspid regurgitation less than 2+ during a left-sided heart surgery. We take a sizer according to the surface area of the tricuspid valve leaflet and assess the dilatation. When the annulus is dilated, more dilated than a sizer which is one size larger than the supposed size of the tricuspid, then the tricuspid valve needs to be fixed. Thus, we place a lot of importance on tricuspid annular dilatation while treating tricuspid valve regurgitation, whereas where tricuspid regurgitant jet is not so important as tricuspid annular dilatation. This is a surgical view of how we measure the tricuspid annular dilatation, where the anteroposterior and anteroseptal commissure distance measured, and if it is more than 70, then we need to fix the tricuspid valve. Okay. So performance of different tricuspid valve repair techniques, if we study the De Vega annuloplasty or the suture annuloplasty as vis-a-vis the ring annuloplasty, the ring annuloplasty always seems to be doing better than the De Vega suture annuloplasty as regards recurrence of tricuspid regurgitation is concerned. And this shows that the freedom of recurrent TR, which is much less with the ring as opposed to the suture annuloplasty, at 5 years, and a better long-term survival with the ring rather than the suture annuloplasty. This was from Tyrone David group. This is how we put the ring into the tricuspid valve, which shows a rigid ring which fixes the valve in the bimodal shape to prevent the recurrence of regurgitation. There are certain KOL recommended guidelines. The major surgeons, those who treat valvular heart disease, and they have various recommendations for tricuspid valve. What to know is surgeons, those who treat mitral valve disease, either rheumatic or degenerative, they have a very low threshold for treating tricuspid valve regurgitation while doing the left-sided valve surgery for better outcomes. So thank you for your attention. I think we have covered most of it, and we'll be open for questions. Thank you very much.
Devika, please take over, and Dr. Bhattacharya.
Yeah, I think, Devika, are you still here?
Yes. Yeah,
so you were going to ask give some comments on Dr. Majumdar's presentation. So please go ahead.
Listening to the functional regurgitation by Dr. Mukherjee, which was an excellent presentation. I would add one point for Devdutta's presentation. Like the most important pitfall in multivalvular heart disease is our stepmotherly attitude towards the tricuspid valve. for the regurgitation in case of multivalvular heart disease. We don't look at the tricuspid valve the way we look at the mitral valve and the aortic valve. So that is one of the pitfalls I think we should keep in mind, to look at the tricuspid valve very nicely.
Okay, so if you go on to the next, Dr. Shushan Mukherjee's presentation. Do you have any questions for Dr. Shushan Mukherjee? There are a lot of patients undergoing valvular surgery in our institution.
Yes.
So going by your experience, what is the percentage of these patients that you recommend for tricuspid valve repair?
See, most of the patients who we take the measurements, even if it is mild tricuspid valve regurgitation, we always take the measurement of annulus because there is a paradigm shift of tricuspid valve, surgical treatment. We have many methods like repair, annuloplasty. So it's very important, even from the mild to moderate up to the severe, we give all details of tricuspid valve in each and every case of mitral valve disease. Now, one point I would like to ask Dr. Mukherjee, like as you said, in degenerative mitral valve disease, you said TR is more common than the rheumatic.
Yeah.
Like how surgically you plan for the repair in those cases, degenerative mitral valve disease with tricuspid valve involvement.
The surgical plan always remains the same, whether it's rheumatic or degenerative. For degenerative mitral valve disease, we plan mitral valve repair along with tricuspid valve repair. However, for rheumatic heart disease, repair is not so common. We do replacement of the mitral valve and do the tricuspid valve. What is important is, as you have mentioned, the tricuspid valve regurgitation only with a flow jet is not enough. We need to understand the other parameters like the dilatation of the annulus, and there are other few things which we look into. Whether if the patient has chronic atrial fibrillation, the chances are that this annulus is not going to do well after just treating the left-sided heart disease. If there is pulmonary hypertension more than 45 millimeter of mercury, we would be very aggressive in treating the tricuspid valve, even though the regurgitation may be less. So we try to fix it. And for my personal opinion, and I think of the opinion of current surgical thing, the use of rigid ring should be emphasized. And I do it very commonly. My incidence of tricuspid valve repair in mitral valve surgery is around 50%. We do, as you all know, I do about 100% minimally invasive mitral valve interventions. And I add a tricuspid valve intervention along with a minimally invasive mitral valve intervention, as it can be treated very easily. And the pre-designed rings, there are a few commercially available pre-designed rings which follow the bimodal structure of the tricuspid valve. They have done very well, actually. You don't need to do much. You just have to place the ring, size it properly, and place the ring properly, and it works wonders. And the outcomes are much better in patients than when you don't do the tricuspid valve.
Regarding the annular sizing, do you rely on the transthoracic echo more or on the transesophageal echo?
No, you see, the echo is done. Echo has its place, but when I open the chest, I have already made up my mind that I'm going to intervene into the tricuspid valve. So what I do is a perioperative view. So I do a few.
You rely on transthoracic or transesophageal?
No, transthoracic is good enough.
Yes.
When we do, but we have a transesophageal.
We have seen the transthoracic is better than transesophageal.
Yes.
But with Dr. Majumdar, I'm Dr. Ajaya. I just want to, with permission of the chair, to ask two questions to two speakers. And what is the current status for having your torch view or glass view of Philips to estimate the volumetric assessment where the light and sound has been used, and it is a game changer, breakthrough technology. And it can give better dimensions to TR and MR and to regurgitating lesions, where most TR is volume dependent and diuretic dependent, or is dependent on pulmonary artery pressure, and it is also dependent on your artifactual things like pacemaker wears. So Shushan, how do you assess the TR in presence of this pacemaker until unless you remove the pacemaker wear, you cannot assess? And what is the role of volumetric assessment before you decide and you are committed to do something on the tricuspid valve?
Personally, if you ask me, Prakash, I don't do volumetric assessment, but definitely, as I said, that when I am intervening into the left side of the heart, I keep a very low threshold for treating tricuspid valve. There are the three aspects which I look into is one is the annular dimensions that has been measured through a transesophageal echo. If it's more than 40, definitely you keep a low threshold of changing the valve, even though the TR grade may not be great enough. TR grade may not be great enough. We look at the tethering heights, not so often. Tethering heights, if it is more than 8, then definitely we need to intervene on the valve. And if, as you said, that if pacing wires are there, they tend to interfere with the tricuspid valve motion, and you have to have a very low threshold of treating the patients. So, per operative view of a patient, when you open and see that the right atrium is dilated, when you open the RA and see that the annulus is dilated, we look at the anteroposterior anteroseptal commissure. If it is more than 70 millimeter, definitely this valve needs to get a intervention. Even though the TR jet might not have been very great during the postoperative echo.
Thank you, Shushan. I think. Thank you very much. We are almost at 6:30, and the next session needs to start. So I thank all the speakers, especially Dr. Shushan Mukherjee, Dr. Devdatta Majumdar, and Dr. Ravinder Singh Rao, who joined us from Jaipur. And we would move on to the next session. Over to you, Dr. Shah.
So our next session is heart transplant. Our chairpersons are Dr. Taposh Rai Chaudhary, Dr. UN Shorkar, Dr. Buddhadev Mukherjee, and Dr. Dhiman Kahali. Have they joined? I'm audible?
Yeah, you are audible, Jayanto, but I think the audio has to be improved a little.
Oh, sir is here.
Yeah, there is interference in between. So I think if the tech team, you can ask Raghu to have a look in the audio,
right.
Otherwise, I am here. I have been here for long. I have been listening to the nice presentations. Yeah.
Dr. UN Shorkar is here? Dr. UN Shorkar? Dr. Taposh Rai Chaudhary? So our moderators for the session are Dr. Bhabatosh Bishwas, Dr. K. Mandana, and Dr. Binay Krishna Shorkar. Dr. Kahali, sir, you can start the program.
Okay. Good evening and welcome everybody to this great session of heart transplantation. And as we have been noticing that in Kolkata, lots of centers have been doing the heart transplant program. And unfortunately, in our center, we haven't done anything as yet, but hopefully we'll be doing soon because of some logistic problems. So there is a very rich faculty here. And just to start with the program, we have Bridge to Heart Transplant by none other than Dr. Mrinalendu Das. She is a very good surgeon. And Dr. Mrinalendu, please, you start the program.
Yeah, can you hear me?
Mrinalendu Das, please.
Yeah, I'm here. Can you hear me?
Yeah.
Can I share my screen?
You can listen to you. Yeah.
Well,
the problem.
I'm not getting my screen actually.
Sir, do you see your PowerPoint presentation? Do you see your PowerPoint presentation?
Okay, let me open that first. Yeah.
Yeah, please. Yeah.
Yeah, I have opened it.
Okay, now go to Zoom, sir. You are on Zoom already. There is something called share screen. There is something called share screen on the Zoom platform on the bottom of the monitor. Yeah, please click share screen.
Where is Zoom one?
ডান দিকে নিচে আছে, দেখুন মৃণাল দা, ডান দিকে নিচে।
না, আমি অ্যাকচুয়ালি জুমটাকে মিনিমাইজ করেছি, তারপরে স্ক্রিনটা খুলেছি। তো এবারে জুমে যেতে পারছি না এখন অ্যাকচুয়ালি আরেকবার। ওকে,
none বা something else, none or
Hello, sir. Do you require any help?
Yes, please.
Yeah. So is our presentation open on your computer?
Yeah, it is open.
Okay. Is the Zoom open on your computer?
It is open. I have minimized it. I don't know where it has gone. Actually.
Oh, acha. Do a Windows icon.
প্রেজেন্টেশনটা মিনিমাইজ করে দেখুন জুমটা কোথায় আছে।
আচ্ছা, হ্যাঁ, ঠিক আছে, ট্রাই করি।
Hello. They should see a Windows button. Windows button on your keyboard.
Sir, window button. Okay. Yeah. Got it.
So do you want to share your slides with us?
So please do that.
No, I actually was on the Zoom. I was listening to the lecture also.
Sir, you can Dr. Plavan Mukherjee join till that Dr. Dash will prepare his slides. As Dr. Plavan Mukherjee is there? Dr. Kahali, sir, please.
Dr. Palambi is here, sir.
Yeah, I'm there.
Plavan Mukherjee is there, Dr. Plavan.
Yeah, so Dr. Plavan Mukherjee start, and by that time, Dr. Meenalendu Dash, let him get ready with his slides.
Okay, I've given you the slides, so I mean you can put it on.
Yes, sir. 1 minute.
এখান থেকে গৌতম সেনগুপ্তকে ফোন করে হচ্ছে যে বল যে গৌতম সেনগুপ্তকে ফোন করে বলে স্যার আপনি জয়েন করে যান। জয়েন করে গেছেন তো গৌতম সেনগুপ্ত, ডক্টর গৌতম সেনগুপ্ত।
So your slides are sharing.
Yeah, absolutely. Thank you.
Yeah.
So do I start?
Yeah, maybe.
Okay. Good evening, and thanks for asking me to speak today on how you prepare a patient for heart transplant. And I'll spend the next few minutes on how we do it in our unit. Okay, I'm outside Calcutta and I hope my internet holds. Okay, first and foremost, I'd like to say a few words on our understanding for the purpose of heart transplant. Because, this is a problematic subject. There is a huge number of patients waiting for transplant and the organ is scarce. So how do you ethically allot your organs? The principle we follow now is to identify patients with the greatest need for heart transplant. You have to identify those who need it most. But amongst them, you have to identify those who have the highest potential for a favorable outcome. By that I mean the patient has to be sick enough to get a heart, but not so sick as to preclude long-term survival factors after a heart transplant. So you give a heart to a patient who needs it and who is likely to have a good outcome in the long run. Next slide, please. And to come to this conclusion, we need the help of different specialties, especially the cardiologists, the medicine people, the nephrologists, sometimes the surgical people, not much. And also we have to take care of the psychosocial aspects of a heart transplant patient, and that really needs to be looked into. And everything, this is important, all this has to be coordinated by the cardiac surgeon. You have to get the cardiologist, you have to get the nephrologist, get all of them in, have a meeting, talk about the patient, and then decide. Next one. Next slide. Thank you. Definition of heart failure, I believe we had a lot of meetings and everyone knows, and there are a very huge number of patients in advanced heart failure in our country. And these patients are the ones who need some form of intervention and ultimately maybe heart transplant. Next one. Next slide. The group we are dealing with are stage D patients. That means the patients who are refractory despite all medical management and require some form of intervention. So I'll be talking about this group of patients who come into the stage D. Next one, please. Next slide. It is easy. The stage D patients have been divided by the Intermax levels into 7 groups, according to the severity of the disease that they have. And this Intermax classification also helps us to formulate a form of management for them. You know, the Intermax, according to the severity of the patient, we have the different levels, with the worst patients being the level 1, crash and burn. They are self-explanatory. The heart has failed. The end organs are all really getting damaged. From that, the next worst group is those who are sliding fast on inotropes. These 2 groups are really the ones we have not treated as yet, because we've just started a program. And the groups that we take into consideration are those who are stable but on inotropes or advanced heart failure, whom they call the frequent flyers. They get the medicines, they get better, they go home and come back within 2 days with all swollen up and again with respiratory distress. So Intermax level 3 and 4 are the ones we have done the heart transplants for. Next slide. Next slide, please. As I said, this Intermax levels helps us in determining what form of treatment these patients would really need. For example, a patient who is really bad, Intermax class 1 and 2, they would be patients for short-term VAD. They really will not be candidates who would get a heart transplant or a long-term left ventricular assist device. Those belong to class 3 and 4 may be candidates for LVADs if heart are not available. But if hearts are available and they can be pulled on with medicines, are the candidates who can have a heart transplant. And these are the group that we have catered to up till date. Next slide. Next slide, please. So basically, who are the patients that we have treated with heart transplant? Patients, as I said before, they are on inotropes, IV inotropes. They are in New York Heart Association 3 or 4 or maybe AHA class D with a decreased VO2 max. I'll be talking about this later. Other candidates who can be a recurrent ventricular arrhythmias with hemodynamic compromises. The 4th patient we did who had severe and untreatable angina. He had a CABG before in our department only, and in about 3-4 years' time came back with angina. Nothing, no target vessels were available, and we had decided that we'll do a transplant. The other indications would be end-stage congenital heart disease, patients on mechanical support, and the last group is cardiac allograft vasculopathy. Though we have not got these patients, but as the program goes on, these patients will also be coming for retransplant. Next slide, please. Next slide. Can I have the next slide? Thanks. So this is something I really did not want to talk on. This is something Mrinal will be talking on, but I'll just quickly run over the next few slides because Mrinal will be dealing with this in detail. The patients who are not doing well, they have to be on some form of support. Either it can be a peripheral ventricular assist device or a left ventricular assist device. Next slide, please. Next slide. Next slide, please. The peripheral ventricular assist device we have at present are the IABP, the Impella, the Tandem Heart, and the VA ECMO. The IABP usage is small, but a patient who has crashed, that is, say, Intermax level 1, he can be supported with the IABP for some time with the hope that he is getting better. But the other patients would need something better. In fact, the Impella, Tandem Heart, and the VA ECMO are better stuff to support a failing heart. The one thing I'd like to point out here is, IABP is pulsatile, while the others are non-pulsatile. We all know how IABP works, and I'll not really go into detail about this. Next slide, please. We'll go quickly over these. Next slide, please. Next slide. This is what the
Sound. Not audible.
Plavan sir, kindly check your.
No, not audible, not audible.
Kindly remove your headphone and try, sir.
হেডফোন থাকলে ভালো হয়, ডিস্টার্ব করছে না।
অডিও কি চলছে? ওনার কানেকশন প্রবলেম হচ্ছে।
হ্যাঁ, সেটা তো হচ্ছে। তারপরে তোমার
Can you hear me now?
Now we can hear you.
Please continue, sir.
Can you hear me?
Yes, sir. Please continue.
Can you hear me?
Yes.
Yes, sir. We can hear you. Please continue. Hello.
Okay, good. Can you hear me now?
Yes, sir.
Oh, good. I'm continuing.
Yes,
we can listen to you, sir.
Yes, sir.
Okay, thank you.
Continue, please.
So I just talked about the impeller. Can I go to the next slide, please? Next slide, please. Good. This is the tandem heart, which again can be used for a trailing ventricle. I'll not go into the details, as Binalendu will be talking about all this. Next one, please. Next slide, please. Next slide. You can't hear me, I believe. Okay.
No, we can hear you.
Yeah,
we can listen to you. Yeah.
Good. This is the last form of a peripheral support system that we have, which is the VA ECMO. Here, basically, you're taking blood from the venous side and putting it into the arterial side after oxygenation. Next one, please. Next slide, please. Can I go to the next slide? Yeah.
Yes, sir. Change already because of network issue. I think it will.
I know. I know. I understand. These are the 4 left ventricular assist devices that you have, which can be put in when the patients are in Intermax 3 and 4. So unless you get a heart, you can put in these devices, and this can run for some time. Next one, please. Next one. Yeah, go to the next one now. Next one. Just skip this slide. Skip this slide. Yeah, good. So when we get a patient of heart failure, he is basically on guideline-directed medical therapy. But that is not sufficing for him. And we have found that all our 4 patients that we have transplanted needed milrinone. These inodilators had been very useful in the sense they cause peripheral vasodilatation, good inotropy, and often get the patients who are not doing well into a stage where they can be taken over for a transplant. And we have seen that we have been able to put them on milrinone for a pretty long time. All the time we had to wait to get a heart, and they tolerated it very well. So this is one drug I think that works wonders, and they can move around with this, provided the syringe pump can be carried with them. Next one. Next slide, please. Next slide, please. So once we get a patient, quickly we should also know whom not to operate. This is something which is important. If there is active malignancy, there is severe cerebrovascular disease, recent pulmonary embolism, and the patient is non-compliant and doesn't have a social support, these are the patients, though transplant may be indicated, we would probably not do, because obviously you can understand the long-term results will not be good. Next one, please. Next one. There are a few relative contraindications, and when there are more than 2 or 3 contraindications, relative contraindications, we would also not really be very keen. Age 70 years actually is not for us. Our cutoff age is 60 years, even at present. If the patient is very obese, we wouldn't do it because he will not tolerate. Pulmonary hypertension is a terrible thing, and we are afraid of it, because if the pulmonary vascular resistance is more than 3 units, it's very unlikely that we can get the patient through, despite nitric oxide and all that. And if he has pulmonary disease also, primary pulmonary disease, he wouldn't be a candidate for heart transplant. He would probably need a heart lung. Next one, please. Next one, please. Uncontrolled diabetes, renal dysfunction, active infections, and hepatic dysfunctions, which transaminase is greater than twice the normal, would not be an indication, would be a relative contraindication unless corrected. So if more than 2-3 relative contraindications are there, we would not operate. Next one. Next one, please. So now we've got a patient whom we have decided we can operate. The first thing that we do with this patient is we score him. We use the Seattle heart failure model first. There are other scores are there, MAGIC score and heart failure survival score. We do not use them that often. We always use the Seattle heart failure model for all our patients. Next one. Next one. You know, this is a very good heart failure model. It has been very well validated and provides accurate 1, 2, and 5. কতক্ষণ বাঁচে
স্যার আরো দুজন আছে এরপরে 12:24 মিনিট টাইমটা দেখুন
আমার কতক্ষণ আছে সময়
করে দেবেন
ওকে so provides accurate 1, 2 and 5 year survival. Next one. Next one, please. This is what the Seattle heart failure score looks like. You have few things, very simple things that you can put into: age, gender, NYHA class, EF, few drugs and lab findings, and you get 2 graphs. What his survival will be and what his expected survival will be after he gets a heart transplant. If, next one please. If his 1 year survival.
We have got 2 more speakers.
Yeah, so how long do I have?
First.
How long do we have? Okay, so go to the next one, please. Next slide, please. Next one. We do not use the heart failure score because we don't have the VO2 max. Next one, please. Next one, please. Next one. Go to the next one.
Dr. P.P. Mohanan.
These are the 4 patients, and you can see, go back to please. Go back, please. Okay. These 4 patients, yeah. So with the Seattle heart failure score, and they all had a 1 year survival of around 65%. They were all candidates for transplant. Go to the next one. Next one, please. Next one, please. We have to do a whole lot of tests. Every organ system has to be tested, and I'll quickly go over these slides. Just stress on a few important points. Yeah. Go to the next one. You know, the X-ray, ECG, echocardiography is there, and we do not go to the next one. We do not have a CT machine as yet. Go to the next one slide. Next slide, please. So what we do is we do the 6-minute walk test in our veranda. And if it is less than 300, then it is all right. Go to the next one. CPAT machine, next one, please. I'll go over quickly. Go to the next slide, please. Next one. Next slide. Next slide, please. Okay. Okay, let me here. I'll say a few words about the right heart catheter. Please keep it here. The right heart catheter is important. We have to see the right atrial, right ventricular pressures, pulmonary artery pressures, because we are very afraid to see whether there is any active pulmonary hypertension or not. Go to the next one. Normally, this is done in the cath lab. Go to the next one. But since the cardiologists are very busy and cannot give us time, we now do it in our, keep it here, please. Keep it here. We do it in the intensive care with a Schwann-Ganz catheter. And our algorithm we follow is, if the mean pulmonary artery pressure is more than 25, we see the pulmonary capillary wedge pressure. If it is less than 15, it is probably pre-pulmonary hypertension and it's lung cause. If it is more than 15, we do the transpulmonary gradient, TPG. If it is more than 12, we do the DPG. If the diastolic pulmonary gradient is less than 7, he is a good candidate for a heart transplant. If the TPG is less than 12, he is a good candidate. We do this in the intensive care, and maybe we have to repeat it frequently so that we know whether the patient is going worse or better. Next one. Next one. Next one, please. Next one. This is the first case. They helped us in the cath lab with this. This is the right heart catheter that we do in the ITU itself with the Schwann-Ganz catheter. Next one. Next one, please. Next one, the lung functions that have to be tested, and it is done, the standard lung function test. Immunological tests, two things we have to do is the panel reactive antigen and the donor specific antibody. This is important because PRA, a high PRA value would indicate that the proportion of donor population to whom the recipient has performed cytotoxic antibodies is high. Next one, please. And next one, please. And often the patients, we have what is called the sensitized patient because they have had pregnancy or have had blood transfusions. And if the patient is sensitized, then probably he will have antibodies and the rejection chances are high. So we basically have to do desensitization of these patients before we do transplant. And how we do it, I'll show you. Next slide, please. Next slide. Next slide, yeah. There are innumerable methods of desensitizing and sensitized patients. We can do plasmapheresis, we can do antithymocytic globulin. What we use is basiliximab. 2 doses of basiliximab at the time of induction and post-op does wonders. It is a costly drug, but government provides it for us, and we always use basiliximab in patients who have a problem with being sensitized beforehand. Next one, please. Next one.
Can you make it short? We have 2 more speakers.
No, okay, tell me how long do I have? I'll finish. Next one. 2 minutes?
Within 2 minutes.
2 minutes?
Yeah.
Okay, okay. Go to the next slide. The kidney changing is taking a lot of time. The renal functions have to be tested. Go to the next one. Go to the next slide, please. Next slide. Next slide. The liver functions have to be tested. Next slide. Coagulation profile has to be tested, and we have to take the help of hematologic people. The markers of next one, infections have to be tested. Next one, please. All the tests, go to the next one. All the viruses have to be IgG, IgM have to be done against them. And for next one, go to the next one. Next slide. Next slide. Next slide, please. So once all this is done, we involve ROTO. We vaccinate the patients. Next one. Against all the vaccines that are important. Go to the next one. It's finished. The social part is we have to take care of his home. Next one. Next one. And we have, next one, please. Yeah, and we have to have the team meeting so that everything is in place and it's a well-oiled machine. With this, these are the first two patients successfully done. Next one, please. And I'm finishing with my last slide. Next one. These are our 4 patients who have been successfully transplanted. Thank you. I mean, because of the audio connection, I believe I gave you a lot of trouble, but sorry.
Thank you very much, Dr. Mukherjee, for your extensive and elaborate presentation. Our next speaker is Dr. Gautam Sengupta. I will request him to present. Dr. Sengupta is there?
Dr. Gautam Sengupta.
Dr. Gautam Sengupta.
Yes, sir. Doctor is there.
Doctor is there, then he is to speak.
Sorry, I am late to join.
Okay.
But I'm very glad.
Suppose that we are all looking for you.
We are just waiting for you.
Yeah, Dr. Mukherjee had a great lecture. Now we are waiting for the next lecture by Dr. Gautam Sengupta.
Sengupta, exactly.
No, I have heart problems lecture because now
Yeah. It was a very good piece of information. We are
exactly
listening to it. Yeah.
But it is very difficult to give within that short time.
Yeah.
Only 12 minutes are allotted. Dr. Sengupta, please.
Sir, I'm here. Can you hear me?
Yes, we can hear you.
Yeah, we can listen to you. Yeah,
Yes.
Dr. Sengupta, you start, please.
Yes, I'm just uploading my slides, or if the organizers can start my slides, then I can continue.
Okay.
Actually, complications.
I have given, sir. I have given. I have enabled for you. Please go ahead.
Actually, complications in heart transplant is an exhaustive subject, and many things have to be said. Actually, we are at a disadvantage as we do not have the bodily presence, and our bodily gestures and other things are not present. So it is not possible to emphasize what we want to tell you. But still, I'll try to make myself understandable. Just connect again.
Sir, currently, Mrilendu Das is sharing, sir. Dr. Mrilendu Das.
I think there is a problem.
No, they are connecting.
Who is connecting? Dr. Mrilendu or myself? How much slide look at that?
उधर शेयर कर लेते आपने
তোমারগুলো আসছে
did we?
No, then this is Dr. Mrilendu Dash's.
Yes, sir. Dr. Mrilendu Das sharing the screen.
So it's best if you let Dr. Dash to continue with the lecture.
Dr. Dash to continue, and then after that, Dr. Sengupta, please.
Yes.
Yeah. We are sorry for the inconvenience.
Can you hear me?
Yes.
Yeah, we can listen to you, sir. Yeah, please.
Okay, fine. I'm sorry for the confusion because I was been trying to do it mailing and all sort of things, So just can I go ahead with my presentation?
Yes, Dr. Das, but you have to finish it within 10 minutes time because we are running short.
Oh, all right. I'll try to do as fast as possible.
Please.
So basically, this is my screen, and where is the? It's not moving actually. The screen. Okay. So basically, over the advancement of cardiovascular medicine and intervention, the mortality rate of heart failure has come down, and many of the acute heart failure patients are reaching up to the end-stage heart failure, so needing transplantation. And as you know, that there is a tremendous shortage of donor. So basically, this has stimulated the growth of mechanical circulatory support. So basically, rescuing a heart failure patient from dying by using of mechanical circulatory support is the bridge to transplantation. So I'll be talking about this. At the outset, I must say that all my data will be from Western world because not much of VADs have been implanted in our country, only few of the short-term VADs. So I'll go about that. So this is the paradigm of the heart failure patients. So initially they join here, and then subsequently they drip down into stage 4 and 5, and from there they can be rescued with either transplant or by ventricular assist device. So basically, if we cannot transplant the patient on this area, they will die. So we will probably put a VAD on that and rescue them from dying into the waiting list, and then subsequently they become eligible for transplant whenever the donor is available. So this is one of the articles which shows the huge problem of transplantation and the waiting list. Or about 4,500 transplants done all over the world. But actually, if you calculate in India itself, 5,000 transplants per year should be done, where we are doing a couple of hundreds only. So basically, you can understand the problem. And therefore, the VADS has come and taken over, the mechanical circulatory support rather has taken over a large part of the management of heart failure patients. So whether the mechanical circulatory support helps or not, the most important thing is, just a minute. Hello, I'm talking. Okay. So basically, as early as 1995, this article shows that if a pre-transplant mortality reduces by about 55%, if we put a mechanical circulatory support, and that to the old generation one, you can imagine how it will be with the present generation one. This is a study group from REMATCH trial, where again it has shown that the pre-transplant mortality has been reduced by use of mechanical circulatory support. So this is ROADMARC trial in 2017, which shows even if we put mechanical circulatory support on patients who are actually not inotrope dependent as compared to the medically treatment, even they have a higher 6-minute walking test. So the crucial part, can you hear me please?
Yes.
Yes.
Yeah. The crucial part is the selection of the patient. Plavanda has already covered part of it. Basically, they have to be optimized with the medical treatment before MCS is implanted. So if we go to the Intermax, Intermax 1 classification, their survival is basically in hours, and end organs are failing. There is no problem, no chance of medical management. So they should be put on ECMO and percutaneous VADs like Impella, Tandem Heart. And if we go into the Intermax 2, that survival is matter of days. Here, mostly we put temporary VADs like CentriMag levitated device, and this can be a biventricular support in that case if it is necessary, and ECMO is also necessary. But LVAD is very rarely possible at this stage. So you must remember that Intermax 1 and 2 patients are on temporary VADs, and they cannot go up to heart transplantation. So they has to be bridged to another long-term VAD before they get into transplantation. And the third category is the Intermax 3. These are basically transplant candidate, but if they have to wait for a long time of rare blood group, they can be put on VADs. And the fourth category is a tailor-made approach. Here, the patients are of course not dying, but then they can be put on VAD if they have cardiorenal syndrome, borderline pulmonary hypertension, where they cannot be transplanted immediately, or most commonly patients who have been treated for malignant tumors, and just to see whether the recurrence is happening on 2 or 3 years may be necessary, and these patients can be put on VAD. Another group of patients is sensitized patients. If they have multiple transfusion or multiparous women, they're very highly sensitive with a very high level of antibody, and very rarely you can match a donor for them, so they can be put on VAD. So basically, this shows the 1 and 2 category is temporary VADs, 3 and 4 are on the VADs, and 5 and 6 by electively. And this is the triage. So hemodynamically unstable patients should be parked at somewhere in the bridge to transplant or bridge to candidates, and those stable patients said straight go to the heart transplantation. If there is some contraindication, they can be put on VAD and parked again to bridge to candidacy. If the problem is solved, they can go for transplantation or they go for destination therapy. So these are the different VADs as Plavanda has explained. The most important thing is that CentriMag, it can give a biventricular support when sometimes patient have both RV and LV failing. Just only LVAD will not help. So in that case, it can have a biventricular support. So as ECMO can give a biventricular support. The permanent VADs are artificial heart, HeartMate 2 and HeartWare. So these are the long-term durable VADs. So the results of the VAD are gradually improving. As you can see, in 2001, only 52% patient used to survive first 1 year, and it has reached to 85 to 90% with HeartMate-3. It's almost over 90% 1 year survival. Pulmonary hypertension is a major issue, and contraindication would have had patients, particularly if they have a right ventricular dysfunction, and also renal dysfunction, sterility, smoking, obese patients. These are a relative contraindication for putting a patient on VAD as a bridge to transplant. The effect of bridge to transplants are not less, apart from cost, uncertain future, and compliance to various life norms. Neurological dysfunction, particularly stroke, gastrointestinal bleeding, driveline infection, pump thrombosis is a very major issue, though in HeartMate-3 pump thrombosis is almost nil. And the most important thing, because the patient has to do a redo operation, so they need blood transfusion, they get sensitized, and prolonged non-pulsatile flow causes hemodynamic instability after transplant. So how does the patients on bridge to transplant do after the transplant? So this is one article in 2010 by Ranjit John et al., which shows there is not much of difference in survival if they are on VAD and transplanted, and if they are medically managed and transplanted. However, this is a 36-center multicentric trial. However, later on in 2019, another article, Tooby et al. Has looked into the matter more carefully and found that 1 year mortality, Kaplan-Meier survival is much less in the patients who are bridged to transplant rather than medically managed and transplanted. However, at the end of 5 years, this has evened out. And if they have more risk factors like age, renal dysfunction, obesity, donor age, higher donor age or ischemic time, they even fare much worse than the patients similar category who are medically managed but not bridged. So this is one important research has come out in 2019 circulations. And why it is so? Because the important vasoplegic effect of continuous flow VAD, with non-pulsatile flow causes really maladaptive changes in the peripheral vasoreactivity and endothelial dysfunction of the end organ. So that promotes post-transplant graft dysfunction, also increased ischemic time because of higher dissection and other things while doing, and also accepting marginal donor, because the patient is a long-term VAD, they are desperate to get into transplant. So marginal donors really causes problem of graft dysfunction. So these are the usual trend. As you can see in the B category, the patients who are medically managed weight lesser than those who are on VADs, because this is a change in the criteria of UNOS criteria of allotting heart. And also the median time of waiting on VAD, those who are bridged to transplant, is almost about a year. And more patients are becoming ineligible for transplant, and they go into destination therapy. And till recently, about 60% patients in USA were transplanted via bridge to transplant. However, the scenario has changed, because earlier they were given status 1A category when the VAD is implanted, but as the VADs become much better and better, this status has been taken off. Also in India, the situation is different, because most of our patients are on temporary circulatory supports, and they are given priority, of course, but VADs are very limited in a very handful centers in India, so we cannot really conclude anything from those data. So this is the UNOS criteria in the current situations. Only ECMO is a status 1, and those who are non-dischargeable by VAD status 1. But patients who are uncomplicated VAD and outside 30 days, they are all in status 4. So they really don't get priority. This is what happens to the bridge to transplant patients. At the end of the 1 year, about 20% patients are transplanted, and rest of them are hanging around there. I have just few more slides. So basically, at the end of 2 years, 30% patients are still on bridge to transplant, and 43% patients are no longer in the transplant list, and they have moved into a different category altogether. So at a first glance, if we put somebody on bridge to transplant, that doesn't mean they get transplant. They move the bridge to destination therapy, or even some of them recover also. So bridge is very movable, and important strategy should be the intent of therapy, but the end of therapy we do not know. So that strategy should be bridge to candidacy rather than bridge to transplant or bridge to destination. So this is a sinking ship. If the patients on this area is category of Intermax 1 and 2, they are all dying. And these are category of 4 and 5 and 6. their fate is imminent. But very few can hop into a boat and survive like heart transplant patients. But should we allow these people to die? No, because we have a very durable bed and let them support with a like a life vest and float around till they can hop into another boat and survive. So to conclude, the long list of heart transplantation actually stimulated the exponential growth of mechanical circulatory support. Basically, vulnerable patients are rescued by mechanical circulatory support for the purpose of bridge to transplantations. Patient selection is very important and critical. Continuous flow devices are pretty durable and ready for a long haul, and large number of patients are hooked into it. Actually, 2.5 lakhs of patients in United States itself has put on VAD every year. And up till now, so basically mechanical circulatory support are bridging these patients and preventing them from dying on waiting list for the lack of donor for transplantation. Thank you.
Thank you, Dr. Dash, for your excellent lecture. And I think we'd come to the conclusion later on and discussion. And I would invite Dr. Gautam Sengupta to start your lecture, please. Yeah, you have finished, I think.
Yeah. Gautam sir, kindly unmute yourself, sir. I have sent a request.
Yes, it's unmute.
Yeah. So kindly share your PPT, sir.
Yeah.
If you require any assistance, please let me know. So first you open your PPT.
Yes.
Just a minute. Could you please put in my slides?
So kindly, okay, if you can share your slides to me, then I can.
I have already shared it in the morning.
To whom you have shared, sir?
I think I sent it to Dr. Jayanto Shah. I was given a all thing that the slides are there. Let's see. We have to share that now. Share screen first.
Hello.
Yes.
So got your slides?
Yes.
So got it. Right now it was there, not just previous to this lecture. It was showing there. Technical team can it?
Slides are
No, sir. No, sir. It was not showing, and it was not.
He started his lecture.
If you can share the PPT, then I can share immediately.
Well, in the morning I did slides.
Dr. Sengupta, whether you have got your slides in your laptop?
Yes, sir. I have received it. I have received it. I'll share it.
Share it, please.
Yeah, just a minute.
Yes, it's there now.
Yes.
Well, I'll try to cut it short.
Sorry.
The next slide, please. Well, on completion of transplant, the patient is transported on ventilation to ICU with continuous hemodynamic monitoring, urine output, and drainage. Dysrhythmias are frequent and junctional rhythm frequently, particularly common. The heart is denervated and the cardiac output being rate dependent, a higher than normal rate of around 90 to 110 beats per minute is maintained with the use of isoproterenol infusion and or temporary AV pacing. This is important. We have to remember that the heart is denervated, totally denervated now. Next slide, please. Uncomplicated recovery is usual, and in a hemodynamically stable patient, extubation is possible after 6 to 8 hours. This has been usually in all our patients. Monitoring of the transplanted patient is usually done in an isolated, fumigated, cleaned room with facilities for barrier nursing and with all the gadgets necessary for resuscitation and intervention for a hemodynamically unstable situation. The room should at least have central provisions for 2 oxygen ports, suction ports, compressed air ports, nitric oxide dispenser. Unfortunately, which we do not have even after 2 years. I have been asking for it, but still the authorities are unmindful about it. Next slide, please.
Hello.
Next slide, please. Next slide. The room should also have an ECMO machine, transthoracic echocardiogram machine, and most importantly, manned by an intensivist who has overall grasp of the situation and capable of initiating measures without delay. I think there is a noise in the background.
There is a noise from outside.
Next slide, please. Sorry.
Can technical team mute somebody, all other microphone, please?
Monitoring and post-operative care is usually done according to ISHLT guidelines, international. The transplant team has to be aware, and it is the knowledge which is important, may raise the suspicion leading to appropriate measures. Hence, complications following heart transplant has to be considered in a different perspective. Next slide. The early postoperative complications consist of primary graft failure, hyperacute rejection. I am not going to talk much about hyperacute rejection. Cerebrovascular accident, bleeding requiring exploration, low cardiac output, dysrhythmias, infections, pericardial collections, effusion, tamponade, inadequate urine output. Next. The intermediate complications include infection, rejection, that can be cellular or antibody mediated or the humoral rejection. Number 3 is accelerated coronary atherosclerosis. 4 is lymphoproliferative disease. The late complications are mostly graft dysfunction, cardiac allograft vasculopathy, chronic kidney disease, obliterative bronchiolitis due to cytomegalovirus infection, malignancy in some form. Next. Primary graft failure. There is no consensus definition and is poorly understood. This is one leading cause of early mortality, 30-day mortality, that is ranging from 2.3 to 28.2%, a long range. The condition is described as severe ventricular dysfunction of the donor graft, which fails to meet the circulatory demands of the recipient in the absence of humoral and other evidences of preformed or donor-derived agents of rejection. Next. Actually, primary graft failure is considered whenever cardiac index falls below 2 liters per minute per meter square and or the ejection fraction is below 40% for at least for an hour or so, when all other inotrope, rate, and fluid dependency and other causes are absent. Next. A number of factors have been proposed starting from the time of declaration of brain death, brainstem ischemia, when the storm of catecholamine surge happens to the completion of implantation, where again the factors of ischemia, reperfusion injury come into play. Next. This slide actually simplifies the events which may be involved. The events can be brain death, hypothermic storage, warm ischemia, acute ischemia, reperfusion injury. And what goes on to lead to primary graft dysfunction has been given here. Next slide, please. The hypothermic storage, what are the effects? That can slow cellular metabolism, progression of ischemic injury, paralysis of transmembrane sodium potassium ATPase pump, rapid decline in high energy phosphates, and lactic acidosis due to anaerobic metabolism. Actually, this is the anaerobic metabolism which is the factor. Next slide, please. The implication of ischemia. Heart transplant is unique in having 2 periods of warm ischemia and a distinct single period of cold ischemia. The first warm ischemic period or donor warm ischemia starts with cross clamp and continues through the harvest till the separator organ is immersed in ice. Next. The second is the recipient warm ischemia, occurs over time, taken to implant the organ into recipient's body, and it ends with the release of cross clamp and the beginning of reperfusion. In between is the cold ischemia. Next. Next slide, please. Though the literature mentions 6 hours as the total allowable time, the consensus is to limit and minimize total ischemic time within 4 hours, keeping in mind the total ischemic time is an independent risk factor for overall results. Next. Acute ischemic reperfusion injury is a complex entity, and liberation and ensuing injurious effects of oxygen-free radicals is well known, and one should be well aware that together with inadequate protection, this may lead to serious graft dysfunction. Next. Cerebrovascular accidents is devastating to the morale of the transplant team. There is no way to predict, no way to know when such an event occurred, if it has occurred during the period of anesthesia, no way to prevent its progression to a severe form even if the insult has been minimal, and the cardiac surgical team understands little about this. It is very difficult even to arrange for a basic brain CT with all the monitoring lines in place and all the gadgets attached. Next. Next. All can be done is assessment of severity of the situation, looking for lateralizing signs, managing convulsions with Perivan or levotiracetam and other supporting medicines, care and hoping for improvement. Next. Blood loss during cardiac transplant occurs mainly from the numerous suture lines, destruction of red cells during the prolonged CTP, improper suturing technique, extensive dissection as needed, and in redo cases and post-DD cases. Next. Well, actually, the surgeon who does the transplant is actually the most senior surgeon, and usually the suture lines are perfect. So there are certain guidelines for blood transfusion. In centers like ours, the blood bank reserves at least 10 units of RBCs and same amount of each of other blood products. That is AFP, platelets, etc. Antifibrinolytic activity is managed with continuous infusion of epsilon aminocaproic acid. When indicated, re-exploration is done aggressively before there are irreversible features of hemodynamic instability. Next. Next. In one of our patients, a reduced situation transplantation done several years following mitral valve replacement, we had to transfer the patient back with an open sternum, and bleeding could only be controlled after infusion of adequate doses of cryoprecipitates. The presence of a thromboelastogram in the institution really helped. Next. They could tell us what is needed actually.
Sir, sorry to interrupt. Sir, sorry to interrupt. I think your earphone jack has come loose in your computer. Just insert and your audio will come out all right.
Next. I think there is a problem. Next slide, please. No transfusion of allergenic blood.
hear me?
Yes, sir. Please continue.
Yes. Though transfusion of allogenic blood and blood products introduces large amounts of WBC and other immunomodulatory agents, it is uncertain till now, even after a number of retrospective studies, studies, whether transfusion-induced immunodilation, that is PRIM, has any deleterious effect. The use of leukocyte filter and use of single donor platelet and FFP is recommended as a precaution. Next. Next. Infections, apart from early graft failure, infection is considered to be the second leading cause of death. Infection can be early, intermediate, late. And next. And we are actually interested in the early infections. As in all other situations, infections can be viral, bacterial, fungal, and parasitic. Community-acquired infections are usually late. The following tabulations summarize the timings and pathophysiology of infections. Go quickly through the next two slides, please. These are the infections within which happened during 30 days. Next. 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 Okay. The non-specific immunosuppression means that transplant patients are particularly prone to life-threatening infections. We accept certain rules. CMV, Toxoplasma gondii, hepatitis B, hepatitis C, HIV are transmitted from the graft. Infection is in the first month are mostly nosocomial. Intermediate infections are usually opportunistic and late infections are community acquired and opportunistic. Next slide, please. Next. As infections are ominous threat, transplant patients are usually given and continued lifelong on a combination of antibiotics. That is, these are the following antibiotics we use actually. We omit certain antibiotics after certain times, but we usually continue with some of the antibiotics such as the cotrimoxazole and also the ganciclovir or valganciclovir, which the government is supplying nowadays for at least 3 months or more. Next slide, please. Immunosuppression and rejection, the goal of immunosuppression is actually to inhibition of immune response to infection while preserving the same to malignancy. This is achieved with short intense induction phase with newly evolved immunosuppressants. Next slide. Allograft rejection can be hyperacute, occurring within minutes. We all know this is usually due to the allosensitization, donor-derived antigens, etc. The acute occurring days to weeks after transplantation, late acute occurring 3 months and after, and chronic occurring months to years after transplantation. Next slide, please. Next. Acute rejection is a function of both innate and adaptive immune systems triggered by recognition of the foreign histopathology complex and foreign peptides presented to the self histocompatibility complex by T cells and results in a spectrum from mild to more severe grades and managed accordingly by tweaking immunosuppressive agents, adjusting steroid doses, and other rescue protocols. Total lymphoid irradiation photophoresis may be used in refractory cases, and retransplantation is reserved for the last, as the results are very bad. Next. Rejection can also be cellular and antibody mediated or humoral. Next. The pathophysiology is different, but it is almost impossible to differentiate between the two. And we should proceed always thinking about the worst and with whatever means are available. Asymptomatic mild rejection is monitored. Modification or changing of immunosuppressive doses comes next. Repeat endomyocardial biopsy is done after 7 to 10 days. Next. A few words should be mentioned about cardiac biopsy and its protocols. In the first few days, it is done more frequently. In the first few months, actually, it is done more frequently, and later on, it is tapered off. If the response is not satisfactory and if you hemodynamically unstable, rescue therapy with methylprednisolone, OKT3 or methotrexate is instituted. Total lymphoid irradiation photophoresis may be tried. Retransplantation is the last option and the results are poor. Next.
Dr. Sengupta, you have to go first.
Yes. This is a slide about cardiac allograft vasculopathy. Well, it is nowadays it is a cardiologist domain, and the PCI gives improved survival. Next. Next. There are considerations about CKD, lymphoproliferative disease, etc. And these are all about complications. This should be managed as the situation warrants. Thank you.
Thank you very much for your extensive presentation. We will get little time.
And these are all about complications. This should be managed as the situation warrants. Thank you.
Thank you very much for your extensive presentation.
Can I just mention one point?
Yes.
Yes, Tapusda, yeah.
Can you all hear me?
Yeah, we can listen, Tapusda. Yeah.
Okay. Gautam, I think it's beautifully said. I think covered everything. But I think what commonly we face, and particularly I think it's happened in several Calcutta transplants also, because most of our transplants, when we get this recipient, they have got a early pulmonary hypertension, and so often there is a right ventricular failure post-transplant or right ventricular dysfunction, to be very frank, as opposed to left ventricular. Unless there is acute rejection, left ventricular, usually we choose our donors carefully. So it more often happens is right ventricular dysfunction. And I think this is just a suggestion we have learned, and I think a lot of people follow that, that routinely to use a nitric oxide infusion as opposed to other pulmonary vasodilator, and keep them for 2 days and see what happens. In case, because that is supposed to prevent initiation of right ventricular dysfunction. And right ventricular dysfunction happens is quite as bad as a biventricular dysfunction. Quite for obvious reasons. Now, I think one of our heart patient had right ventricular dysfunction, and we had to redo in a way that we have put a cannula in a directly like Centrimax, the right atrium, and the other cannula returned to pulmonary artery to bypass the right ventricular completely. And then obviously it stayed there for a few days. Now that is, I think, it's not a very major
সেশনটা শেষ করতে হবে, অনেক এরপরে লাইনে রয়েছে, রাতে 11টা বেজে যাবে তাহলে। হ্যাঁ বলছে স্যার আপনাকে ওই যাই হোক কিছু একটা করে বলতে স্যার ওই রানিং শর্ট অফ।
So can I just say one line, sir? Dr. Kahali?
Yeah, sure. Short comments.
Yeah, short comment, Dr. Kahali. Thank you.
Thank you.
Side, but I have to say only one thing, that all these surgeons of Calcutta have done the transplant here at the moment. And what is essential to note is that, this forum is the biggest bridge between the cardiologist and the cardiac surgeons. I think this is one we should look at, because if you identify the patients early and keep on referring on the bridge to the surgeons, as Dr. Tapos said, that the right ventricle is very important. When the right ventricle goes bad, I think it becomes too late. I think what is more important is that we as a fraternity, cardiologists and cardiac surgeons, maintain that bridge and look at the early young patients who are going into failure and bridge them early so that they can have a proper subsequent transplant, which is more sort of result oriented. I think that's the most important message we should all, I think, give it to the cardiology fraternity. We as surgeons will be very, very thankful if that is done. And that work will become bring the better outcomes to all our patients. Thank you, Dr. Kali.
Thank you, Dr. Mandana, for your excellent comments. Yeah. So I think it was a beautiful discussion, and I thank all the speakers. They're all outstanding. And with Tapos Raichaudhury's presence as a chair and Dr. Mandana, who have been doing lots of cases, congratulations to both of them and all the participants for an excellent work you have been doing in the city. And we are really proud as cardiologists for excellent work by you. And it was an excellent session. I congratulate all of you and announce that the session is concluded. Thank you very much, Jayanto. Take over the mic. Thanks a lot.
Thank you, everybody. Our next session is the case-based discussion. Our chairpersons are Dr. Kajal Ganguly, Dr. S.C. Mondol, Dr. Narayan Chandra Sarkar, and Dr. Ananda Bagchi. Have they joined?
Yes. Am I audible, Jayanto? Jayanto, am I audible? Ananda Bagchi.
Sir, you are audible. And our moderators are Dr. Miraj Mondol, Dr. Raja Nag, and Dr. Tanmay Mukherjee. So please call the speaker. Dr. Dipankar Ghosh is speaker.
So, this is a session for case-based discussion. And here the speaker is Dr. Dipankar Ghosh.
Dipankar?
Yeah. Am I audible?
Yes, you can start. Yes.
Yeah, I'm starting the share screen.
Yes.
Host a disabled particles prevent screen sharing. Mr. Raghu?
I have enabled, sir. Please go ahead.
Okay. Right, I'm making it full screen.
Yes. Go ahead, Dipankar.
Sharing. Mr. Raghu? Okay. Good evening, everyone. I thank the organizers for having me here. And today we are going to discuss a very interesting case on atrial fibrillation. The case is of a 55-year-old female who has been complaining of palpitation for the last 4 days, and there is no history of any angina or dyspnea. She is known to be hypertensive and diabetic. The ECG shows documented atrial fibrillation. The echo shows an ejection fraction of 70% with mild concentric left ventricular hypertrophy, and she is hemodynamically stable. That's all the data that has been given in this case. So our diagnosis is that she is suffering from clinical atrial fibrillation, and it's a case of first diagnosed AF. Now, why AF? Because the ECG is showing irregular RR intervals, and there are absence of distinct P waves. Why clinical atrial fibrillation? Because there is an ECG documentation of atrial fibrillation. Also, if the Holter run shows a minimal 30-second duration of AF, we will call it a clinical AF. One must note that there is an entity called subclinical AF where both the ECG and the Holter do not show AF, but the AF rhythm is determined or detected only in cardiac implantable devices, interrogation, or on event recorders. Now, our case is a case of first diagnosed AF. Why? Because irrespective of its duration, maybe 2 years, 3 years, the patient was on AF, but when we are diagnosing it for the first time, it's been documented, we will call the case as first diagnosed AF. The other entities, one must be aware of it, that if the AF terminates spontaneously or with intervention within 7 days, we call it paroxysmal. If it persists beyond 7 days, but terminates either spontaneously or on treatment, we call it persistent. The other two variants of long-standing, persistent, or permanent depends on the viewpoint of both the patient and the physician. Now, if a rhythm control strategy is adopted, that is, the patient and the physician wants to bring it back to the sinus rhythm, then we call it long-standing, persistent. And if a rate control strategy has been adopted, like that, let the AF be there and we will just rate control it, then it's called permanent. One must be aware that the terms like lone AF should be abandoned because every patient of AF has a cause. And other entities like valvular, non-valvular AF or chronic AF needs to be avoided. Now, once the diagnosis of AF has been done, so we will follow the CC to ABC pathway. Now, C is confirm atrial fibrillation, and the next C will be characterize the atrial fibrillation. Now, we characterize the atrial fibrillation on these 4 parameters. Every AF patient we see in the OPD needs to be characterized on these 4 parameters. One is, first, you must assess the stroke risk. Second is the symptom severity. Third is the AF severity burden. And 4 is the substrate severity. Now, to calculate the stroke risk, you must apply the Chadwick score, which includes congestive heart failure, hypertension, age, diabetes, the stroke risk, or any event of stroke, vascular disease, and the sex. Now, in our patient, the Chadwick score is 3 because our patient was diabetic, hypertensive, and she was a female. So it's a pretty high Chadwick score, 3. Meaning by which that she needs anticoagulation. At the same time, while calculating the Chadwick score, one must assess also the bleeding risk by doing the Hasbled score, which means hypertension, abnormal renal or liver function, stroke, bleeding history or predisposition, labile INR, elderly patient, or use of concomitant antiplatelet drugs or alcohol. In our patient, the Hasbled score is 0. She has got none of these risk factors. Now, one must note here that high Hasbled score is not a contraindication for oral anticoagulation, but it rather indicates more vigilance and regular review and follow-up. And this is a very important take-home message. Next, we look at the symptom scale. Now, our patient was complaining of palpitation. So, her case would be a 2B score, where she can continue the normal daily affected. It's not affected, but she's troubled by symptoms. Now, the other variants are if she was asymptomatic, we call it 1. If her daily activities were affected, we'd call it 3. And if the activity is absolutely discontinued, we'd call it 4. The symptoms one must look for in AF are the classical NYHA 4 symptoms of dyspnea, angina, fatigability, and palpitation. And apart from that, one must look for dizziness and anxiety. Now, we look at the severity of the AF burden. What is the temporal pattern of the AF? Is it paroxysmal, persistent, long-standing, persistent? Only time will tell in our case. And what is the total AF burden? That is the total monitoring period and how much of that total monitoring period the patient was in AF. So that will determine the severity. The most important but not the least is the substrate severity. And a very good article on this has been written by Vlachos in Prediction of Atrial Fibrillation Development and Progression, Current Perspectives. Now, there are certain scores here. One score to predict whether a person will end up with atrial fibrillation or not is the chest score. In our patient, among these risk factors, she is only hypertension. Now, our patient is already on AF, so this score is no more relevant in our case. But if you want to look at the development of the AS and progression of the AS, you can look at Hatch score, Latch score. These kind of scores are there, and the higher the number of the score, the more chance of the progression of the AF is there. One must also know that the Chadwick risk score independently predicts the recurrence of AF post-ablation. And this is another significant message. So it's not only a score for giving us the risk on stroke, but post-ablation, if the patient will have a recurrent AF or not, you can assess it by Chadwick score. Overall, if the patient has these kind of risk factors like physical inactivity, alcoholic, obstructive sleep apnea, so in our case, the patient had hyperglycemia and hypertension. So these are the risk factors in which AF is likely to be progressing. Now, next we can look at, as for the assessing the substrate severity, we can look at the biomarkers because there is a direct link between inflammation and atrial fibrillation. This is because post-CABG on day 2 and day 3, patients are seen to develop AF. So a host of, pardon?
Please mute your phones. There is noise coming.
Okay. So these are the biomarkers one must look at, namely CRP, IL-6, troponin, NT-proBNP, and D-dimer. So there's a role of biomarker in also in substrate classification in AF, and most important is imaging. Now, in the echo, it was already said that the patient had an EF of 70% with mild concentric LVH. But what we need actually in the echo report is the left atrial size, whether it is more than 40 millimeter or not, whether there is evidence of diastolic dysfunction, and if possible, the speckle tracing of the left atrium strain and stiffness index. One may do MRI to see the left atrial fibrosis, and one may also do an electroanatomic bipolar voltage mapping. And if there are evidence of reduced conduction, it suggests that there is evidence of fibrosis in atrium. So overall, atrial fibrillation can now be relabeled as fibrotic atrial cardiomyopathy. Now, thus, having diagnosed atrial fibrillation and looked after the characteristic in all these 4 parameters, we would look at the management part, and particularly we'll follow the ABC pathway. Mainly, we will talk about the anticoagulation part, better symptom control, and we'll take care of the cardiovascular comorbidities and risk factors. Now, one must understand that AF management now is an integrated process. So apart from the cardiologist, the general physician, pharmacist, and all the other super specialties are more or less involved in AF management. And as well as it's the patient-centered management. So one rule fits all doesn't apply to cases of AF. And each and every case should be individualized. So basically, the decisions that we are taking in our case is to go ahead with an anticoagulation, and particularly with NOAC. We'll discuss in detail why we are taking all these decisions. We will go for a rhythm control strategy in our patient. We will talk about the antiarrhythmic drug maintenance. We may discuss about ablation procedure also and the comorbidity management. Now, coming to anticoagulation, let's follow our patient's pathway. Now, she has got a Chadwick score of 3. So she requires anticoagulation. That's a class 1 indication. Now, why NOAC? We said that we would give her a NOAC. Why NOAC? Because meta-analysis of all randomized control trials involving NOACs showed a significant 14% reduction in major bleeding risk and 52% reduction in hemorrhage. So NOAC gives us much more safety over vitamin K antagonists. Second point is the time in therapeutic range is more than 70% usually with NOAC. That's not possible mostly with vitamin K antagonists. And NOACs also enjoy similar stroke rate reduction with vitamin K antagonists. But if you are using dabigatran 150 milligram twice daily dosage, it gives superior stroke prevention than vitamin K antagonists. But this is unusual dose. We don't really use too much of 150 milligram twice daily. And all-cause mortality reduction is to the tune of 10%. One must take care there is an increased incidence of GI bleeds with NOAC. Now, if you're still confused about using whether NOAC or vitamin K antagonist, you can apply this score, a same TTR2 score. And if the score is on the higher side, it suggests that you use NOAC in place of vitamin K antagonist. Now, in our case, she was female, the age was less than 60, where she was only 55, there's hypertension, diabetes. We possibly would use an antiarrhythmic drug like amiodarone, and she's a non-Caucasian. So the overall score out of 8 comes to be 6. And so NOAC is the preferred agent again. Now, after that, which NOAC? That's the second issue. Now, if you are thinking that your patient is at increased risk of thromboembolism and you want to give protection against embolism and ischemic stroke, so dabigatran 150 milligram dosage is the best. If you are worried about your bleeding risk in your patient, you should choose apixaban or edoxaban. If you are worried about GI bleed, you must avoid dabigatran. If you are dealing with an elderly patient, you should try rivaroxaban. If your patient is non-compliant and wants only a once daily dosage, you should choose either rivaroxaban or edoxaban. If your patient has a CKD or a renal dysfunction, it would be best to use a vitamin K antagonist. But if you're looking for a NOAC, you can use apixaban. If there is use of peripheral embolism, rivaroxaban. If there is history of MI or ACS, it's best to avoid dabigatran. And if you have to feed the NOAC through Ryle's tube, you should give apixaban, rivaroxaban rather than dabigatran. So again, decisions which NOAC. While using NOAC, you should be aware of the antidotes available. For dabigatran, it is idarucizumab. For apixaban, rivaroxaban, it is arenaxanate alpha. And if you're using all the NOACs, a new drug has come in the market, which is called ariprazine. But one must be aware of the disadvantages of NOAC. Particularly, I would like to highlight that NOACs are costly. And so when we are treating our patients, you should be, because these are all lifelong treatment. Patients' compliance is again important. The issues of drug interactions are there. extreme body weights, because most of our patients might weigh within 30 to 50 kg. We are not sure about the NOAC dosage in this kind of body weight range. So there are issues of altered GI absorptions are also there, and one must be aware the contraindications of NOAC. You should not use NOAC in mechanical valve prosthetic patients or patients with rheumatic heart disease with moderate to severe mitral stenosis. So these are the standard NOACs with the dosage. Now, one must be aware that using antiplatelets only is a class 3. That not should be done. Again, I would repeat that a high Hasbled score is not a contraindication for using oral anticoagulants. And the clinical pattern of AF, whether you are detecting paroxysmal, persistent, or permanent, each and every case of AF should be anticoagulated. So having just decided on the issues of anticoagulation, we now move on the next agenda. We want to use a rhythm controlling drug in our patient. So why? Simply because it improves quality of life. The patient is symptomatic. And of course, which are the other subsets you should apply the rhythm controlling. You must do try rhythm controlling in young age groups. First episodes of AF, if the patient has got LV dysfunction or tachycardia-induced cardiomyopathy. So all these issues need rhythm control. And it's a class 1 recommendation. So how to go about the rhythm control? Rhythm control basically means you're doing cardioversion. So there are two options. Either you can do pharmacological or electrical. Since our patient is hemodynamically stable, we would opt to go for a pharmacological cardioversion. So our pathway would be that the patient is not on oral anticoagulant and it's already 4 days over. She's been having palpitations. So from the history, the guesswork is that the AF duration is at least more than 48 hours duration. So the line of action would be either you have to do a transesophageal echo, exclude LA clot, and straight away apply the pharmacological cardioversion drugs or the antiarrhythmic drugs, or you apply anticoagulants in the form of NOAC and do rate control for 3 weeks. You have to wait for 3 weeks, keep the AF for 3 weeks. It looks funny, but that's what the guidelines suggest. Then try pharmacological cardioversion and continue lifelong anticoagulation. Of course, there is a shortcut in between. One might try to do a transesophageal echocardiography to exclude LA clot and try pharmacological cardioversion, but that's not recommended. There are a host of cases where transesophageal echo has shown that there is no evidence of LA clot, but patients on this type of management strategy have ended up with a cardioembolic stroke. So either you do a transesophageal echocardiography, exclude LA clot, and do pharmacological cardioversion straight away, or you wait for 3 weeks with rate controlling agent, and then after 3 weeks of anticoagulation with NOAC, as in our case, we apply the pharmacological cardioversion. So for rate control, we use beta blockers or non-dihydropyrin calcium channel blockers. Now, coming to the pharmacological cardioversion, we would want to do it with one of these drugs, antiarrhythmic drugs. Well, my choice would be using flecainide. And if you are in a hurry to cardiovert, or if you feel that your patient might deteriorate hemodynamically, so you apply it IV. So IV flecainide, propafenone, or varnacalant, or IV ebutylite would be the drug of choice for pharmacological cardioversion in AF. Now, if you have time, you can apply amiodarone. Amiodarone does cardioversion very efficiently also, but it compared to these agents, the action of amiodarone is slightly delayed. So also one must be aware that interactions of amiodarone with dabigatran is there. Amiodarone increases bleeding risks of dabigatran. So one must be aware when using this kind of combination. So use of varnacalant, flecainide, or propafenone is class 1 indication. Again, use of amiodarone is again class 1 indication. And you can apply pharmacological cardioversion in hemodynamically stable patient, as in our case. Now, if you want to facilitate electrical cardioversion by using an antiarrhythmic drug, so that's a class 2A indication. And oral cardioversion with pill in the pocket therapy is also a class 2A indication. So it's also a pretty good strategy to use in patient for achieving rhythm control. Now, coming to the issues of catheter ablation, because we want a rhythm control strategy in our patient. So only patients with reduced ejection fraction or patients in heart failure, they enjoy a class 1 indication, as well as patients who have already been tried on drugs and failed drug therapy. So these are the subset of patients in whom you can recommend catheter ablation. Since our case is only for 4 days and it's a first diagnosed AF, now we would try to stick to the pharmacological cardioversion with antiarrhythmic agents and oral anticoagulants. Of course, we will discuss the issue of catheter ablation with our patient, but as of now, that's not our strategy. So catheter ablation also is not without its risk. There are a host of complications you can accept, and the issues of proceeding anticoagulation after catheter ablations are also there, and that has to be done with following the CHA2DS2-VASc score risk. So maintenance, now we come to the maintenance. We would like to use amiodarone. That's one drug which you can use. It's easily available, which you can use in patients with structurally compromised, structurally damaged heart, with patients with reduced ejection fraction. If you're using class 1A or 1C agent, one must be aware that there should not be any structural heart damage or structural heart disease. Severe left ventricular hypertrophy is also supposedly one of contraindication for using class 1C agents. Also, there are a host of papers where people have used these drugs, but reduced ejection fraction is an absolute contraindication for using flecainide or drugs like propafenone or QT prolonging drugs. So these are the recommendations. One, you can use amiodarone, dronedarone, flecainide, propafenone. So these are the drugs. But of course, you must understand that in permanent AF, which you have decided, please don't use antiarrhythmic drugs like amiodarone. We sometimes come across patients of rheumatic heart disease with MS in which patient is getting amiodarone. So it's a futile attempt, and it just increases toxicity. So my key take-home message from this wonderful short case is that atrial fibrillation.
Please sum up. Please sum up because we are running late.
This is the last slide. So atrial fibrillation, it's a progressive disease with increased morbidity and mortality. Prevention of arrhythmia progression is therefore of paramount importance. An intense rhythm control strategy which prevents structural and electrical remodeling. Okay. So I thank you. I thank you for giving me time and for your attention. So thank you all.
So thank you, Dr. Ghosh Dossidhar, for your excellent presentation. For want of time, we cannot allow any questions. So I declare the session closed and we go to the next session.
Thank you, sir.
Proceed to the next session.
So our next session is PVC and NSVT when to address. Our chairpersons are Dr. Anjanal Datta, our President-elect, Dr. P.P. Mohanan, Dr. Vishwakesh Majumdar, Dr. Shantanu Guha, Dr. Dipankar Mukherjee, and Dr. Alokmer Sir, Dr. Azizul Haq, Dr. Debobroto Roy, and Dr. Ashit Das. Our chairpersons are present?
Yes.
Dr. Anjanal Datta, Dr. P.P. Mohanan is there, Dr. Shantanu Guha,
everyone. Yeah, he's there.
Dr. Vishwakesh Majumdar, and Dr. Dipankar Mukherjee.
Yeah.
Dr. Alok Majumdar, and Dr. Haq, and Dr. Roy, Dr. Debobroto Roy. So let us proceed for our.
Hello, Dr. Narasimhan. Hello, Dr. Narasimhan.
Hello, sir. Good evening.
Yes.
How are you?
Good evening.
Good evening. How are you? I am
Nice
fine.
to see you.
Thank you so much.
Yeah.
So nice to meet.
Yeah. So now we have probably the number one or one of the number pioneer in the electrophysiological studies, along with clinical cardiology, and that is how Narasimhan is so important for us, because it is not just on the complex network of electrophysiology, but he touches upon the clinical aspect as well, so making it more digestible and easily acceptable to most of the cardiologists. He will be talking on approach to PVC and also probably NSVT. I think with the consent of our co-chairs and moderator, we can invite Dr. Narasimhan to start the deliberations.
Good evening, chairpersons. It's indeed a great honor to be presenting to all of you. I really enjoyed the talk on atrial fibrillation that was presented previously. I wish we had a little more time to discuss. Anyway, the topic I was assigned to talk about is approach to PVCs. That's a common clinical problem. And let us see how to go about it. First of all, the task is like when your person presents with PVC, it's an indication that something is not right. So you need to investigate this person a little more closely before just starting on amiodarone or a beta blocker, as the case may be. PVC, is it a benign disorder in an idiopathic PVC in a young person like an athlete? Or is it a sign of a more serious disorder? Secondly, you need to understand, are there any ECG characteristics which you can predict this is going to be a low risk versus a high risk PVC? Now, why are PVCs important? This is the natural history study. This is a famous study by Dukes, which was published a couple of years ago, saying that across the board, whenever patients don't have PVC, compared to them, those with have increasing degree of PVC ambient ectopy, their future risk of developing heart failure is high, as well as sudden cardiac death and overall mortality is high. Now, does it make a difference whether the PVC is present at rest or during exercise? So this is a work which was published years ago in New England Journal of Medicine. Compared to people who don't have PVCs, patients who have PVCs that happen only during exercise, which disappears during rest, this is the survival. And during recovery, this is the survival. If they have PVC both at rest and during exercise, their mortality is very high. Now, what about what causes the PVC? Basically, it could be a multiplicity of factors in the myocardium. There is a conduction delay due to fibrosis, but it can be microfibrosis, which we don't pick up on a routine echo. It can be abnormal automaticity because of stretch. Commonly, the stretch is in the His-Purkinje system or in the papillary muscles, which cause. This is the reason why during an acute MI, when the LV dilates, you get a frequent PVCs. You put an IABP and do an angioplasty, immediately everything may settle. Structural abnormalities. Refractory period becomes very short. This is common in some of the toxic conditions which can cause PVCs, and delayed after depolarization. And why is it important? Because some of the common conditions like we see in clinical practice, like diabetes, hypertension, obesity, obstructive sleep apnea, can cause a myriad of pathological disturbance in the myocardium, and they can cause frequent PVCs. For example, when you control diabetes with secretagogues like glibenclamide or with insulin, they do not affect the conduction abnormalities or structural abnormalities. The only drug which probably does something to this is SGLT2 inhibitors. Similarly, when you give antihypertensive drugs like alpha blockers, they don't cause any change in the structural abnormalities, whereas ACE inhibitors and beta blockers are very effective. Adipokine release because of epicardial fat can cause this kind of a problem. Obstructive sleep apnea can cause this kind of frequent PVC. So let's see, this is a patient who was referred to us with frequent troublesome PVCs, and the patient was referred to us for catheter ablation. She underwent a catheter ablation about 6 months prior and was started on antiarrhythmic therapy with beta blockers, didn't work very well. Now, the clue was the postgraduate who took the history that this patient was running back from work and was preceded by palpitation. And this is an exertional PVC, never present at rest, and there is a family history of sudden death. When you see a PVC, the most important beat is after the PVC. When there is a long pause, suddenly the T wave becomes very tall. Compared to the T wave after that, the T wave becomes very tall, the QT becomes very wide. This kind of post-pause PVC prolongation, the QT, is typical of a long QT1 syndrome. So you are concentrating on the PVC, but the real problem is here, which is a long QT, and the patient does not need any ablation she needs escalation of her beta blocker, everything will settle down, or you need to address the other conditions. So, second, 68-year-old person, effort tolerance, 2 flights of stairs, and PVC was very symptomatic. Angio was done, was normal. But whenever you see this kind of varying morphology of PVC, one is left axis, one is right axis PVCs, both coming from very close to the fascicle because you see everything is very narrow. Thirdly, look at the company it keeps. The company it keeps is a poor or a progression with, you can see, a fractionation of QRS in V2. Everything suggests this is not a benign PVC. This patient has got myocardial scarring based on the ECG, even though angio is normal. On further evaluation, this was found to be a cardiac sarcoid, and that makes a huge difference in patient management. This is a 63-year-old hypertensive diabetic, no CAD, mild CAD, non-smoker, and he had a mild LVH, and this was what the ECG shows. You can see that there is a significant LVH, significant PVC density, and this patient was started on different drugs, including amiodarone, nothing worked. And some of these PVCs, when they're very frequent, more than 25% in a day, over a period of time, they can cause LV dysfunction. So the PVC can be a marker of a disease, or PVC by itself can cause further LV dysfunction. How do you decide whether it's the cause or the effect? When you see LV dysfunction of short history and patient has frequent PVC, preserved wall thickness, if there is absence of gadolinium enhancement on MRI, these things suggest that the PVCs are responsible for the LV dysfunction rather than the other way. And usually it is associated with a high PVC burden, and usually the PVCs are very wide in width. Now, how does the PVC cause LV dysfunction? If you have a PVC 25% of the time, you find that the PVCs produce a significant dyssynchrony in a beat that occurs during PVC and the beat after. So this kind of a frequent LBBB or dyssynchrony in the ventricle can cause abnormal ventricular mechanics and cause LV dysfunction. More importantly, these patients are very symptomatic, and following abolition of PVC by whatever means, you find that the LA diameter comes down and their diastolic function significantly improves. This is an important reason for patients visiting us. When the patient comes to us, they have significant effort intolerance or dyspnea or fatigue, but their LV function looks normal. But if you look at the diastolic indices, they are significantly abnormal. E by E prime is more than 15. It comes to almost 10 after abolishing the PVCs. One of the clues that this can happen is when you see a PVC and the good old clinical sign of post-extrasystolic pause, that is usually associated with significant recruitment of LV, and this patient is likely to improve if you get rid of the PVC. LV function is likely to improve. This is a classic example of a young adult with uncontrolled PVC despite multiple combination of therapy. You can see a left axis PVC, looks epicardial because of a pseudo delta here. We found that the PVC was coming from near the middle cardiac vein. After ablating it epicardially, everything became normal. EF from 40% has become 60, is off of all medication. But there are pure electrical disorders which are malignant. This is a first publication which was from France, where Lienhardt looked at, are there any electrical characteristics which differentiate who's going to die, who's going to survive? If you have a very short coupling interval below 300 milliseconds, and if it falls on the T wave, they predict a higher risk of PVC. You need to investigate this person. This doesn't mean they need an ICD. They may have a benign tubular disorder, for example, like Gettleman syndrome. Renal tubular disorders can present with this kind of a PVC, or an Ayurvedic drug that the patient can take can present with this kind of PVC. So you need to investigate this patient and get rid of the offending agent. The other thing, as I said, is when you have a PVC, always look at the beat following the PVC. Now you see a big T wave in the normal beats, but it's completely abolished in the beat following the PVC. Post-PVC T wave abnormalities suggest that there is some degree of myocardial fibrosis, whether it's severe hypertensive heart disease or coronary artery disease. We need to investigate further. The CAST trial has shown that without understanding the substrate, if you mechanically suppress the PVC with a drug like flecainide, more patients will die. You need to treat, investigate and treat the patient and understand the cause. The second electrical abnormality, which predicts high risk, is when the coupling interval keeps varying. See, for example, a longer coupling interval, a shorter coupling interval, longer coupling, shorter coupling. So when you have a varying coupling interval and a short coupling interval, it portends a high risk characteristic of polymorphic VT and VF. So even if a person has a normal looking ECG, but the QT, I mean, the T wave falls, the PVC falls on the T wave, or if there is a varying coupling interval, you need to consider it as a malignant PVC. This is a famous publication which was published in JACC, highlighting the fact that patients with varying coupling interval generally have a parasystolic foci, and they'll have a varying coupling interval, but interectopic interval may be normal, and they have a higher risk of causing future problems in terms of LV dysfunction or sudden cardiac death. Some of the clinical clues are like fractionation of the QRS or a fascicular block. When you see it in patients who have frequent PVC, you need to investigate these patients further. Now, when you have PVCs which are of varying morphology, but they suggest some kind of a fascicular origin. Fascicular origin is predicted by narrowness of the QRS complex. During PVC, the initial onset is very rapid, suggesting, and the QRS duration is very short, suggesting it's coming from one of the fascicles. When you see frequent PVCs coming from the fascicles, it suggests either a digitoxicity, or if a person has altered magnesium levels, this can happen. Again, the first case that I said, the patient finally was actually genotyped to have a long QT1 and did very well with beta blockers. Everything became normal. Now, we forget why we are doing this practice of medicine, because there's so much of push to reveal ICD. For example, this lady was asked, she had recurrent presyncope, but no syncope at all. She had frequent palpitation, presyncope, near blackout, but no true syncope. And this patient was on metoprolol and statins for a minor CID. And this was the ECG. Whenever, I mean, the rhythm strip during Holter shows a varying coupling interval, you should consider it as a malignant PVC. For example, this patient, if you had put an ILR, she would have died with an ILR with this kind of a problem. You may make a diagnosis later on. This happened with an ELR within 7 days of fixing the PVC. So we tend to believe that ILR solved the problem, but actually this clinical characteristics was right there, right in the beginning in this patient, that there's a presyncope and there is varying coupling interval on the initial ECG that should have suggested that you should act rather than monitoring the patient again and again. I'll give you a classic example. If you have a CHADS3 in a person and the patient has had a stroke, and what looks like embolic stroke, if you do a ELR for 2 weeks, you may not pick. But if you do for 2 years, you'll pick an AFib. But by that time, the patient might have developed a second stroke. So you need to take the clinical thing into context rather than monitoring this longer and longer. And this is a straight line. So if you have a PVC frequent, if echo is normal, some patients with high risk characteristics, we may have to do a cardiac MRI or subtle echo abnormalities which are missed out, or you need to look for TAPSE. You need to look at whether there is a regional decrease in strain rate in the echo. Focal hyperechoic areas, especially in the papillary muscle or moderator band, suggest that that patient's PVC is probably malignant. And stress tests to induce polymorphic VT can be made out of certain conditions called CPVT only on exercise stress testing. When you have a patient with an incomplete bundle branch block, it can be either athlete's heart or ARVC. ARVC will always be with associated prolonged signal average signs, whereas athlete's heart will be normal. And look at the PVC burden in patients, or whether it's complex PVC in terms of varying coupling interval and morphology. If that is the case, you need to consider a person to be a high risk of sudden cardiac death and take appropriate measures. This is a very elegant work which Debabrata did when he was with us. He looked at patients who were referred for ablation, about 40 patients. They were all evaluated and referred for ablation. And he picked up that if a patient's baseline ECG has a fascicular block in what looks like idiopathic VT, where MRI, everything was normal, presence of QRS fragmentation, fascicular block, or low QRS amplitude, if any of these three signs are present, then it's more likely to be cardiac sarcoid. Whereas if all of them are negative, it's purely an idiopathic VT, you can proceed with ablation. Whereas if you suspect sarcoid, this patient would require steroids and no ablation. Is a very nice manuscript that he had put together. So if you have frequent PVCs and the patient is symptomatic, look for structural heart disease by ECG, echo, and MRI. The evidence of a structural heart disease on ECG may be LA enlargement, if a patient has poor R-wave progression, incomplete bundle branch block or fascicular blocks, or fractionation of the QRS. All these things on ECG should make you suspect that the patient has a structural abnormality. Even if echo is normal, they need a cardiac MRI. You need to pick up whether there's an LV dysfunction, either systolic or diastolic, coronary artery disease, HCM or DCM. In DCM, presence of scar and frequent PVCs mandates that need an ICD. If there is no scar and PVCs are there, dilated cardiomyopathy, you may manage them medically very well. In the absence of structural heart disease, if a patient has frequent PVC, generally most of them are benign. Either anxiety, lack of sleep, REM sleep, if it is disturbed, they can cause this problem. But if the coupling interval is short and varying, if PVC is present both during exercise and recovery, if there is pleomorphic PVC or non-sustained VT, then it is not benign. You need to investigate this patient further. So, in conclusion, Chairman, ladies and gentlemen, what are the broad principles? In all patients who present to us with PVC, please evaluate the patient clinically with just basic tools of ECG, echo. If there is any suggestion that it could be underlying CAD or cardiomyopathy, we need to investigate them further. For a vast majority of patients, beta blocker is good enough. For patients with long QT and frequent PVC, the ideal beta blocker is propranolol and not metoprolol. For fascicular PVCs from left ventricle, calcium channel blockade works very well. For symptomatic PVCs that is unresponsive to medical therapy or which causes PVC-induced cardiomyopathy, you can consider RF ablation in that substrate. In patients with low ejection fraction due to coronary artery disease or hypertrophic cardiomyopathy, normal LV function, if the patient has frequent PVCs or non-sustained VT, you need to risk stratify this patient for sudden cardiac death and consider ICD, because the PVC may be a marker of a sudden cardiac death. Suppressing the PVC with drugs will not solve the problem. I think I'll stop here. And again, thank the organizers for the kind invitation for this wonderful meeting. Thank you very much.
Thank you.
Dr. Narasimhan, because this is a very, as you said, a very commonly encountered problem. And as you rightly said, the risk stratification should be based on the frequency, complexity, and the hemodynamic response. One foolish question, Narasimhan. What will be, you said about the burden of BPCs in a structurally normal heart. will you touch on the 25% thing before you start pharmacotherapy, or you have some other guidelines?
What we have realized is we spend a lot of time evaluating the third patient. Unfortunately, I didn't put the follow-up. The third patient I presented with hypertension and 25% PVC was going around different centers. He was on amiodarone, unresponsive, referred for ablation. All that we did was we corrected his sleep apnea and repeated the Holter 3 months later. So when we correct a sleep apnea, there is something called periodic limb movement, PLM they call it. It takes about 2 to 3 months to improve, and it doesn't improve in a day or two. And we are little, so it is very difficult to generalize the treatment. This 25% is reliable only if you have ruled out all the other organic causes for this.
Thank you.
So is there any relevance of RV origin or LV origin in PVCs?
Right. For example, RV origin, if you have PVCs and the family has a history of dilated cardiomyopathy, this is the only condition where you would like to restrict the physical activity. Because if it's signs of, if you see minor sacculation, you need to ask the echocardiographer to take a modified inflow view and look at the tricuspid valve and the area around it. Generally, we find some sacculations there or a little hyperechoic moderator band. If you see these signs and the RV origin PVC, you need to consider it's an early ARVC, and most important treatment is avoid aggressive exercise. Split the exercise thrice a day, 15 to 20 minutes each, instead of doing prolonged exercise, and then you need to re-stratify for scarring and so on. That may be an early indication of ARVC.
Yes, epicardial PVC and Purkinje PVC, these are more dangerous. You have already told.
Very important. Epicardial PVC, because it's coming from epi to endo, it takes a long time to reach the endocardium and engage the Purkinje system. So the PVC tends to be very wide in amplitude, width of the PVC, and they have a higher tendency to produce LV dysfunction and cardiomyopathy compared to ones that comes from endocardium. Purkinje related PVCs have a greater risk of producing sudden cardiac death. Having said that, I have seen quite a few patients with endocardial PVC from Purkinje fibers due to muscle. They give it now in a lot of things to build up the muscle, like for example, cocaine or marijuana. These toxic substances or some of the anabolic steroids can cause this kind of a problem. You need to be watch out. Look at the cause and treat it adequately. So epicardial, more cardiomyopathy, endocardial, more risk of sudden death.
An epicardial treatment, probably ablation is difficult sometimes.
Yes, so we need to find out why the patient has epicardial PVC, and our experience indicates that it's so tuberculous pericarditis. It doesn't involve the pericardium alone. Just beneath the pericardium, if there is a layer of fibrosis in the subepicardial layer, this patient will come back to us later on with epicardial PVC. So it's generally a sign more often due to granulomatous disease or some of the cardiomyopathy.
Thank you. Thank you.
Thank you very much. Thank you.
When you have a PVC of different morphology, pleomorphic as you call it, and when you have PVC with a different coupling interval, I think more important is the coupling interval than the configuration of PVC. Is it correct?
That's right. So when you see a varying coupling interval, it indicates parasystolic focus, which is protected.
Yeah.
When you see varying complexity, it indicates diffuse myopathic process, either in terms of sarcomeric mutation or in terms of a granulomatous inflammation.
Regarding NSVT, casual NSVT is a frequent finding in the Holter monitoring without any suspicion. What is the relevance of those NSVTs?
So if you see in a completely benign NSVT for many years, this used to be reported as Gallavardin phenomenon several years ago. They can go on for years and years without LV dysfunction. Typically, this is RVOT morphology. Most important is echo imaging to make sure that TAPSE and strain rate imaging, everything is normal. Make sure there is nothing else that is masquerading as idiopathic PVC.
I think we can conclude now. Anjana?
No. Hello.
Thank you very much.
I asked the Maulisa.
Thank you very much.
Hello, Maulisa.
Can I ask one question, Ramajendra?
Call it a day and thank you very much.
Okay.
This one.
Hello.
Yes.
Hi, this is Dr. Malvi Shah. Hello.
Yeah.
How are you?
Oh, fine. Have you got any question?
No. Am I the next speaker?
Okay. You can continue now.
I think it is time to conclude. So let us conclude this session and move to the next one. To Dr. Jayanta Shah, please.
Hello.
Jayanta, just go ahead.
So our next session is SCD conclave. First we have Dr. Shomu Bora. Our chairpersons are Dr. Robindranath Chakraborty, Dr. Sukumar Ghosh, Dr. Bijoy Prakash Pandey, Dr. Debashish Banerjee. And we have the moderators, Dr. Siddhartha Bandyopadhyay, Dr. Debobroto Bera, and Dr. Suchit Majumdar. Shomu, you can start.
Yep. Okay. A very good evening to all. Thanks for the invitee. It has been a pleasure to be preparing for this lecture. And after following Dr. Narasimhan's elegant talk, I would be suggesting some ECG features of sudden cardiac death. So we'll not include PVCs in out there. So obviously of a variety of causes of cardiac disease which can cause sudden cardiac death, how do we risk stratify these? And of the many investigations, ECG is the most easily available as well as the cheapest of them. So you have echo, you have to have a functional class status, the etiology, and the genetics also, but then definitely an ECG is the easiest to risk stratify. The scope of ECG in sudden cardiac disease is vast, so we are not including arrhythmias which include brady or tachy, we are not including acute ischemia, and we are not including Holter as well as other special markers like heart rate variability and others. So we are sticking to the ECG risk assessment on non-urgent settings only. So in cardiovascular mortality, the ECG can be divided into the presence of QRS duration fragmentation, ST segment changes, bundle branch block, PVCs, hypertrophy, QT interval, and the morphology of the T wave as well as the P wave. So we'll divide this topic into three. When you have a ECG with an abnormal echo, when you have a ECG with normal echo and symptoms or family history present, or you have just an ECG with no symptoms, a normal echo and no family history. So let us see an abnormal echo finding, and the first and foremost and the most common would be an MI and ECG changes to risk stratify sudden cardiac arrest. So this is an old MI, more than 5 years back, and the patient presents with dyspnea on exertion. How do we risk stratify such an a patient with such an ECG? So what are the pointers which suggest higher risk? The pointers being a wider QRS, the QRS duration of more than 110, 120 milliseconds, and the presence of LBBB and PR prolongation and a notched QRS in such a setting, which will suggest higher risk. But in a recent MI, just 2 weeks back, with no chest pain, and if you have a ECG which shows that there are multiple leads which show Q wave with poor R wave progression, you can see that the QT is prolonged, there is persistent ST elevation, and there is T wave inversion. Such patients would be at higher risk. So what are the risk factors in patients with old MI? The presence of wide QRS, PR prolongation, fragmented QRS except the V1 and AVR leads. Presence of left bundle branch block is more as compared to right bundle branch block. Persistent ST elevation, QT prolongation, T wave inversions, Q waves in more number of leads, and poor wave R wave progression. Positive T wave in AVR and an abnormal QRST angle is also considered to be at a higher risk. So approach to such a patient will be definitely doing an echo, and the ejection fraction showing the magical figure of 35% has been suggested as the best predictor to say for sudden cardiac death. However, please do not rely only on the ejection fraction. There are other features that are there, which includes ECG and also the history of syncope and the functional class. What about in patients with non-MI structural heart disease, which includes cardiomyopathies and myocarditis? So let us see examples. This is a patient who has presented with breathlessness, and what you find is low voltage in the limb leads, less than 5 millimeter, and you have a higher voltage in chest leads. There is a left axis deviation, PR prolongation, and atrial enlargement with a late transition. So in DCM patients, this may be the presentation, while the degree of left ventricular hypertrophy, the presence of ST depression, and the presence of strain would be a suggestion of a significant LVH. The presence of wider QRS, the presence of left axis deviation, as well as atrial enlargement would add on to the risk in patients with HCM. In patients who present with cardiomyopathies, and if you find that there are intraconduction defect, or if you find this kind of epsilon wave with STT changes, wide complex, then you should suggest of infiltrative cardiomyopathy or RV cardiomyopathy. And patients who present acutely with acute symptoms basically and have sinus tachycardia, so presence of sinus tachycardia, bundle branch block, abnormal Q waves and STT changes in acute myocarditis settings suggest high risk. Of all of these presentations, what are the highest risk patients? So if you have very low voltage complexes in presence of a dilated heart, or even in presence of hypertrophy, which suggests more of fibrosis, suggest high risk. Abnormal broad QRS with axis shifts or PR prolongation, and fractionated QRS with abnormal Q waves suggest high risk patients. So this is an example of very low voltage complexes, and what you can see on echo is bilateral involvement, LV dysfunction as well as RV dysfunction, and very thin walls. In a patient with HCM, you have this kind of fractionated potentials. Absence of actually LVH will signify high risk. And you can see this fibrosed septum nearly. A patient who has LV dysfunction showing very broad, more than 200 milliseconds with PR prolongation and atrial enlargement is at very high risk. So Strauss et al. Showed that a QRS score, which includes the QR and S wave amplitudes, duration, and notches, in all leads except V1 and AVR, helps in identifies and quantify the scars in ischemia and non-ischemic cardiomyopathy, and people who have higher scores have more chances of arrhythmia. Now, coming on to the next part, which is in patients who have an echo which is normal, but they have symptoms or they have family history. That's very important. And the first and foremost that we see in clinical practice would be a short PR interval, delta wave, and a QRS being wide, which is classical of a WPW ECG, and a patient who has had syncope on history, right posterior pathways, or suspicion of multiple pathways, and pre-excitation, which is present at higher heart rates, which come at high risk. The lower risk patients would be patients who have intermittent pre-excitation. In patients who actually have exertional syncope, it's very important to see an ECG, because most of them end up with a neurologist initially, but even after giving treatment for seizures, if the syncope or seizures persist, an ECG should be done. And this is an example of one such patient who had a QT prolongation as a presenting feature of syncope, exertional syncope. The QT interval of more than 500 milliseconds, presence of sinus bradycardia or notched T waves in more than T3 leads, or the presence of T wave alternance characterized by alternate T wave being inverted and positive as seen in this example suggest very high risk patients, and definitely a presence of torsades spontaneously on monitoring is at a very high risk. The opposite of long QT, not very commonly seen, is this patient with a short QT, which is characterized by a QT interval of less than 320 milliseconds. Atrial fibrillation is a common presenting with pleomorphic ventricular arrhythmia. Not to mention that a Brugada is not really uncommon in our patient population. The presence of a classical ST elevation in V1, V2, V3 and a 2 millimeter with T-wave inversion suggests a classical Brugada pattern. Now, this is one common subset that we find, that patients with early repolarization abnormality, and you find that there is a J-point elevation in anterolateral leads with ventricular ectopics. So how do you risk stratify them, and what are the indicators of higher risk? Is when you have this J-point elevation, which is more than 2 millimeters in inferior leads more than the lateral leads, and they are actually downsloping at the end of 80 milliseconds. So if you have a downsloping J-point and the patient presentation is more in inferior leads, they are at higher risk. The ECG may be normal, and as mentioned by Dr. Narasimhan, if you make an exercise, you actually get them to an arrhythmia, and this is a classical bidirectional VT of a CPVT patient. So if you have such patients, you need to really go after them and treat the condition to decrease the risk. Now, the most common patients that we find are patients who just present for risk stratification, who have no symptoms, no family history, and they have a normal echo. And you need to do a multitude of tests to risk stratify them, but we'll concentrate only on ECG. This is a patient who was asymptomatic and presented with this ECG. So are there any high risk features? An abnormal QRS-T axis. So if the QRS is positive here with the T wave which is inverted more than 1 millimeter, then it suggests high risk. In an asymptomatic young thin individual, if you find presence of Q waves which may be physiological but a higher voltage, it may be a subtle sign of something. So in a normal subject, if you have, what are the indicators that you should raise alarm? The QRS duration being 110 milliseconds, the QRS-T angle which is more than 100 degrees, a QTC interval of more than 440 milliseconds in men and 460 milliseconds in women, presence of left ventricular hypertrophy, presence of early repolarization with more than 2 millimeter being more significant, especially in the inferior leads, and presence of T-wave inversion more than 1 millimeter other than AVR. So in a Finnish study, it was studied that if you had one or more abnormal ECG, the risk was higher. And if you follow these patients over a 10 to 30 year period, and if you have more than 2 ECG abnormalities of the above, then the risk is much, much higher as compared to no ECG abnormalities at all. So the rationale was a QRS duration in which a 10 millisecond prolongation of QRS duration increased the risk by 18%. And if the QRS duration is more than 110 milliseconds, the risk is 2.5-fold as compared to a normal QRS duration. Abnormal QTC may signify a genetic or a structural abnormality. LVH promotes fibrosis and arrhythmia and increases the ischemia if there is coronary artery disease. Again, an abnormal QRS-T angle as well as T-wave inversion may be the first sign of subclinical coronary artery disease or left ventricular hypertrophy. Other markers in general population may include late transition in V5, a P-wave which is abnormal, which includes notching of the P-wave and a deep terminal negativity. And it may suggest that there is an increased chance of atrial fibrillation, heart failure, and stroke. There is some role of AI which is emerging in ECG now, and nowadays if most of the Western companies are coming out with algorithms which will scan up your ECG, will dissect the various QRS, QT interval, T wave, and it will feed it into a machine, a database, and what will come out is a report which will say that you are at normal risk or at a higher risk. So the future may be different. You need not individually see, just feed it into the AI program and then you get the risk stratification done. So Concluding, ECG in relation to symptoms, disease diagnosis, echo finding, and family history is important, not individually ECG per se. ECG criteria of sudden cardiac death are non-specific in structural heart disease, where echo and the initial diagnosis, the cause is more important. The ECG criteria of sudden cardiac death are specific for channelopathies, especially long QT and Brugada, where type 1 or the degree of QT prolongation is important. And ECG risk in general population is based on symptoms, echo findings, and the number of abnormalities that the ECG presents with. Thank you for your patient listening.
Thank you, Dr. Somu, for that nice presentation. We will have the discussion on this at the end of the session. So now we have Dr. Molly J. Shah, who is a pediatric cardiac electrophysiologist in the Cardiac Center at the Children's Hospital of Philadelphia. She is also a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She has a special interest in adult congenital heart disease, catheter ablation, novel catheter and device technology, inherited cardiac channelopathies, and sports participation. Thanks, madam, for accepting our invitation on behalf of CSI West Bengal branch for this talk. Let's begin the talk.
I just want to confirm that you can you see my slide?
Yeah. Yes. Yeah, it can be seen.
Okay, great. Thank you very much. Good evening to all of you. It's about 10 o'clock in the morning here for me, and it's a beautiful day in Philadelphia. I want to thank Dr. Majmudar especially for extending this invitation to me.
Thank you very much.
Okay, so let's begin with a little bit of a historical perspective. Sudden death in the young, especially related to long QT syndrome, was first described all the way in the 1950s by Jervell and Lange Nielsen, who noted that certain children with deafness were dropping dead. Followed 10 years later was the report by Dr. Romano and Dr. Ward in Ireland, where they noted that children were dropping dead even without deafness. And when they recorded their electrocardiograms, you can see that they had massively prolonged long QT intervals. Fast forward to 2020, we have now come full circle with genetic discoveries of these syndromes, and we even now have the ability to culture a patient's individual cells and design gene-specific and patient-specific therapies. So for an overview here, long QT syndrome, as you know, is a familial cardiac channelopathy with an incidence of 1 in 2,000 individuals. It affects individuals of all ages, from fetus to older adults. And the hallmark is a prolonged QTc interval on the EKG. The syndrome is associated with malignant ventricular arrhythmias, syncope, seizures, and sudden death. From a genetic standpoint, the inheritance is autosomal dominant, but can also be recessive. And to date, there are 16 genes associated with the syndrome. Over 60% of patients can be genotyped by commercial testing, and the syndrome has gene-specific features. Despite the discovery of novel genes, 75% of long QT syndrome is caused by mutations in the potassium channels, KCNQ1 and KCNH2, which are also known as long QT type 1 and 2 respectively, and also the sodium channel, which is the SCN5A mutation. And I'm not going to take too long in describing an action potential to cardiologists in the audience, but I think it's very important to understand the cellular basis of long QT syndrome and how the channels govern the action potential to really understand risk stratification and gene-specific therapies. So as you know, the action potential arrives from the neighboring cells through the gap junctions. The sodium channels are then activated. Once the sodium channels open, there is a large influx of sodium into the cell and a minor influx of calcium, causing the beginning of depolarization. This is followed by inactivation of the sodium channels and continuation of the plateau phase of the action potential, and this is mainly maintained by an influx of the calcium channels, followed by phase 3 of the repolarization, during which there is exit of potassium channels from the cells, and this period continues until the end of repolarization. So to sum this up, long QT syndrome is really a function of channel pathology, so that there is gain of function in some of the cardiac channels, such as the sodium channels, where the sodium channels therefore fail to close and sodium keeps leaking into the cell, and loss of function of some channels, such as the potassium channels, where the potassium channels fail to close, and therefore the repolarization process cannot terminate. This produces a prolonged action potential, and when early after depolarizations arrive in the vulnerable period of repolarization, this sets up a perfect milieu for Torsades-de and other ventricular arrhythmias. So now let's move on to the clinical diagnosis of long QT syndrome. From a clinical standpoint, the diagnosis is made on a scoring system that includes ECG findings, clinical history of syncope or cardiac arrest, a positive family history of long QT syndrome. And by this scoring criteria, we can assign a low, intermediate, or high probability of having long QT syndrome, and a score greater than 3 usually is sufficient to make the diagnosis. Now, the starting point of long QT syndrome evaluation is really the story and not the EKG. So anytime we have a young patient with no structural heart disease who passes out, a thorough history is mandatory. Red flags for long QT syndrome-associated syncope include sudden syncope, typically without a prodrome, which is associated with exertion, emotion, sudden auditory stimuli, or in the postpartum period for women. This is an example of a 12-year-old boy who passed out consistently whenever he was asked to perform in a music recital, and this was chalked off to a case of nerves. When we implanted a loop recorder and he passed out during another response, we saw that he was in fact passing out, yes, a case of nerves, but also Torsades-de. The ECG remains the cornerstone for the diagnosis of long QT syndrome, and the corrected QT interval is calculated most commonly using the Bezet's formula. Very briefly, the end of the T wave can be determined by the threshold method as shown here, or when T waves are flat or indistinct, the tangent method can be used. Over the past decade, several cutoff values have been suggested for the abnormal QT interval. However, you can see from this graph that there is significant overlap between normal individuals and long QT carriers, and therefore the older cutoff of 440 milliseconds will produce significant overlap, and current international guidelines for the diagnosis of long QT syndrome is really 480 milliseconds to 500 milliseconds in asymptomatic individuals, and a cutoff of 460 milliseconds or above in patients with symptoms or a family history. Now, know that up to 30% of patients with long QT syndrome who are gene carriers have either a normal or a borderline QT interval, and we refer to these patients as those having concealed long QT syndrome. So here are the provocative tests that you can perform to manifest the concealed QT interval, and these include an exercise stress test, a stand-up QT test, and an uncommon test that is pretty much out of clinical practice, which is the intravenous epinephrine test. The exercise test is probably one of the most useful and easily done provocative tests, and it also shows genotype-specific responses. Compared to controls, in patients with long QT1, including those with concealed long QT1, as the patient exercises, the QTc increases with increased heart rates and remains prolonged throughout the recovery period. In patients with long QT2, including concealed long QT2, the QTc interval will shorten with exercise just as in controls, but prolongs in the recovery period when the heart rate is intermediately high. And this is shown in a graphical manner, and the best time for diagnosing a prolonged QT interval is in 5 to 7 minutes of recovery. And here you can see that both in patients with long QT1 and long QT2, the QT interval is prolonged compared to the controls. Here's another simple bedside test. This is the stand-up QT test. And you can see in the upper panel, in the control patient, after being supine for 10 minutes, when the patient is asked to stand up, the RR interval shortens, but the QT interval also shortens as the heart rate increases. However, as seen in the bottom panel, in a patient with long QT syndrome, when that patient stands up, the RR interval shortens as the heart rate increases, but the QT interval does not shorten. So this is called QT stretching with an upright position. We don't perform the intravenous epinephrine infusion test because there's really no more to gain than the exercise and the stand-up test. But if you had a patient who had a cardiac arrest and was not able to exercise or stand up, this could be another test that can be performed. It's diagnostic of long QT syndrome type 1, where there is a paradoxical increase in the QT interval with intravenous epinephrine infusion. Let's move on now to genetic testing. Why should we perform genetic testing? Genetic testing is useful for reaching a diagnosis of long QT syndrome in up to 70% of patients. It's also helpful in screening family members and providing gene-specific treatment and risk stratification. 3 caveats about genetic testing. 1, that long QT syndrome genes have variable expressivity, so family members with identical mutations have different disease severity. There is incomplete penetrance, so gene carriers may be asymptomatic and have completely normal QT intervals. And finally, beware of variants of unknown significance, which only serve to muddy the waters. We'll now talk a little bit about genotype-phenotype correlations. Genotype-specific ECG characteristics have been described with long QT1, in which typically the ECG shows broad-based T waves. In long QT2, where the T waves, as shown here, are either notched, bifid, or flat. And in long QT3, where there are late peaking T waves, but the T wave itself is quite normal. Now remember that these are simple correlations and are not diagnostic of specific types of long QT syndrome, and patients often have other types of T wave repolarization abnormalities. As far as genotype-specific triggers for long QT syndrome cardiac events are concerned, in long QT type 1, events are usually triggered with exercise and emotion. In long QT2, cardiac events are usually triggered by emotion and auditory stimuli, and in long QT3 patients, cardiac events occur at rest. Now let's look at genotype-specific probability of a cardiac event. The probability of cardiac event is much higher from birth to the age of 40 in patients with long QT1 and long QT2 compared to long QT3, but the lethality of a cardiac event is highest in long QT3. The mean age for the first cardiac event in long QT syndrome is in the teenage years. And as you can see, this is truly a disease of childhood, where the average age of long QT events in long QT1 is only 13 years and 18 years in long QT2, and again, in the later part of the teenage years in long QT3. Note that the peak incidence of cardiac events is from birth through adolescence for long QT1 and 2, and cardiac events occur later in life in long QT3. In all 3 genotypes, males are at risk primarily through age 15, after which females have a persistent risk in long QT1 and long QT2. So the point here is that males are at highest risk during adolescence, and their risk then diminishes, but females remain at persistent risk throughout their lifetime. So let's talk a little bit about long QT syndrome risk stratification. Now, we know that some patients are symptomatic, some patients have normal EKGs. So who is at risk for having a cardiac event? And we can now perform long QT syndrome risk stratification by phenotype-guided methods, genotype-guided methods, and a combination of both. So talking about phenotype methods, the ECG is the best and the most powerful phenotype for a patient with long QT syndrome. The probabilistic risk of developing malignant arrhythmias in patients with long QT syndrome is highest when the QTc interval exceeds 500 milliseconds. Another marker on the EKG is the presence of T-wave alternans. And as you can see in this patient who has both a QTc greater than 500 milliseconds as well as T-wave alternans, there is a very high risk of Torsades de Pointes. The risk is also modulated by external factors and internal factors, such as fever, hyperthermia, the autonomic nervous system, hormones, and drugs. The risk is also modified by age and the stage of life, so that the highest risk is actually in the fetus and in the neonate. And in males, as we said, it's in the adolescent periods, and in the female, it's in the postpartum period. Now let's look at genetic testing and see how this can help us with risk stratification. So genetic testing is just not a matter of being positive or negative, but the risk also depends on mutation location, the biophysical characteristics of the mutation, the number of mutations, and the specific types of mutation. And this is all provided to you in your commercial genetic testing report. So when you look at the mutation location, as you can see here in long QT1 and long QT2, the transmembrane part of the channel is the most important. And within the transmembrane channel, if the mutation location is either within the C connecting loop or in the pore of the channel, these patients are at high risk. So in patients with long QT syndrome type 1, if the mutation location, and again, if you read your genetic testing report, this should be available in the report. If the mutation is located in the C loops, as shown here, of the transmembrane part of the channel, this is high risk. And in long QT type 2, if the mutation is located in the pore of the channel, this is also high risk. Now, we want to quickly talk about a few high-risk long QT syndrome subtypes which bear special attention. These are patients who are not even born, the fetus. This is probably the highest risk for long QT syndrome, and this can be manifested as either intrauterine 2-to-1 AV block or intrauterine Torsades de Pointes. In this example of a fetus with Torsades de Pointes, the mother was actually treated with intravenous lidocaine and magnesium sulfate, and this was successful in terminating intrauterine Torsades de Pointes. This is another patient. This is a neonate who was born with bradycardia, and as you can see, during sinus rhythm, the QT interval is over 900 milliseconds, and the patient has 2-to-1 AV block with frequent episodes of Torsades de Pointes. This patient was treated acutely with esmolol, lidocaine, magnesium sulfate, and isoproterenol. And finally, a temporary bedside ventricular pacemaker was implanted. And as we paced the patient, the QT interval actually shortened, and the Torsades de Pointes interrupted. This is the same patient. This is his EKG when he was born. The patient was actually born in Torsades. So our house staff lovingly call this patient, whose that name is really Samad. His name is now Torsades Samad. When genetic testing was obtained on this patient, we found out that this patient actually had a double hit genetic mutation, so that he inherited long QT1 from the father and long QT2 from the mother, and unfortunately now is the carrier of both long QT1 and long QT2. Another high-risk form of long QT syndrome is Jervell-Lange-Nielsen syndrome. This is associated with congenital sensory neural deafness and extreme prolongation of the long QT syndrome. Remember, this syndrome is caused by inheriting 2 copies of variants in the KCNE1 or KCNQ1 genes, and typically the patients are at very high risk for sudden cardiac death. The reason they are also deaf is that the IKS channel, the potassium channel, is also expressed in the inner ear. So just as it is dysfunctional in the heart, it is also dysfunctional in the inner ear. Another high-risk form is The Timothy syndrome, which is long QT syndrome type 8, this is a gain of function calcium channel mutation. The calcium channel is ubiquitous in the body. So not only does it affect the heart, but it also affects the patient's intellect, the patient's facial features, and is associated with syndactyly. Typical triggers for arrhythmias in Timothy syndrome are hypoglycemia and cardiac anesthetics. And the mortality, if untreated and unrecognized, is over 50% in the first 3 years of life. This is one of our patients who was having syndactyly surgery. The cardiac anesthesiologist was unaware of the diagnosis and gave the patient sevoflurane. And you can see that as the patient is emerging from anesthesia, you can see the T-wave alternance pattern, which is really a harbinger for torsade de pointe. This patient ultimately had an ICD implanted, and you can see that this ICD is implanted in the abdomen because of the patient's age, and the ICD coil is placed in the pericardium. Subsequently, the patient has had several appropriate shocks. So if we put genotype and phenotype together, who is at highest risk? Well, the highest risk patients are these patients with Timothy syndrome, Jervell-Lange-Nielsen syndrome, Anderson-Tawil syndrome, and patients who are in the neonatal and fetal period. Another high-risk category are all patients who have a QTC greater than 500 milliseconds, particularly with long QT1 and long QT2, and long QT3 patients who are males. So let me just bring this to your attention. If a female with long QT3 had a QTC greater than 500 milliseconds, the female is actually in an intermediate risk, but the male is in the high risk. However, when you look at the female with long QT2 who has a QTC greater than 500 milliseconds, that female continues to be in this intermediate risk category compared to the male counterpart. And then finally, the lowest risk patients are those with QTCs greater than 500 milliseconds and males after the adolescent period. And this applies to both males with long QT1 and long QT2. Now we're going to spend the next 5 minutes talking about long QT syndrome treatment. Beta blockers, uninterrupted use of beta blockers is the primary treatment for long QT syndrome. And beta blockers are effective by decreasing the adrenergic drive, reducing the peak heart rate, shortening the QT interval in some cases, and decreasing the dispersion of repolarization. There's a genotype-specific effect such that patients with long QT syndrome type 1 exquisitely respond to treatment with long QT with beta blockers, and less so with long QT type 2 and long QT type 3. All beta blockers are not equal, and it's important to note that the most effective treatment or the most effective type of beta blockers is either propranolol or nadolol and not metoprolol. In long QT1, while beta blockers are effective, even metoprolol sometimes can be effective, though it is not recommended in long QT type 2. Only nadolol is effective. So we do not recommend using metoprolol in any type of long QT syndrome, only use nadolol and propranolol. But what if a beta blocker is not enough? Let's talk about gene-specific treatments. In long QT type 3, sodium channel blockers are effective. Just one caveat, propranolol also has sodium channel blocking effect. So if you're going to choose a beta blocker for long QT type 3, then propranolol would be a good choice. Mixelotine has been shown not only to reduce the QTC interval in patients with long QT type 3, but also the risk of arrhythmias. And similarly, other sodium channel blockers such as flecainide and ranolazine have been shown to be effective in long QT type 3. This is a 12-month-old with long QT type 3 and 2-to-1 AV block. You can see the QTC interval is 560 milliseconds. After good response with intravenous lidocaine as a short-term challenge, we started this patient with oral mixelotine. The QTC decreased to 470 milliseconds. And you can see that now there is 1-to-1 AV conduction, and this patient did not need a pacemaker. Similarly, atrial pacing. So remember, at faster rates, the sodium channel does not remain open. So atrial pacing at faster rates can also improve the QT interval without sympathetic stimulation. This is using sodium channel blockers is now a class 2A recommendation in the treatment of long QT syndrome type 3. Another medication that can be used, which is long forgotten, is the old sodium channel blocker phenytoin. This has been shown not only to improve sodium channel function, but it also has a calcium channel blocking effect. Interestingly, mixelatine also has been shown to be effective in long QT syndrome type 2, as it also affects potassium channel, the sensory voltage function of the potassium channel. Now, in long QT type 2, there are studies that have shown that by supplementing the patient with potassium so that the serum potassium level is greater than 1.5 milliequivalents, either with potassium supplementation or spironolactone, has been shown to improve the QT interval and also improve the risk of arrhythmias. In patients with and in women with long QT syndrome type 2, remember the highest risk is with menopause and with the postpartum period. Progesterone has protective effects against long QT associated arrhythmias, and so we should try and avoid estrogen especially with oral contraception in these women. So progesterone is good, estrogen is bad. Finally, long QT syndrome diagnosis is not equivalent to getting a pacemaker. Even in secondary prevention, we actually try and use another method, which is left cardiac sympathetic denervation, to provide protection against sudden cardiac death. And this involves surgical ablation or surgical interruption of the lower two-thirds of the stellate ganglion and the thoracic ganglia from T2 to T4. This is a neonate born with incessant torsade. We had to actually place this patient on ECMO for cardiopulmonary support. And finally, after performing a sympathectomy, and it's important to really send the sympathectomy specimen to your pathologist so you can confirm that all the ganglia are appropriately removed. And this patient now, 9 months later, no ventricular arrhythmias, continued to have 2-to-1 AV blocks, so got a pacemaker, but no defibrillator, and the sympathectomy was life-saving. And I'm just going to end with some lifestyle management recommendations. We know what the genotype-specific triggers are. The most problematic is sleep. We can't have our patients not sleep. We also can't have our patients not exercise. So current recommendations for athletic participation for patients with long QT syndrome is that as long as patients are adequately treated and there is a safety net in form of an AED that is available at the site, patients are allowed to participate in sports. As far as sleeping, at least in the United States, we're able to provide families with certain monitoring devices which will alert the patient in case of an arrhythmia. All patients are expected to have their own personal AEDs. And finally, this is a checklist we provide to our patients: avoid QT prolonging medications. Here's the website where they can find the list. Maintain electrolyte balance and hydration, compliance with beta blockers, personal AED as part of their personal equipment, and an emergency plan is set up for the school to take care of any problems. So finally, high-risk patients with long QT syndrome, no ICD, beta blockers, personal AED. We often will implant a link monitor for arrhythmia monitoring, avoid excessive adrenaline-inducing activities, and consider a sympathectomy. Thank you very much.
Thank you, Madam, for that excellent deliberation and actually the round approach for all the long QT syndromes. So I will ask, actually it's an international faculty talk, so we'll take the questions now only. So maybe Dr. Somu, can you, do you have any comments on that? Some questions?
It's an excellent talk, and I think the most important take-home message would be to have beta blockade as the first line therapy in long QT1, try to genotype and maybe then give therapy directed with the type of long QT, and not be in a hurry to do an interventional procedure unless it is required.
Okay, so I actually one question I have. Sometimes this long QT is a transient phenomena. We can see in some ECG showing and some ECGs not showing, something like that. So do you recommend some long-term monitoring to see the phenotype in suspected patients of long QT syndrome?
So, Dr. Majmudar, that's actually an excellent question. So just from a risk stratification standpoint, patients who have a persistent QTC prolongation that's greater than 500 milliseconds, so persistent is definitely more important than intermittent. And in any patient where we typically don't put in intracardiac monitoring like the Link monitor just for the diagnosis of long QT syndrome where the QTC is intermittent. But any patient who is symptomatic with this kind of intermittent QTC prolongation, in our experience, the Link monitor is extremely helpful. I'm not sure about the expenses in India, but for us, all our patients with channelopathies who are at risk for sudden cardiac death, we have a very low threshold for implanting a Link monitor.
One more question. See, for example, all these patients who have this maybe drug-induced Torsades or electrolyte-induced Torsades. So do you suspect or do you look for long QT in these patients, or just think that that is due to drug and forget after correcting it?
No, I think that's where genetic testing is extremely important. So there is an entity, just for the audience, which is drug-acquired long QT syndrome. And typically, those mutations are not specific long QT syndrome mutations. They have different kind of channel mutations, and it's usually the KCNH2 channel. So if any patient who has drug-induced Torsades, I strongly recommend getting genetic testing and also doing all the provocative testing for long QT syndrome. So if their baseline EKG is normal, at the minimum, that patient should have an exercise stress test. The one thing, in addition to what Shomu said about treatment, exercise stress testing is extremely important in the diagnosis of long QT syndrome. All these intermittent long QT intervals that you find on the ECG, if when you exercise the patient and in the recovery period, if the QTC is persistently high, even if it is normal at baseline or during exercise, that patient has over an 85 to 90% positive predictive value for having a true long QT syndrome.
Okay, I have a question.
Any other? Yeah.
One question. Thank you very much for the very interesting and exciting lecture. Ranolazine, it is known to produce QT interval prolongation, but you mentioned it is also a treatment for a type of QT.
Correct. So it's only with long QT type 3. Sir, you bring up an excellent standpoint, and that's why genotyping is so important. So you don't want to give ranolazine to anyone with long QT syndrome. You only want to give it to patients who have long QT type 3.
Thank
you. So
you.
it is only for sodium channel mutations.
I have a question.
Any other questions?
Yeah. So, ma'am, when do you consider ICD? Is question number one. And when you consider ICD for the smaller kids, what is the approach, epicardial, and how do you go with it?
Great. So I think our mindset in the 21st century is do not consider ICD. And ICD, not only is it expensive, but in long QT syndrome, which is driven by adrenaline, these patients have a very high incidence of inappropriate shocks because of sinus tachycardia, as well as sometimes the QT interval is so long that there is oversensing from the ICD, and the problem of inappropriate shocks, which increases your catecholamines and is then proarrhythmic, is very significant. So the only patient I consider an ICD in is an older patient, so a teenager who's had a cardiac arrest. In these younger infants, as I showed you, we can put an ICD, and I'll speak to that a little bit. But I think doing a sympathectomy is your best approach because the infants and toddlers are not physically active. So they might have had one cardiac arrest, and if you treat them with beta blockers and do a sympathectomy, I think it's a much better approach than taking the risk of putting in an ICD. However, if you have to put in an ICD in an infant, right now our current approach is the following: that the surgeon performs a sternotomy. They put on bipolar pace sense epicardial leads just like you would for any ventricular pacemaker. And then we take the SVC coil. If all of you recall that in the old days, or even in the current time, before the dual coil ICD, the manufacturers had a separate SVC coil, which only has a 5-centimeter coil to it. So you take that coil, and we have the surgeon put it in the pericardium, posterior in the heart, but you must not suture onto the myocardium. You have to tell your surgeon to suture the coil to the pericardium. So we don't have any scarring on the myocardium. And then you connect the coil to the defibrillation port of your ICD. And so typically you're going to need basically a dual coil ICD configuration, and you put the coil into the SVC coil portion, and then the pacing portion goes where the pacing portion is. But that is probably the best way to put in an ICD. In the old days, people would put epicardial patches. That's absolutely contraindicated in young patients because it will create a restrictive physiology in the myocardium. So just use a simple SVC coil in the pericardium and pace sense leads on the epicardium. I hope I answered your question.
Yeah.
So if there are any other questions, otherwise we'll move on to the next talk. Thank you, madam, for that excellent
Thank you,
lecture.
Dr. Majmudar. Thank you very much. This was a great honor to be able to speak today. Thank you, everyone.
Thank you very much, madam. Thank you. Yeah. So next we invite Dr. Sanjeev Mukherjee to give his talk. Hello, Dr. Sanjeev Mukherjee is here. Yeah. Okay. So resuscitated sudden cardiac arrest in a young player, how to evaluate. That is also a continuation of the earlier talk, I think.
Absolutely, yeah. So, thank you, Dr. Suchit. In the next 12 minutes, I'm going to talk on this topic, resuscitated sudden cardiac arrest in a young player, how to evaluate. Now, this is actually a clinical question that has been put, and so we need to understand each and every part of this statement. First is, how do you define a player or an athlete? So a player or an athlete is an individual who on a daily basis keeps preparing for an event. You know, he goes, exercises on a daily basis, and his target is to achieve laurels and achievements. You know, so that is how you define an athlete who is meant to win awards. So that is the level of training that he undergoes. Young, by definition, is an individual between 12 to 35 years. And a resuscitated sudden cardiac arrest in this scenario means that the arrest happened while during playing or within 1 hour of sports-related activity. So we're looking at an individual who is between 12 to 35, had a cardiac arrest and was resuscitated and has now come to us for an evaluation. So is this condition new? The answer to that would be an absolutely no, because there is historical perspective. You know, Phidippides in 490 BC, he's basically a runner, ran from Marathon to Athens about 40 kilometers to give the news that they have won over the Persians. And the moment he delivered the news, he dropped dead. So there is definite historical perspective of sudden cardiac arrest, which has been there in literature. And these are some of the recent examples that we have from Hanganthers. I know these are all from US. The top two are basketball league players. Flo Hyman, very interesting. This lady used to play volleyball, has won Olympic medals. And during one of her league, club matches, she had sitting on the side after playing and had a sudden arrest, and was found to have marfanoid features. She died of a ruptured aorta. Sergei Grinkov, again a basketball player, had single coronary artery, so coronary anomaly. Pete Maravich was an ice skate player, and he died of a premature coronary event. So there are multiple etiologies which can cause sudden cardiac arrest in these young patients. And for my friends, cardiology friends, we must also understand that there is a legal angle. The top two players, actually, their cardiologist who saw them had to go for an extra, court, out of court settlement. So we should be very, very cautious when we look to such an individual, because any death, they create a flutter in the society and also has got a lot of emotional attachment. So we should be very cautious while we evaluate these patients. Now, going forward, there are certain games or sports which are more likely to cause sudden cardiac arrest. Like basketball and football is more likely to cause compared to maybe swimming or a golf or a baseball. So those games also are one of the things that we must remember. And this was a paper from Dr. Barry Maron in 2007, SERB. And in his subset of patients in this age group, when he evaluated, he found that hypertrophic cardiomyopathy was there in about 43% of cases, followed by coronary anomalies, and then some percentage of myocarditis and ARVC. Whereas papers from Italy showed slightly different. They had more of ARVC and coronary anomalies compared to what Dr. Maron's paper saw. So it may differ from place to place, but grossly, these are some of the conditions that should be there in the back of our mind when we evaluate a young individual, a 12 to 35-year-old age group who has suffered a cardiac arrest. And to simplify, I think this is what would make our job easy. Remembering the causes based on structural anomaly like HCM, ARVD, coronary anomaly, Marfan, mitral valve prolapse, aortic stenosis, or atherosclerotic CAD. Electrical, we can talk about WPW, congenital long QT, Brugada, and CPVT. And in acquired, we have got myocarditis, commotio cordis, and of course, illicit drugs, which is common in sports. So based on these etiologies, I think we should be frame our questions and frame our investigations in the patient who has come to us. Now, in this individual, if you look at, as the images are very clear, if your echo shows an asymmetrical septal hypertrophy with and without outflow obstruction, 90% of these patients of HCM, can have ECG changes like deep T-wave inversions, as can be seen here. So if the things are not fitting borderline, then you can look at high-risk features. If there is unheralded syncope, family history of sudden cardiac arrest, a severe LVH more than 30 millimeters, or an attenuated BP response, or a sustained or a non-sustained VT on an exercise, on a halter. So any one of that, if you get, then also, the case is much stronger for an ICD. So HCM must be ruled out. We must have our echo ECG. We must have particular focus to look at HCM. Coronary anomaly, difficult to screen, but if history-wise, if a patient gives history of exertional angina or exertional syncope, and we do not have other reasons, then we must think about coronary anomalies. And the one which is common in this age group would be a left coronary coming from a right sinus, or a right coronary coming from a left sinus. And the reason that they have a cardiac arrest is, as you can see in the image down, that the artery traverses between aorta and PA. And during exercise, when the aorta dilates, it compresses the coronary over the pulmonary bay, can cause relative ischemia and ventricular arrhythmias. Sometimes, because of this abnormal origin, the takeoff angle is very high, and as aorta dilates, the output becomes slit-like and can cause relative ischemia followed by a ventricular arrhythmia. So a CT coronary angiogram is diagnostic, and surgical treatment is a treatment of choice. ARVD, again, very, very important. We must keep in our mind, as you can look on this image on the right side, the ventricle, the right RV looks dilated. The wall is replaced gradually by fibrofatty tissue. They have focal myocarditis followed by replacement with fibrofatty tissue, which becomes a place for a reentrant ventricular arrhythmias. And they usually have desmosomal protein-related problems. And in ECG, you can have some slurring at the end of R wave, which is called an epsilon wave. So if any of these high-risk features are there, suppose he has got a resuscitated arrest, and top of it, anything you get, then probably you're looking at an ARVD. And again, ICD is definitely a choice that you will offer. As far as long QT is concerned, a lot has been discussed about it. I will not be going into detail, but again, long QT1 is something that can happen with exercise, and we should think about it. If a resting ECG shows a QTC more than 500, we are definitely strongly thinking about long QT syndrome. Brugada, somebody who has got ST coving in lead V1, past history of resuscitated arrest, and if type 1 Brugada pattern is seen as evident on this ECG, then obviously it is a Brugada syndrome as an etiology, and we must be looking at an ICD. Always remember that while you do an ECG in long QT, make sure to do an ECG in supine and standing, as it can bring out covert long QT. And as far as Brugada is concerned, while taking an ECG, we can take leads one space higher, and sometimes that can actually expose a Brugada syndrome. Commotio cordis is purely a traumatic event, and this happens mainly in sports where there is either a collision like soccer, or there is a projectile like a baseball which comes and hits on the chest. Commonly seen in young individuals like adolescents or a young boy, where the chest is very, very compliant. And the injury or the trauma must happen in a particular phase of the cardiac cycle. It is usually in that 20 milliseconds of the ascending limb of T wave. If there is a trauma which gets transmitted to the ventricular wall, it can cause, it can interfere with repolarization and giving rise to a VFib and a cardiac arrest. And a defibrillation is most of the time life-saving, and trauma is the only etiology here. Myocarditis also is a very, very strong suspicion that we must have. Any athlete, if he complains of exercise intolerance, there are features of heart failure, or in the background history of a fever, we must think myocarditis. So history is important. Once history is there, we must go ahead with ECG, echo, lab parameters, and serology. And many a times we should be able to get the diagnosis if there's an LV dysfunction. Sometimes cardiac MR and PET CT might be helpful. Commonest organisms are Coxsackie, parvo, and human herpes virus 6. And if myocarditis is the etiology, then he should be off competitive sports for the next 6 months. Atherosclerotic coronary artery disease was not very high in the paper that Dr. Barry Maron had, but I think we should be very, very cautious in our country at least, because we know that Asians tend to have coronary artery disease a decade earlier. So any feature of hyperlipidemia like xanthelasma, xanthomas, or a corneal arcus, that should raise a red flag, and we must evaluate for coronary artery disease. And if ECG doesn't show changes, then and there is evidence, there is history of effort angina or exertional dyspnea, then I think a CT coronary angiogram is warranted to uncover the reason of sudden cardiac arrest. Drugs and performance, we all know Ben Johnson, Armstrong, Maria Sharapova, all are high-end athletes who all got involved into drug enhancing substances, performing enhancing substances. So this history should be there, because many of these drugs can cause QTc prolongation and ventricular arrhythmias, and many can also cause coronary artery disease. So the list of investigation that I'll have is ECG, as I said, standing, supine, one space higher to look for long QT and Brugada, an echocardiogram to look for LV function and the RV saculations or RV dysfunction, do a treadmill to uncover things like multifocal PVCs or a bidirectional VT for a CPVT, cardiac MR and PET scan for inflammatory cardiomyopathies and coronary angiogram in some cases. Genetic workup is slightly needs consideration in very special cases, as we had just discussed in lot. So finally, this will be my ending slide. And this slide comes from Veneto region of Italy. And if you look at this slide, very interesting. I think in our country also, we should be following this. If we look at the deaths in patients who were in athletes, it was much higher in 1979. And what they started was pre-screening. And see, the pre-screening has brought down the death in athletes. From the screen athletes, the deaths are much lesser compared to unscreened non-athletes. This is from 79 to 2004. And I think this is something that we all should try to practice to save many of these young lives. Thank you.
Thank you, Dr. Sanjeev Mukherjee. I would ask Dr. Debabrata Bera to continue the discussion now.
So,
hello.
Any questions? Any questions from the audience? I cannot see here in the chat box anything. Dr. Shomu is there. Molly Madam is also still there. Thank you for taking.
I have a question. I can actually start. That was an excellent talk. Really enjoyed it. My question is really about the Indian context. Do you think parents and schools and teams are actually aware of the concept of sudden cardiac death in the athlete? Do people actually worry about this as they, I mean, in the US, it's almost the other extreme where every athlete is getting an EKG for no good reason. But I'm just wondering what the awareness in the Indian context is.
Yeah, so that's a great question. See, thing is, even when I was, presenting data, data is predominantly Western because we still do not have clear data from our country. So I think awareness is something that is, I think, is still low, and probably we need to raise awareness to a higher level. So my answer would be no. I think it's clearly no.
And how about the I'm sorry, I just have a lot of questions because this is a topic that's dear to my heart.
Right.
So we have been able to allow a lot of our high elite athletes, as you described, even though they have cardiovascular conditions, we have been able to permit them to participate because we're able to create a safety net where an external defibrillator is right on the field, and the coach and the trainers are required to be CPR trained. Is that something that would ever be possible? What about AEDs?
Yeah. So going specifically, I think the big league matches that we have, with the big stadium, big league, they usually collaborate with one of the hospitals, corporate hospitals or hospitals who get into the sports area with their AEDs and required medications. But if you ask me on events which are happening on a lower scale, those places we do not have, still don't have those facilities. And I think we still lack awareness on this front, and we need more work to be done, I think. That's.
Thank you. Thank you very much.
Yeah, I will. I'll just ask one question to Sanjeev.
Yeah, sure, please.
Yeah, the differentiation between a vasovagal syncope and sudden cardiac death by a bystander is very difficult. So it sometimes you post exercise and after half an hour a person drops down, whether it's vasovagal syncope or was it a cardiac arrest is difficult to differentiate. And what are the pertinent points that we should keep in mind to differentiate the two is an important thing that we should discuss.
True. So thing is, if somebody is brought to me with this kind of a background, an elite athlete, a player, who has dropped suddenly and something has been done and he was saved, I think I would still go ahead with the entire battery of investigations because, as I said, there is a definite legal angle to it. And if this athlete has an event tomorrow, then as a cardiologist, both socially, ethically, we will be at question. So I think I'll go with the entire battery of investigations, which will include an ECG, as I said, both supine, standing, a treadmill probably, and of course an echo and standard investigations. But I think your point is definitely correct. But in a vasovagal, I'm not looking at, it's not going to be life-threatening, but I think somebody who has got an event, and I'm not clear about, obviously the history will be the cornerstone, but if there is any doubt, I will be more cautious on the side of investigating than on the side of allowing him to go back to his sports activities. That will be my take.
So just an extension to maybe even Molly, that if you find somebody who has nothing on ECG or investigation, and you have such a history and you're not able to conclude, what would you advise to the patient then?
Right. So this is an excellent discussion. So just one extra point. When syncope occurs after exercise, I think it is going to be extremely difficult to say whether this is vasovagal or arrhythmogenic syncope. However, vasovagal syncope almost never occurs mid-stride. So if an athlete tells me that I was running, so usually vasovagal post-exercise, you have vasodilation and you can pass out. Mid-stride, if a soccer player is running, has no prodrome, and drops, even if he wakes up, to me, historically, that is very suggestive of an arrhythmogenic syncope. And even if I agree with you, Sanjeev, I would do everything that you said. We have the luxury in these cases of not implanting an ICD because I can then, if I find nothing, I would let the family, I would involve them. It's a shared decision-making process that your child or your brother had a worrisome event. If you want to go back and play, you can, with the caveat that you have an AED on site. So I feel that we are more permissive in athletics because we are able to provide an adequate safety net. So I wouldn't empirically treat that patient with a beta blocker. I might implant a loop monitor, because if there was going to be another event, I would rather know what the rhythm is during another event. So I would definitely implant a loop monitor if that athlete was going back into play.
Do you want to consider ICD if we don't find anything in these cases?
I don't.
If you don't know the rhythm.
If I don't know the rhythm, if there's absolutely nothing on all the extensive investigations that Sanjeev described, I don't implant an ICD. I would implant a link monitor for sure.
And Dr. Sukumar Ghosh wants to ask something.
I want to say we sometimes see the early repolarization. Sometimes we see as a normal variant. How would you take up the issue? Sometimes we see in black young males it is a normal variant. So we consider how much investigation or look into the issue.
Should I answer that question?
Yeah, I think Shomo is discussing.
Yeah. So, see, as I discussed, if you have the early repolarization, especially during bradycardia, and if it is just limited to the lateral leads, say V5 and V4, without involvement of the inferior leads, and the ST elevation is not more than 2 millimeters, which is actually going upsloping, then it may be normal. However, this can vary according to time. It can vary according to the sleep patterns also. So it depends on a lot of factors. And if the clinical scenario suggests arrhythmia, then you have to go further and investigate. That's very important. But based on ECG, the high-risk features would be involvement of inferior, elevation of more than 2 millimeters on, and persistent this J-point elevation, which is downsloping even after 80 milliseconds of the J-point. Adding on that, if there is ST elevation which persists during exercise or at a higher rate, then again, it may be a risk factor.
Any role of genetic testing So how we go about genetic testing in this sort of patient, sports patient, sportsman who has fainted and has a cardiac arrest. We don't know anything about the other things. How can we do a genetic testing? Because it is often a cascade testing. I think we should not.
I think the problem with genetic testing is you're opening up a hornet's nest, as we say, because if you have no story, if you have only the story with no associated findings, and then you do genetic testing and you get a variant of unknown significance, it's absolutely a nightmare. So I feel that if there's only a story and no other phenotypic features, no family history, I really think implanting a link monitor and, if possible, creating a safety net if the athlete was going to go back and play sports without genetic testing is the way to go.
Thank you.
Any comment from Dr. Rakesh or Dr. Bhaduri? Yeah, so I have a couple of questions. One for Madam. So in adults like SCAR, VT, VT Storm, when we do sympatherectomy, we do bilateral sympatherectomy. But for long QT syndrome, is it that the only left-sided sympatherectomy is enough, or you do bilateral, ma'am?
I would start with left because really the whole hypothesis is really an imbalance between the left and the right. So I would always start with left. If the left doesn't work, then you go to the right. And now it's a simple enough procedure that the recovery after a sympathectomy is so quickly that you don't have to feel that you have to do both at the same time. So in children and even in adults with long QT syndrome, I would always start with left and then do the right only if needed. Because the left is extremely effective, I would say, in over 90% of the cases. It's like that last 10% that require the bilateral sympathectomies.
Any harm, ma'am, doing both sides simultaneously?
No, actually, the harm doing one side is more like a cosmetic harm, especially for young patients, because when you do only one side, some people will develop what's called this Harlequin syndrome. And so like for a teenager, they sweat only on one side. They become they have like this discoloration or a redness on one side because you are disrupting the sympathetic input only on that side. So the harm, I think, there isn't a clear harm doing bilateral sympathectomies, but I think your risk for things like Horner syndrome, which could be irreversible, will increase with bilateral sympathectomies.
And one question for Dr. Shomu. Thanks for your wonderful talk, sir. Just for the sake of audiences, can you summarize, let's say we have many patients with post-MI and they ask for a primary prevention ICD. So what are the key features you will look for before putting a primary prevention ICD in a patient in post-MI setting?
So the first thing that I would look in is the echo, and the echo ejection fraction should be less than 30% in asymptomatic patient and even less than 35% in a symptomatic patient. Second thing is whether the revascularization has been completed or not. If the revascularization is not completed, then we need to revascularize first and then go ahead further and wait for at least 3 months after revascularization. So full revascularization if possible, wait for 3 months and then we see the ejection fraction and then decide whether to do. And then if the patient still has, now on echo, if you have a scar which you think that cannot be reversed back, or if there is an extensive aneurysm or dyskinesia, definitely you may not wait for these 3 months if there are high-risk features. Like the first high-risk features would be history of syncope, on ECG, presence of a wider QRS, especially bundle branch blocks, or notching between the QRS, which suggests that there is a conduction delay occurring, presence of a scar and possibility of a VT. And third thing is presence of NSVTs on Holter. Now people have used functional class 3 and 4 as such to risk stratify, but before that, definitely the ECG features, which includes VPCs as well as broad QRS, which are at high risk.
Thank you, sir.
So I think we can, if there is no other question, we can end the session here. Dr. Debabrata?
Yeah, thank you so much, madam, for taking out your valuable time. And
I enjoyed it. This was a great discussion. Thank you so much. Appreciate the invitation. Bye-bye.
Thank you so much. Bye-bye. Good night.
So tomorrow, I think the session will start at 1 o'clock with the preventive cardiology session. So till then, have a good night, everyone, and a good weekend. Thank you.
Thank you.
Thank you, everyone.
Good night, Baduri sir.
Thank you.